non-dialyzed, it might have a short half-life in the water, so probably it is not detected in the dialysis appropriately when we need to check it. It is 60% plasma protein binding, hence making dialysis timing administration probably not really important, as long as we are giving them early before dialysis or way after. Some institutions completely avoid the dialysis on the days of melphalan. Moving to our second agent is cyclophosphamide. It causes nephrotoxicity by itself, tubulopathy, enhancing release the antidiuretic hormones, causing SIADA, which might lead to a picture of pre-acute kidney injury. It has a long metabolic chain. Their active metabolites, such as acrolein, could cause urotoxicity. The other thing, it is predominantly excreted unchanged in urine. Hence, renal dysfunction will increase the systemic exposure. So it has two possible nephrotoxic mechanisms of action. And the way to mitigate these side effects or these toxicities is by probably increasing hydration, which might be a little bit challenges for our elderly patient or patient who require fluid restriction at some point in their transplant. Frequent urine voiding and probably using Mesna might increase the excretion of cyclophosphamide. On the long run, increasing myocardial toxicity were observed in patients with chronic kidney disease. Moving forward again to the dosing, as you can see, again, it's a gray area, a lot of different dose recommendation. The FDA said basically just do no dosing adjustment and monitor for toxicity. HOPES actually looked at the effect of creatinine clearance and the area under the curve of cyclophosphamide, and it's found to be increased whenever renal function drops. In terms of dialysis, it is moderately dialyzed. For patients who are dialysis dependent, administering dosing after hemodialysis, providing to allow at least 12 hours before the next session, might consider Mesna in some scenarios. Our third agent is fludarabine. So fludarabine is renally excreted. It has an active metabolite, the 2-fluoro-ARA, which is clearly renally excreted. Creatinine is directly correlated with the excretion and clearance of this metabolite. In the normal scenario, it goes around 150 ml per minute. However, you can see with the drop in renal function, and for example, reaching to a severe renal function, it could go down to 50% of its normal clearance. Looking at the doses, again, we have a variation in dosing, depend on the institution and which recommendation we will follow. There are a few papers looked into individualizing or personalized dosing of fludarabine. I wouldn't go into that, but this is another approach in terms of dosing of fludarabine. Especially, it might be more relevant with cellular therapy when we are using it. Giving this gray zone, this is a nice abstract actually published recently in the ASBMT meeting early this year. They actually tried to look at the fludarabine dosing in patients with renal dysfunction and see their toxicity and see if there's any changes can happen. So they actually looked at patients with renal function less than 70. They gave them 20% dose reduction of fludarabine. What you can see in the blue table that there's almost comparative results in terms of toxicity, in terms of infections, as you can see in this abstract. So shifting gears toward renal dysfunction post-transplant. So the acute kidney injury post-transplant have been reported to be around the acute kidney injury and the severe acute kidney injury were around 55% and 8% respectively. And in a pooled estimated analysis of the estimated incidence of acute kidney injury requiring renal replacement therapy was around 7%. In another retrospective analysis, when they looked at the impact of chronic kidney disease on the renal transplant, they also looked at the factors that could cause to chronic kidney disease. It was found that age and the history of acute kidney injury early within the transplant, I mean, within 100 days almost after transplant, were associated with increase of development or increased risk of developing chronic kidney disease. So this is just a brief criteria to remind everyone about how we assess the renal function. We have 3 different groups. It's always good to keep it handy whenever we're assessing patient, as it could cause, or as it could happen gradually after the transplant without actually, if we didn't pay close attention to the baselines of it, it might slip. So why do patients get acute kidney injury post-transplant? Looking at this timeline, you can see that acute kidney injury could be defined as renal impairment in the first 100 days, and then after 100 days of renal impairment, then at that point, it could be considered as a chronic kidney disease. There might be several things that could happen. There's a lot of things that patients go through during this period. For example, the conditioning itself, on day 0, the donor stem cell infusion, then the engraftment around day 25, followed by acute GVHD and chronic GVHD, and there's a lot of treatment that we can use it at that point. So, and even if you looked at this slide where they looked at the type of transplant and the intensive conditioning and the risk of acute kidney injury, you will realize that the allogeneic myeloablative regimens are associated with higher risk of acute kidney injury. And with autologous, even with autologous myeloablative, it goes down to 50% of risk. If you can see on your right, there's a lot of, or they have plotted some factors that I would say that will increase or might correlate with these results. As you can see with allogeneic myeloablative, the risk of exposure of calcineurin inhibitor, development of SOS, development of chronic GVHD are higher. So this might take me to the second slide, which is the factors of renal impairment after transplant. So after transplant, there's a lot of things we put our patient on. I would like to call out in this slide the factors that are introduced to the patient after transplant, such as either complications such as GVHD, SOS, sepsis, TMA, or the nephrotoxic induced medications such as our immunosuppressions and anti-infective. And at some point, if patient developed a GVHD, there's also the GVHD medications. This is a brief picture just to show or illustrate. I wouldn't say the amount of damage that could happen from for kidneys during the management of patient post-transplant. However, I just would like to highlight that there are multiple mechanisms of nephrotoxicity with different causative factors that we will highlight momentarily in some of them. So before moving forward to that, what are the main reasons or how can we prevent the acute kidney injury for these patients? The key factor is to try to reduce the transplant complication as possible by choosing a proper conditioning regimen and source donor that matches the patients, administer appropriate doses of nephrotoxic agent and using less nephrotoxic agents as possible, given the fact that most of the reasons that patients develop acute kidney injury mainly directed from drug-induced nephrotoxicity. So going to some dosing pearls for post-transplant, starting with our immunosuppressant, the calcineurin inhibitor, tacrolimus and cyclosporin. It caused a direct nephrotoxicity, leading to vasoconstriction of the efferent and efferent renal arteriole, leading in the end to reduce the blood flow and causing a direct cell death of the kidneys. And then you have the TMA with that epithelial damage. It is commonly seen with tacrolimus with higher levels, more than 20. However, it can be spotted with lower doses or lower levels of tacrolimus. Tacrolimus thought to have less incidence than other calcineurin inhibitors such as cyclosporin. So strategy to mitigate that is considering probably calcineurin inhibitor-free regimen. There are a few papers looking at, for example, post-transplant cyclophosphamide, delaying the calcineurin inhibitor after the cyclophosphamide, using a T-cell depleted source. Other approach is close monitoring for these calcineurin inhibitor. The dose recommendation that's published for both medications in literature so far is listed in the system. It's probably been going by reducing the percentage of the dose with elevated creatine clearance as explained in this picture. So this is an interesting abstract, actually. When we said that tacrolimus have probably less incident than cyclosporin, we know both of them are in the same group. So they both bear the same, probably the toxicity of acute kidney injury. However, in solid organ transplant, there were some reports established that tacrolimus might have less effect on nephrotoxicity. And then there is this paper who looked at 31 patient hematological transplant patient who had renal impairment due to calcineurin inhibitor cyclosporin, defined as a serum creatinine more than 90. 70% of them received cyclosporin for GVHD prophylaxis. Looking at the factors for those patients that might increase renal impairment, 15 of them received MAC, 16 received reduced intensity conditioning. ATG was administered in around 28 patients, and 10 patients received 12 gray TBI. They were switched to tacrolimus targeting level of 5 to 15. And the results were kind of impressive. If you look at this result, the creatinine clearance dropped with using tacrolimus significantly. So moving forward to the methotrexate, it could cause crystal nephropathy, precipitation of parent drugs and metabolites within tubular lumens. Their oxygen-free radical production may lead to cellular death. The usual dose with methotrexate in transplant or for GVHD prophylaxis is usually small and given as a pulse doses, day 3, 6, and 11. Dosing mainly depend on several factors such as hepatic mucositis, fluid, third spacing on the day of methotrexate administration. However, in terms of renal impairment, also there are specific dosing mentioned based on the clinical trials as mentioned above. Moving forward to our treatment of GVHD, if patient by any means develop GVHD, we have here 3 of the common medications or the approved medication for GVHD. Again, as mentioned, or as you can see, for ruxolitinib, they're basically no major recommendations except reducing with a lower dose or try to avoid it. For ibrutinib, there are no dose adjustment for renal dysfunction or dialysis. For bilimucidil, no dose adjustment for renal dysfunction. So basically what we were going to do in here is just dose, monitor for toxicity, and adjust accordingly. Moving forward to the anti-infective, antibiotics have a big share for patients post-transplant, especially if they're nephritic, and we need to give it for febrile neutropenia management. I would not spend more time. I would not spend a lot of time on this slide, but just to embark on the fact that we need to monitor the levels and renal adjust these medication. Like moving to the most important thing is the big nuclear weapons that we actually send to our kidney post-transplant are the antivirals. So starting with acyclovir, it is excreted through tubular secretion and glomerular filtration. It is majorly excreted unchanged, insoluble in urine, may lead to crystal depletion and vascular injury, hence leading to interstitial hemorrhage, slowing the blood flow and reducing GFR. Doses mainly depend on the type of dose and frequency and route is used. Most commonly used, the normal dose in oral is 800 milligram oral BID and 5 milligram per kg Q12 hours IV. Some institutions still use the 200 milligram 250 milligram per meter square, which is equivalent to the 5 milligram per kg. The second medication is the big gun, which is the foscarnet. It is used in the treatment of CMV, especially in early phase. If we are afraid of engraftment failure, foscarnet lead to the reduction in GFR result in foscarnet crystal formation primarily within the glomeruli, leading to tubular toxicities and tubular nephritis, glomerulonephritis, and acute tubular necrosis, ATN. So the way to mitigate that again is increasing filtration rate with hydration that might improve and prevent these destruction. It is very important to mention the electrolyte imbalance. There is a paper looked at the electrolyte imbalance in patient post-transplant and foscarnet. It was found to be higher and more significant with patients with renal impairment with foscarnet. In terms of hemodialysis, it is extensively hemodialyzed, and these are the doses provided afterward. Moving forward to cidofovir, it can be used for CMV mutation, and some adenovirus infection can lead to necrosis of proximal renal tubule. Most clearance occur through a glomerular filtration, through the glomerular filtration. Probenecid is given to just mitigate the effect or uptake of the cidofovir, preventing the nephrotoxicity. So this is a nice slide arranged by Maggie Nelson, presented in the ASPMT, looking at the different dosing of cidofovir. We know in the package insert that it is contraindicated to be given with creatinine clearance less than 55 or serum creatinine more than 1.5 gram per deciliter. However, there are alternative doses recommended in here. I would like to call out in this slide the hemodialysis dosing. It was found that it removes 50% of cidofovir, so it can, in this point, administration dose 2 hours per dialysis without cidofovir, without probenecid, may be appropriate. Of course, in here, if there is no expectation for renal function to be recovered at this point.
1 minute.
Okay. Ganciclovir and valganciclovir, these one of the agents that we are mainly using, especially in our center, the valganciclovir upon discharge. They are not nephrotoxic. They have less nephrotoxic risk and more myelosuppressive effect. However, these are the medication that require dose adjustment based on the renal function. Concomitant administration with other nephrotoxic medication may lead to increase in nephrotoxicity. So frequent monitoring of renal function is really warranted to monitor the dose and if there is renal function, renal impairment at any point. These are the dosing as mentioned in here. Moving forward, last but not least, amphotericin. It alters the vascular smooth muscle function within the renal tubules, alters the permeability, and can lead to vasoconstriction and tubular transport defect. Our patients with high risk for renal impairment with amphotericin who have lower baseline of albumin level, longer duration of therapy, higher daily doses, concomitant nephrotoxic medication, elderly, obese, or using conventional forms of amphotericin. Renal recovery, luckily, can be recovered in third of the patient within 10 days of discontinuation of amphotericin. It comes with a warning also for electrolyte disturbance. It is highly bound to protein, highly protein bound, and renal clearance occur in around only 5%. So there is no major recommendation when it comes to dialysis. By that, to conclude, renal dysfunction and its severity pre-transplant are predictors for overall survival, non-relapse mortality, and probably the need for dialysis after transplant. Guidance for common chemotherapy dose adjustment differs among literature, as well as standardizing dosing approach among institutions. Finally, the complexity of post-transplant care medication mandate close renal function monitoring and potentially medication dose adjustment, which a pharmacist play an integral role in it. By that, I leave you with this beautiful sunrise view and wishing you a beautiful day. And to remember that always after this long journey, we can still have a bright day. Thank you so much.
Thank you so much, Dr. Abukhour, for the amazing presentation. And now we'll go for our second speaker, Dr. Bashair Al-Suhail. She is working as an infectious disease clinical pharmacist consultant at the King Fahd Hospital in the University of Al-Khobar, assistant professor of pharmacy practice department in the Al-Imam University. She is a board certified specialist in infectious disease. Welcome, Dr. Bashair.
Good morning, everyone. It's hard to follow after Dr. Abukhour. Mashallah, this is an amazing presentation. I really enjoyed it. So I think I have a lighter note. So we're going to talk about prophylaxis post-hematopoietic stem cell transplant. And I think over the days that over the last day, you've seen a lot of advances in allogenic hematopoietic stem cell transplant. And these advances come with its own consequences and complications of infections that needs to be addressed either in terms of prophylaxis or treatment. So I have nothing to disclose or any conflict of interest. When we're talking about infections in allogenic or even autologous transplant, we have to keep in mind that one of the major complications are infections. Mostly 20% of these patients will experience infection that is actually anticipated with viruses and bacterial infections and even fungi that we know about. And sometimes we are not expecting or we are not taking into consideration. The thing is that we don't have biomarkers or markers that gives us a cutoff point for each type of infection. However, we have studies that we can base on a lot of our recommendation. And despite doing that, we might face sometimes unsuccessful prophylaxis or reaching to serious and fatal infections. So risk factor for infection can come from disease status itself and can come also from patient risk factors. Type of transplant, the pre-transplant consideration as well is also considered the risk factor, whether the patient is on immunosuppressive, the conditioning regimen that he received, the presence of GVHD, and also the rate of neutrophil engraftment. All of these are considered risk factor for infections. However, it's not one size fits all. So each stage of transplant will have a different group of infection that the patient is at risk for. The pre-engraftment period, which is from day 0 to day 15 to 45, this is the first period of risk. And then we have the immediate post-engraftment period, which is from the engraftment to day 100, and then the late post-engraftment period from day 100 to a year after transplant. So if we want to start with the pre-engraftment period, there's a higher incidence of bacterial infection and certain fungal infections such as Candida. And this is expected because we are having manipulation in the oral and mucosal barriers. There is a lot of catheters, lines, peripheral, central that is used for the conditioning regimen. And all of this may lead to predisposing the patient to infection, in addition to the prolonged neutropenia and the risk of febrile neutropenia. When we move to the early post-engraftment, still the risk is there. Still there is a mucosal barrier interruption, and there might be an additional risk of having GVHD and the need of ongoing immunosuppression to treat this condition. So we still do have risk of bacterial infection. However, fungal infection extend to include also some types of Aspergillus and mold infections, CMV, varicella zoster virus as well. When we're moving to the post-engraftment or the late recovery, as we can say, we would see more of encapsulated bacterial infection such as Streptococcus pneumoniae, and also, again, viral infections, CMV, varicella, and fungal infections. So to summarize, we would say that bacterial infection is at concern, especially pre-engraftment and immediate post-engraftment, whether it's gram-negative or gram-positive. For fungi, we would see in the pre-engraftment Candida infection. We might see also Aspergillus, but it's higher in the immediate post-engraftment period. For viruses, we would see CMV and EBV, especially in the immediate post-engraftment or the late post-engraftment. There are some other infections that can happen, especially in the late post-engraftment, such as respiratory virus of seasonal variation, reactivation of tuberculosis, or NTM. So let's start with bacterial infections and what do we need to take into consideration. So given the fact that it's common, we need to cover for bacterial infection prophylaxis during neutropenia, which is typically less than 100-day post-transplant. And the agent of choice is fluoroquinolones, and it has been shown to reduce gram-negative bacterial infection. And it should be continued until we have a recovery of neutropenia, unless we need to treat specific infection. However, still there is concerns regarding the potential of fluoroquinolone resistance that we might see as well. In a recent published paper in 2022, they wanted to see the efficacy and safety of using prophylaxis levofloxacin in pediatric and adult patient post hematopoietic stem cell transplant. It was a retrospective study between 2016 to 2020, and they wanted to see the proportion of patients who experienced at least one bacterial bloodstream infection in the first 100-day post-transplant. And they included 370 patients where patients in the non-prophylaxis group developed more bacterial bloodstream infection. And there was no difference in the rate of death, antibiotic use, fungal use, and the major concern with the use of prophylaxis, which is the MDRO's infection. And this actually confirms what we are practicing. So giving prophylactic levofloxacin to cover in the first 100-day until the recovery of neutrophil is something that is recommended even by recent papers. So how about beyond the 100 days? So there is also a recommendation to prevent bacterial infection, especially with Streptococcus pneumoniae in patients who are having chronic GVHD and undergoing treatment for GVHD. The choice of the antibacterial agent is not something that is agreed upon. It is based on the local antibiotic susceptibility data in the center itself. Moving on to fungal infections. So as we've said, fungal infections are also common, especially pre-engraftment, post-engraftment with different type of fungi. And the problem with fungal infection, it is difficult to diagnose in a timely manner, and it is associated with high risk of morbidity and mortality. So the use of prophylaxis in fungal infection is something that is of high importance. Aspergillus is one of the most common causes of invasive fungal infection in hematological diseases, followed by Candida and other rare fungi. So despite the recent advances in the use of prophylactic, we also do see invasive fungal infection, and unfortunately, these come with high risk of morbidity and mortality. However, we know that there are patients at higher risk of invasive fungal infection that we need to keep an eye on. Patients who are experiencing mucositis, neutropenia, GVHD, patients having central venous catheter, and patients who are administered broad spectrum antibiotics. So we've agreed we need fungal prophylaxis. So which type of antifungal should we give? With fungal infection, there is no one agent that can cover every single fungi out there. So the concept of having broad spectrum or something that can cover everything is not applied with fungal infections. So if we just want to recap on what exactly do we need to cover, we've agreed we want to cover yeast, which is mainly Candida. And sometimes we do need to cover molds such as Aspergillus and Mucor. So as you see, we have yeast mold. Dimorphic is something that is an endemic, and we don't see it in our region. So usually we don't concern ourselves covering it. If we're seeing fluconazole, you can see it can cover Candida. However, it is intrinsically resistant to Candida krusei and can be sensitive or resistant to Candida glabrata and has no activity against mold. When we move to extended coverage triazoles such as itraconazole, voriconazole, they have additional coverage of molds. However, they do not cover mucor. For posaconazole, it will cover most of the yeast and it will cover all types of mold, whether it's Aspergillus and mucor. Echinocandins, which everyone loves because of the safety profile of it and less drug-drug interaction. As you can see, the coverage of it can cover most of Candida. However, it does not cover mucor and it does cover Aspergillus. So based on that, if we want to choose an agent, if we're thinking of covering Candida, then fluconazole as prophylaxis could be in certain patients. And if we want to extend the coverage to include mold coverage, such as aspergillosis, which is one of the most common infections, especially early post-engraftment, then we can use voriconazole or posaconazole. So the recommendation is in allogenic patient, we can use fluconazole during neutropenia as a prophylaxis, and we can use, especially patients with significant GVHD, we can think of extended coverage. So we can use posaconazole or voriconazole. This is actually a study that they wanted to see what are the differences between these agents? So which agent as an antifungal prophylaxis in patients with hematological disease or undergoing hematopoietic stem cell transplant is favorable over the other? As you've seen, we have different options, and this was a systematic review that it looked into all the available randomized clinical trials, whether the patient received antifungal versus placebo or no antifungal or different type of antifungal prophylaxis. In total, they've included 69 trials with 14,000 patients, and they've looked into different groups of antifungal prophylaxis. They found that posaconazole was associated with the best probability of success against invasive fungal infection and a reduction in invasive fungal infection. And voriconazole was associated with a significant reduction in invasive candidiasis. In a subgroup analysis, they found that in terms of both safety and efficacy, voriconazole might be the better choice in patient undergoing hematopoietic stem cell transplant, while posaconazole for patient with acute myeloid leukemia or myeloblastic syndrome. However, this study comes with its own limitation. The follow-up period was very short for most of the studies, so we cannot really rely on the survival outcomes. Also, there is a lot of heterogeneity in terms of patient characteristics and comorbidities as well. And the dosage form and the doses was not accounted in the analysis, which we know that it really affects the outcomes in terms of prophylaxis. However, it gives us an idea that we do need some prospective trials that can give us head-to-head comparison between these agents that we are using to develop a better picture on a firm recommendation. Well, I want to use this over this agent. Moving on to PJP, it's also one of the concerns in hematopoietic stem cell transplant recipient. And if we're not giving prophylaxis against it, around 5 to 16% of patients will develop it with a high mortality rate ranging from 30 to 60%. However, with prophylaxis, this risk is not entirely eliminated. However, it's reduced to 1 to 6%. It usually occurs within 6 months after transplantation, and this is why this is the period of time where it's important to cover for it and to give prophylaxis. And there are known risk factors for patient to develop it, such as patients receiving allogenic transplant, patient receiving high dose of steroid, or cyclophosphamide or rituximab. The incidence have significantly decreased with the use of Bactrim, and high-risk patients who do not receive prophylaxis or show poor compliance to prophylaxis are the main population at risk of this type of infection. Of course, one of the agents that is well known and studied in different papers is Bactrim, or trimethoprim sulfamethoxazole prophylaxis. And when compared to placebo, it has reduced the incidence of PGP by 91% and decreased mortality associated with it by 83%. However, the mortality rate still remains high despite giving prophylaxis, especially if the patient does acquire the infection. So as a recommendation, we should give it at least 6 months or until the immunosuppressant is discontinued in allogenic hematopoietic stem cell transplant. The main issue with it is the concern of myelosuppressive properties, and it might result in delayed engraftment. Nevertheless, this did not stop us from using it because, as you've seen, the risk of having or acquiring the infection and the risk of mortality is very high. However, we have other options as well that is studied for prophylaxis, such as pentamidine that can be given once a month by inhalation, Dapsone as well, and Atuvacone. So if it's a patient who has an allogenic transplant, then we should give from engraftment to at least 6 months, as long as he's or she's receiving immunosuppressive therapy. For autologous, from 3 to 6 months after hematopoietic stem cell transplant. Moving on to CMV, which is also another cause of morbidity and mortality that can complicate the outcomes in patients with the hematopoietic transplant. It can be either there are different risk factors. It can be acquired from the donor, or it can be of latency in the recipient itself. CMV can cause something from DNA viremia, which is asymptomatic and not a serious infection, and it can extend to having organ involvement, such as pneumonia, and this is actually with worst outcomes in those patients. Whenever there's an organ involvement, then the risk of morbidity and mortality is higher. So this is why we need to overweight the benefit and the risk of giving prophylaxis. So patients, as I've mentioned, who are at risk are CMV seropositive recipient, CMV seronegative with a CMV seropositive donor, those that had unrelated haploidentical umbilical cord or T-cell depleted transplant. There are two approaches for prevention, either pre-emittive therapy or prophylaxis. Pre-emittive therapy traditionally was something that we go as an approach and was preferred over antiviral prophylaxis, because with these antiviral we do have induced toxicities and bone marrow suppressions. So this is why we thought initially that pre-emittive is the better approach. So pre-emittive, basically what they do is they screen for CMV viral load by PCR weekly, and they initiate antiviral upon detection of viremia. The threshold is different between centers and depending on the patient and the risk factor.
2 minutes.
Pre-emetic therapy, however, is appealing because we are reducing the drug's toxicity, we are reducing the cost as well. However, it does require intensive CMV PCR monitoring. It does require for the patient to come on multiple visits and comply with the screening. And many of the studies showed comparing prophylaxis with acyclovir, valganciclovir, did show significant decrease in CMV disease, but not significant decrease in mortality. However, with the addition of letermovir by FDA, or the approval in 2017, this shift of using just pre-emetic has changed to thinking of, yes, we should consider prophylaxis, especially in high-risk patient population. And this was based on a study that is a randomized trial comparing giving letermovir versus placebo. And we've seen clinical significant decrease not only in CMV infection, but also in all-cause mortality, and there was no significant difference in adverse event. And this actually has been also supported by real-life data and real-life experience with it, and many have published looking into historical not giving prophylaxis versus giving letermovir prophylaxis. My final note is, of course, I cannot cover every type of infection in 20 minutes. However, I just want to stress on the importance of vaccination post-hematopoietic stem cell transplant. So the guidelines does recommend in both allogenic and autologous recipients should be immunized as scheduled, even during immunosuppressive therapy. However, if the patient is receiving high dose of corticosteroids and GVHD, we can wait until the dose of immunosuppressant become decreased. So there are different types of vaccine that we should actually give the patient, starting from 3 to 6 months, and with live vaccine 24 months after transplant. So just to recap what we've said, that with hematopoietic stem cell transplant, we have advanced a lot, and we have advanced also in terms of prophylaxis and knowledge of infection and risk stratification. However, we still have a lot of research to do and a lot of things to look into, and we do need further studies to improve the prophylaxis of infectious disease and the outcomes, of course, in the future. Thank you so much.
Thank you so much, Dr. Bashair. Very informative lecture. Thank you. And we'll go with our last speaker today, Dr. Afnan Noor. Dr. Afnan is a board-certified oncology clinical pharmacist. She has completed her pharmacy postgraduate year, 1 year and 2 years in oncology hematology PMT at King Abdulaziz Medical City in Jeddah in 2020. Currently, she is working as a clinical pharmacy specialist in hematology and bone marrow transplantation adults in King Faisal, Jeddah. Welcome, Dr. Afnan.
Thank you, Dr. Amara, for the nice introduction. And I would like to thank the organizing committee for giving me this opportunity to present this topic today, which is about calcineurin inhibitors and stem cell transplantation. So why this topic is important? Because calcineurin inhibitor is widely used in transplant patients, and it's considered a neurotherapeutic index associated with a lot of drug-drug interactions and different formulations with different pharmacokinetics. So it's require close monitoring and dose adjustment. So throughout this presentation, we'll be able to identify calcineurin inhibitor mechanism of action and pharmacokinetics. And we're going to discuss drug-drug interactions straight to the CNIs, summarize the appropriate dosing and monitoring of CNIs, and review the sum of CNI toxicities. We'll start with the mechanism of action. It's actually reduced the T cell activation through the inhibition of calcineurin by forming a complexes in the cytoplasm with cyclophilin and FK binding protein, respectively. And this calcineurin inhibition will result in reduce of transcription of many cytokines. It's mainly indicated to prevent and to treat graft-versus-host disease post-transplant. It's important here in this slide to know that we have a lot of formulations. For example, in cyclosporin, we have non-modified and we have modified microemulsion products, and we have as well topical and parenteral. And for tacrolimus, we have the same idea, different oral formulations which are not interchangeable. And an important point to know, if you stabilize patients on one formulation, you should not change it to different formulation because the concern of different pharmacokinetics. And also, if your patient can't tolerate oral, just go ahead and change it from IV to oral, as the IV route associated with higher potential of toxicity. An important point to mention about administration, if you are dealing with cyclosporin suspension, we can mix it with orange juice or apple juice that will mask the unpleasant taste of cyclosporin. And we cannot mix it in plastic because it's going to adhere to plastic containers. For tacrolimus, the important point regarding the extended release product, if you miss the dose or if the patient misses the dose, just counsel the patient to take it as soon as possible within 15 hours as a time window. Otherwise, he should wait for the next dosing timing. For immediate release cyclosporin and immediate release tacrolimus, it should be administered, if the dose has been missed, should be administered within 4 hours as soon as possible. Otherwise, the patient should not double the dose. If you want to switch from formulation to another formulation, we need to closely monitor this patient for several weeks after switching and adjust the dose to attain the pre-convergent blood concentration. And in this table, you can see the conversion factor for oral to IV. Cyclosporin is 1 to 1.4. For cyclosporin to tacrolimus, actually, the clinician use 40:1 ratio when they are converting from cyclosporin to tacrolimus. For tacrolimus switching formulation, from oral to IV, we are using 1:4. And from immediate release to extended release to 1:1 conversion. Immediate release to extended release, we have to use 80% of the immediate release and convert it to extended release. For oral immediate release to some sublingual immediate release, we have to decrease the oral dose by 50%. And from granules to capsule, it's 1:1. The important thing about absorption of calcineurin inhibitors, that they are poorly absorbed in general. It has a lot of inter and intra-individual variability, and also as well as a lot of drug interaction and first-pass metabolism effect. The oral bioavailability of extended release tacrolimus approximately 50% higher compared to the immediate release tacrolimus. And it should be administered at morning, as the report and the study showed that the morning administration associated with higher area under the curve or higher bioavailability compared to the evening administration timing. It's interesting to know and to remember that the absorption and metabolism of CNIs may vary with race and ethnicity, and this variation may be related to differences in the frequency of polymorphism in cytochrome 3A4, 3A5 gene. Continuing about the pharmacokinetics, the distribution for both agents widely distributed in tissues, and they are also highly binding proteins. And for metabolism, both of them are extensively metabolized through hepatic. And for cyclosporin, it has more extensive first-pass effect, which decrease the bioavailability. For elimination, it's important to know that both agents will have a prolonged elimination in patient with hepatic impairment, and it will be shorter elimination in pediatric due to higher metabolic rate. And you can see the half-life for a different formulation, they are different, even for tacrolimus as well. The immediate release tacrolimus has a variable half-life, which is not, we cannot rely on one number. However, the extended release is almost 38 hours. Going forward to the Food and Drug Administration, for food interaction, the presence and the composition and timing of food may affect the absorption of many immunosuppressive drugs. However, it's not practical just to avoid the food at the timing of CNI administration. So it's better to counsel the patient to be consistent with the in terms of food manner or administration of food, whether to take it with food or without food, the patient should be consistent. One of the major food drug interaction is the grapefruit. It's increased in systemic exposure to cyclosporin and tacrolimus, and we have to counsel the patient to totally avoid it. For drug-drug interaction, we have a lot. So we'll start with the first one is the divalent cation, like aluminum hydroxide and magnesium hydroxide, which we are using it a lot in those patients. To minimize, it's going to increase the absorption of tacrolimus. So we have to minimize this interaction by separating the two drugs by 2 hours. For cyclosporin, it's considered a substrate and inhibitor of P-glycoprotein. So all the medication that will be metabolized by this protein should be adjusted if it's combined with cyclosporin. For the drugs that affect gastrointestinal motility or emptying, like prokinetic, for example, that will affect the absorption of calcineurin inhibitors. So for laxative, for example, it's going to decrease the oral absorption by accelerating their passage through the intestine, while the narcotics may increase the transit time in intestine, which increasing the time for absorption. For tacrolimus and cyclosporin, there is a general rule. If you're combining one of these medications with other medication, interacting medication, and both drugs are oral, that will increase the significance of drug interaction because the intestinal and hepatic cytochrome 3A4 enzymes contribute to drug metabolism. So we'll start with the first interacting agent, which is the cytochrome 3A4 inhibitors. It's going to markedly increase the tacrolimus trough concentration and AUC, and it's require impaired tacrolimus dose reduction. And the percentage of this dose reduction, it depends on how strong is the enzyme inhibitor. So for example, with moderate cytochrome 3A4 inhibitor like fluconazole, so it's required from 30 to 50% dose reduction. And while if it's combined with strong cytochrome 3A4 inhibitor like Vori or posaconazole, that will require even higher dose adjustment, reaching to 75%. While the cytochrome inducer, actually, we should not empirically increase the dose, as the initiation of the tacrolimus dose upon initiation, the induction require time from 1 to 2 weeks. So we should not empirically increase the dose of tacrolimus, but we need to monitor closely and adjust the dose as needed. The same idea with cyclosporin when it's combined to cytochrome 3A4 inhibitors and inducers. However, in addition to tacrolimus, drug interaction, the cyclosporin considered an inhibitor for OATP1B1 enzyme. And as I mentioned before, it's also inhibit the P-glycoproteins considered substrate as well for this enzyme. So all the medication that gonna be metabolized or involved in these enzymes will be affected and need dose adjustment. So now we'll start talking about monitoring of calcineurin inhibitors. There's a lot of factors gonna affect the dosing and the monitoring and drug concentration in the blood, according to the pharmacokinetics factors, presence of infection, drug toxicity, and presence of graft versus host disease, as well as the timing of concentration, the type of laboratory immunoassay, the schedule and frequency, and adherence to the medication. So how to monitor it? We are taking a trough before the 5th dose, and which almost approach 50 to 100% of the anticipated steady state. And if the patient has any, like a change in organ function or drug interaction that might need required more frequent monitoring. The goal of trough level is from 200 to 400. And if you want to switch to tacrolimus, it's better to wait till it's less than 125 to avoid any added toxicity. And here you can see the dose adjustment percentages based on the blood level. And in the table, you can see the dose adjustment percentages according to the bilirubin and serum creatinine. For tacrolimus, the goal of trough level is from 5 to 15. And if you want to switch to cyclosporin, it's better to wait till it's 5. And the same monitoring way we're gonna go with. The only point that we want to mention regarding tacrolimus, it's gonna take longer time to reach the steady state. And if you're taking the trough before the 5th dose, that will almost approach 50% of the steady state. So take in your consideration that the trough level, the first trough level will not reflect the full steady state. And here is the table which shows that dose adjustment based on serum concentration. And here's another table which shows the dose adjustment based on renal insufficiency. An important point for nurses that the tacrolimus readily absorb to venous catheter lumen. So if you want to check the trough, it should be withdrawn, the blood sample should be withdrawn from different line. Okay. Now we'll talk about the toxicity, which I summarized it in like 5 categories: neurotoxicity, nephrotoxicity, hypertension, metabolic, and cosmetics. We'll talk about the first toxicity, which is neurotoxicity. We have acute and chronic. The acute one is a result occurs as a result of efferent arterial vasoconstriction ischemia. It's considered a reversible toxicity. It is a multifactorial. And it's lower with tacrolimus compared to cyclosporin. For chronic nephrotoxicity, like interstitial fibrosis and glomerulosclerosis and tubular atrophy, the factors associated with this chronic nephrotoxicity is the acute nephrotoxicity induced factors. And in addition to that, the increased release of aldosterone. How to manage it? Simply by dose adjustment, as I mentioned before, and avoiding concurrent nephrotoxic medication. And we can use calcium channel blocker, such as amlodipine and nifedipine, has shown to improve blood pressure and to maintain glomerular filtration. Now we'll talk about the neurotoxicity. We have 2 different types of neurotoxicity. We have central and we have peripheral. And I will talk first about the central in terms of pathophysiology and treatment. So the first one is central, the major central neurotoxic effects. We have a posterior reversible leukoencephalopathy syndrome, and we have toxic encephalopathy, seizure, and kinetic mutism. For minor central effects include insomnia, visual symptoms, headache, tremor, paresthesia, and mood changes. And this type of toxicity is more frequent, approaching 40% of patients. How to treat this central toxicity? By reducing the doses of CNIs or by converting from CSA to tacrolimus and vice versa. Or we can use the technique of combining combining immunosuppressive drug like CNI plus mycophenolate or sirolimus, allow lower doses of CNI without impairing the efficacy. How to treat the minor symptoms of neurotoxicity, which is considered a common toxicity, by symptomatic treatment, analgesic for headache, low doses of benzodiazepine for insomnia, beta blocker for tremors, and anti-epileptics for paresthesia. Now back to the peripheral type, which occurs weeks to months after starting immunosuppressive drugs, and it can involve both nerves and muscles, and it's considered more severe form, have been observed during tacrolimus therapy specifically, and such as a multifocal and demyelinating neuropathy. Some patients may respond to intravenous immunoglobulin or plasma exchange. How to manage it? By preventing it, and the prevention can be achieved by oral formulation of cyclosporin and tacrolimus, using minimum efficacious doses of CNIs, strict monitoring for plasma levels, correction of electrolyte imbalance, and be aware about the interaction. Hypertension, as I mentioned before, it's caused by renal vasoconstriction and sodium retention. It occurs within the first weeks of therapy. How to manage it? By using calcium channel blocker, and pay attention to the drug-drug interaction associated with diltiazem, which require dose adjustment. For toxic encephalopathy, which is a neurobehavioral disturbance, including mild cases mimic psychiatric disorders and also associated with acute psychotic episodes, and there is the treatment or the management is not specific, involving replacement of the toxic immunosuppressive agent and symptomatic treatment for example, using quetiapine as an antipsychotic drug, or using a sedative for agitation like lorazepam.
4 minutes.
For seizures, can be partial or generalized. It's most frequently the tonic-clonic type. How to manage it? If it's require urgent management, we can use the IV phenotype is the drug of choice. And for we can use oral options like gabapentin, Keppra, valproate, or carbamazepine, and we can stop it within 3 months. Posterior reversible encephalopathy syndrome. It occurs in 1.6% of transplant recipients at any time of transplant, but usually in the first month. What are the risk factors for PRES? Including sepsis, shock associated with multiple organ function, and coexist with TSA and tacrolimus toxicity. What is the clinical manifestation? It includes nausea, vomiting, headache, visual hallucination, cortical blindness, confusion, disorientation, delusions, pyramidal motor weakness, aphasia, ataxia, and seizure. It's required to do MRI early in the diagnostic evaluation. It's usually resolved in few days or weeks. However, irreversible changes may appear in some parts of the lesion. How to manage it? By holding the offending CNIs and bridge it with corticosteroids and or mycophenolate, then switch it to sirolimus. However, we can switch to an alternative CNI. It's considered reasonable, but may cause PRES relapse in some patients. For metabolic abnormalities and infection, CNI has been associated with glucose intolerance, hyperlipidemia, hyperuricemia, hyperkalemia, hypomagnesemia, and hypophosphatemia. Also, for cyclosporin alone, it contributes to bone loss due to induction of high bone turnover. Also, it's associated with infection, as we all know, bacterial, viral, and fungal infection. It's also associated, the CNI associated with risk of malignancy, like squamous cell cancer and benign or malignant lymphoproliferative disorder. And mainly, the risk factor is the overall level of immunosuppressive. Another toxicity which is the gastrointestinal toxicity, including anorexia, nausea, vomiting, diarrhea, and abdominal discomfort. And finally, the cyclosporin alone, not tacrolimus, is associated with gingival hyperplasia and hirsutism. And the risk factor for that is the poor dental hygiene, higher doses of cyclosporin, and concomitant use of nifedipine. How to manage it? For sure, by substitution of cyclosporin with tacrolimus. And there is like a case report suggests to use metronidazole or azithromycin courses. For tacrolimus, it's associated with alopecia in some reports in kidney, pancreas, or recipients. With that, I want to conclude that CNI play an important role in preventing and treating GVHD post-transplant. However, it has a narrow therapeutic index associated with many drug-drug interaction and need close monitoring and dose adjustment. We have to be vigilant about CNI-induced toxicity and their management. Thank you.
Thank you, Dr. Afnan, for amazing lecture. Thanks. We conclude our session. We discovered some power of the clinical pharmacist and how they are important in BMT. I have just one question to Dr. Bashair. If you can join us, please. As you mentioned, Dr. Bashair, we have challenging cases of CMV activation, and always we have a question about using the CMV immunoglobulin. How do you comment, and when it's indicated?
Thank you for your question, Dr. So in terms of prophylaxis, I didn't encounter any studies where they looked into it in terms of prophylaxis. However, in terms of treatment, yes, and in terms of preemptive, so there wasn't like prophylaxis from the get-go. However, while they're looking at the viremia, there was evidence. But again, it's not crystal clear, or there is a criteria that is specific based on the on evidence. So you would see different centers do different approaches. And this is why I stressed at the end that we do need to share our experiences. I know that we are doing every center, we're doing some protocols and some things that is based on small studies. However, if we do look into it and publish it, then we will have cumulative knowledge about criteria that we can say with confidence that this is 1, 2, 3, when can we use it.
Thank you so much. Because of the limited time, maybe any other questions to be personally, or no, it's fine. Dr. Saad, اتفضل.
Question and comment. The question for Dr. Abhour. It's a scenario you are facing from time to time when you have a patient with bone marrow failure and renal failure at the same time. The bone marrow transplant needs a lot of medication. The other one just an organ, they will take it and they put it there. So which one should go first? And comment for Dr. Bashair, the triazoles are good from the coverage point of view, but the drug-drug interaction is a major problem. So most of the center, we are using the echinocandins like casbuvangin.
Assalamu alaikum. So if I understand your question correctly, which indication we should go first to manage?
Yeah, we'll go with renal transplant first or bone marrow?
Well, I think that's a clinical decision to be done by a group of brilliant doctors in the BMT. Whatever general rules, whatever goes first, we can tackle. Probably, just a humble opinion. In terms of the medications or the concerns, as I mentioned, there are a lot of recommendations now. Maybe it's a gray zone, but we can probably work around it. Eventually you will have to go probably with what is pressing matter with the patient in terms of nephrotoxic medication. if there is no contraindication, probably it will require more close monitoring, dose adjustment, mitigating approach such as hydration. It might be a challenging case, but then whether to go with renal or bone marrow, that's a tough call for the doctors.
It's an intriguing question. I just have a comment, brief comment. Actually, John Hopkins reported concomitant renal transplant as well as bone marrow transplant. And actually what they found is that those who got both at the same time, so they do the renal transplant as well as the bone marrow on the same sitting. They are able to take them off immunosuppression for renal transplant purposes later on. So with a post-cyclophosphamide conditioning regimen, haplo. So it's really intriguing and interesting data from their result. So they can do both.
I have last comment for Dr. Afnan. I would like to thank her for the message she gave. If you are combining with inhibitor, abrupt dose modification should be done, while with inducers, wait and monitor the level. Am I right? Thank you so much.
Assalamu alaikum jami'an. Thank you for my colleagues for inviting me to moderate this great session for this great conference. My name is Uthman Radwi. I'm one of the assistant professors at King Abdulaziz University, Adult Hematology and Transplant. It gives me a great pleasure to introduce this next session, which is broken on two parts. So first part is actually going to be presented by elite speakers, and also the other part by elite speakers as well for two cases. Allow me just to remodify the schedule as per the scientific committee to introduce first Dr. Shahrukh Hashmi, who is going to be teaching us at least new things about chronic refractory, advances in chronic GVHD, which is steroid refractory. The floor is yours, Prof. Shahrukh. Sorry, allow me to, because he's well known, I forgot to introduce him. Dr. Shahrukh Hashmi is Professor of Medicine at Mayo Clinic, and also he's the head of the hemato-oncology at Sheikh Shakhbout Medical City in Abu Dhabi. Dr. Shahrukh.
Great, thank you. Can you hear me?
Then wide and clear, Dr. Shahrukh.
Okay, great. Thank you. Great. Thank you for having me. Assalamu alaikum. And I present my slides. All right. So while I want to mention this topic on chronic graft-versus-host, and we're going to not on prophylaxis.
Share screen, doctor, please. Can you share screen?
Yes, I can do that. Let me know when you can see this. All right. Can I can start?
Yes, please, Dr. Shahrukh.
Okay, thank you very much. These are my disclosures. None are relevant.
Slideshow, doctor. Slideshow, please.
Okay. Okay, now can you see my slides?
No, I see presenter view mode.
Okay. Okay, now can you see the slides?
We can see the slides, but on the top row, can you just slide show and view, or F5 might work.
Okay, I've given it to the organizers. So let me know when the slideshow is up.
Yes, go. We can proceed, right? Dr. Shahrukh, you can start. It's fine.
All right, great. Thank you very much. So we're going to talk about the current and future approaches in treating steroid refractory chronic GVHD. Next slide, please. I have no relevant conflicts of interest, but the disclosures are given here. We're going to talk about GVHD.
You're controlling the slides, Dr. Shahrukh. You can control it. Yeah.
Okay, great. Thank you very much. All right, so the question is, why is GVHD such a big problem? And we're going to talk about staging and management strategies for GVHD. As you can see, the allogeneic transplant activity continues to increase, and that is why we will have a lot more GVHD burden in the future. This is US data, but the worldwide activity continues to increase as well. Secondly, the donor types for unrelated registries has increased significantly. And secondly, the haplodonors have increased significantly as well. Therefore, we're going to have an increase in chronic GVHD burden. This is just showing the type of donors, which is, as you know, that the haploidentical is the green one, which is increasing, but also the top bar, which is the blue one, also continues to increase. Can you see the slides? Just confirming.
Unfortunately, we lost the slides.
Okay. It's with the organizers, so if you can pull up the slides.
There you go.
Now share. Now share my. Can you see the slide?
Yes, I can.
I will send control now.
Okay. All right. And while the control is going to be given to me, I just want to mention that GVHD is a very sophisticated and complicated field. There's been a lot of progress in the GVHD as far as the treatments are concerned. And now with this slide, you can see that there is more than 80,000 transplants a year, 40,000 allogeneic transplants. Because of aging populations and increase in non-myeloablative transplants, there's going to be a significant increase in the number of transplants, but also GVHD. As we know, the CTN study concluded that survival is the same and relapse is the same if you use peripheral blood stem cells and bone marrow. However, the whole world continues to do peripheral blood stem cells rather than bone marrow for many diseases, in fact, and that's going to lead to an increase in GVHD rather than decrease. The treatment paradigm is that first-line treatments differ from the second-line treatments. And it's very important to know that the definitions of second-line treatments are dependent on refractoriness. For example, in this one, you see that the chronic GVHD progression on prednisone 1 mg per kg per day for 1 to 2 weeks is actually steroid refractory disease. However, steroid dependence is totally different. Inability to taper prednisone below 1/4 milligram per kilogram per day in at least 2 successful events. So that's important actually to realize. Rather than one time just tapering it off, I usually after 2 weeks put them again back on the higher dose and see actually if they're dependent or not. Typically, you can do it after 2 months, after 3 months. I usually start thinking more very early about dependence rather than refractoriness. This is just to show you, this is what we do every day in our clinic. All my nurses have this in our GVHD clinic. You have to do the proper grading of the GVHD. This is 2014 criteria. 2020, the NIH has convened and made another criteria, which is going to be released soon. 2 papers have been published already on that. But this is something which is clinical symptoms. So you have to do this just like you grade any other disease like AML, myeloma, or anything else. Well, the fundamental question is, how do we treat the chronic GVHD today in 2023? Well, it depends on where you are, what drugs are available, what clinical trials are available, the expertise on GVHD, and also the other factors like patient affordability, insurance issues, and organs involved with GVHD. Now, all of you have heard of CTN trials that we have done in the past in the United States, which are multi-center trials all over the US, maybe 20 centers, 20 largest cancer centers in which the BMT is happening. We learned the hard way from acute GVHD, and it's important for you to know that when we did the study more than a decade ago, in which we put 4 best drugs, mycophenolate, ONTAC, TNF inhibitors, and pentostatin at that time to see who is a winner for acute GVHD, not for chronic. We found out that mycophenolate was a winner. Mycophenolate, or MMF, was a phase 2 trial. Now we did the phase 3 trial that was a multi-center trial on MMF versus plus steroids versus steroids alone, and it was a complete failure. So we learned the hard way that one has to do randomized phase 3 trials in order to actually treat complicated diseases. Otherwise, based on single-arm trials or actually phase 2 trials, decision to be made is going to be tough. So the most effective treatment in 2023 is corticosteroids. And the second-line treatments are numerous. The current paradigm of second-line treatments has a lot of medications, and these are just the new medications. It doesn't take into account the current medications we use like rituximab, like sirolimus, like methotrexate, and others. These are the newer medications. Article just a couple of years ago by Annie Im and Steve Pavlicek looking at the future paradigm. And one of these medications, KDO-25, that's a ROCK inhibitor, was approved already for chronic GVHD. Now, the second-line treatments given on the right-hand side for chronic GVHD, that's my talk today, ruxolitinib, abatacept, alemtuzumab, belumostil, and many others given here. And we use all of them in different parts of the world. And if you ask me that which one of these are approved for the treatment of chronic GVHD, there's only 3 of them which have recently been approved: belumostil, ruxolitinib, as well as we have the ECP, which is approved by most of them, and ibrutinib as well. The abatacept given second has been approved for prophylaxis of GVHD by the US FDA, but not for treatment yet. So how do you choose a treatment? Well, it depends actually on a lot of factors. These are tip of the iceberg. And let me tell you this, that if I tell you the response rates of a very old drug like sirolimus may be equal to these drugs, and why sirolimus is not approved, and that's because very old medications like aspirin are not approved for many conditions, like, for example, headaches. And that's the reality in the bigger picture, that don't think that this is the only treatment paradigm for GVHD, because it ain't. The ECP is very safe. We don't know how it works, actually. We thought it was Treg increased, Treg T-con ratio is altered, but at the end of the day, it's controversial. But it works pretty well, actually. The logistics are very tough, though. It's expensive. It does not compromise the graft versus tumor effect or graft versus leukemia effect, but there could be complications of thrombosis and infections. One of my fellows did the meta-analysis, and we saw the response rates, which are very acceptable for chronic GVHD treatment for second line. Now, the reason why I'm showing this is because if you look at the organs, skin, liver, GI, ocular, all these are very, very different. And that's why we do meta-analysis to pull up the studies actually and look at the overall meta-regression of any particular drug or any particular modality. And this is what you need to look into when you're treating patients. Now, let me go over the 3 drugs that have recently been approved over the past 6 years by the US FDA. They may not be available in Saudi Arabia, all 3 of them routinely for all the patients, may not be available in most of the countries, and in fact, they're not. In fact, all 4 treatment modalities that I showed, ECP, ibrutinib, ruxolitinib, and bilomostil, are not present in majority of the world. In less than a quarter of the world, they're present. But let me go over the data of these new drugs, which at least in the US are considered to be the first go for second-line treatments. The ibrutinib trial that led to the approval was a single-arm trial. David Miklas had presented this, 42 patients, phase 1b, 2a trial, steroid refractory GVHD. They had to have 25% or more involvement of skin of the mouth with chronic GVHD. As you can see, the response rates are 67%. The CR was 9, PR was 19 patients and out of 42, so showing good results actually. And this is equating the results of the previous studies that we've done for rituximab. Rituximab may be a little bit higher in some studies, maybe a little bit lower. Sirolimus, methotrexate, imatinib, and many other drugs. The 1-year follow-up study was presented by Ed Waller as well, which was showing proof of principle that even in the long-term follow-up, it was actually showing ORR of 70%, approximately the same actually. Now, when it comes to ruxolitinib, I want to mention this important part, that the world psychology changes based on the global KOLs so much that bendamustine Rituxan for lymphomas got adapted even before the phase 3 trial. So I asked the question that ruxolitinib in GVHD, this study in leukemia in 2015, what was it, phase 1, 2, or 3, or 4 for its real-world effectiveness studies? And the answer is none. It was actually a retrospective study from Stanford in Germany, which a lot of people were impressive results for sure. But a lot of people start changing practice with ruxolitinib based on a retrospective study, which should never happen in a practical world, unless there's no other choice. But nonetheless, let's see the actual study that we did for ruxolitinib for chronic GVHD. This was a randomized trial, actually the only randomized published trial for phase 3 randomized trial for chronic GVHD second-line treatments in the world. At the moment, there's no other published trial. So we found that the response rates were proof of principle, what we saw in the retrospective studies. And it was against a best available therapy, which had ibrutinib, ECP, and many other treatments, sirolimus, etc. And obviously, the randomization was fair, and there was a crossover arm, clearly indicated that it works in 70% or more response rates in majority of the organs, which was actually leading to the approval of ruxolitinib for chronic GVHD. It was approved for acute GVHD already. Now, this was a REACH3 trial. And if the organizers can put back the slide 28. The next study is bilomostil, which is Rezurock, which we use very frequently here in SSMC Mayo in Abu Dhabi. This was actually a ROCKSTAR study, which was a ROCK inhibitor. Corey Cutter had presented this study already in the plenary sessions in the past and / oral sessions. And it did show the proof of principle that response rates were 74% and 77% in the bilomostil 400 milligrams. So if you ask statistically, well, obviously this was not a comparative trial. To me, it's a single arm trial because, you're using bilomostil versus bilomostil, right? Jakavi versus Jakavi, aspirin versus aspirin. So on the other hand, statistics apart, methodology apart, response rates were excellent. And in fact, in some of the organs like lung, in the selection criteria of the lung patients who entered the criteria or entered the trial, the response rates were actually dramatic, but not the end-stage lung disease patients. GI also was fantastic as well. This is the forest plot showing a lot of variables actually did improve. Well, we did, Steve Pavlicek, Stephanie Lee, myself, and many others on this study. We did this this meta-analysis plus cost-effectiveness analysis, the way NHS ICER does actually for the NICE. And we actually had to do the meta-regression for each of the drugs that were there at that time when it was published. And we also did the cost-effectiveness for each of the drug. And guess who was the winner when it comes to cost-effectiveness? You have both the CR and the PR, which is ORR, as well as the cost, actually. If you put that into account, then the winner clearly was methotrexate. In fact, I hadn't put this drug, because I was a PI for the study, in the actual drug list, but Stephanie Lee indicated to me and Steve Pavlicek that, you know, they do use this routinely in their GVHD clinics. So that's why we included this, and we had no idea that this was the most cost-effective drug for chronic GVHD. And I usually use about 15 milligrams a week, actually, once a week. I'd say every Jummah, every Friday, I actually take this drug, and then go up to 20 milligrams. In kids, actually, I do 10 milligrams max if they're more than 20 kilograms. But, you know, the actual drug at 20 milligram every week in 3 months works like wonders, just like any other approved medication that you're seeing on the screen today. Just same old, plain, old as gold methotrexate. Anyways, the ruxolitinib, ibrutinib, belumosudil have different toxicities. These are approved in the US. And don't think that these are the only drugs you can use. You can use sirolimus as well, rituximab. You need to know how to use them, but also which organs they affect the most. So the last slide, because I want to finish on time and give some time for discussion. We have other experts as well in GVHD on the panel today. The problem I see, and I'm going to ask a provocative questions to the audience, is why the primary endpoint is overall response rates, when it doesn't not necessarily translate into survival. It doesn't actually in a lot of cases. So the quality of life in a morbid disease like chronic GVHD should be the co-primary endpoint or endpoint of a clinical trial. Now, in a GVHD panel that we're designing the trials, a lot of my GVHD colleagues from globally, from Europe and US, they dispute that because they're like, no, we don't have a perfect quality of life scale. And my counter argument is you don't have a perfect scale for measurement of overall response rates either that would translate into quality of life and survival. Anyways, so that quality of life of a patient, to me, patient-reported outcomes are more important than physician-reported outcomes. Prevention trials are more important. We have forgotten the principle that prevention is better than cure. So CTN 1703, post-transplant PSI, was already in the plenary session by Shernan Holten in TCT last year. We saw that in tandem, and it was published in New England Journal of Medicine recently, as all of you saw that, and on wonderful results as far as the GVHD prophylaxis is concerned to decrease the risk of chronic GVHD. While gene therapy trials with suicide gene therapy are actually not for the treatment of a particular monogenic disease. If you CRISPR-Cas9 technology, the stem cells, even haploidentical stem cells, you can switch on and switch off the button if the leukemia happens so that you don't have GVHD. Microbiome management, I know that Mohammed Moti and our colleagues have done wonderful studies for acute GVHD for treatment, but also you're going to see a lot more studies coming up for the treatment of chronic GVHD as well. This will be a much more important area of research. Cell therapy trials, MSCs, work amazingly in acute GVHD, and they are approved for GI GVHD in pediatrics in Canada and New Zealand and Japan. Not just because they're not approved in the United States doesn't mean that we can't use them worldwide if the data is convincing. So focusing on just the US FDA or just the MHRA or focusing on the European approvals or NMPA in China is a big mistake, actually. We got to do our own strategy in each country. And then better DR match with KIR, NEPA, NEMA, many other matches by artificial intelligence modeling is important. We need good models for chronic GVHD. We do not have good models for chronic GVHD. We've got good marine models and good canine models for acute GVHD, but not for chronic GVHD. Chronic GVHD biomarkers are getting better. I can't even tell you how big proponent I am of using bone marrow in non-malignant conditions, but also in malignant conditions like chronic phase CML, which do not require necessarily PBSCs. And in not very high risk AMLs as well, you have to think, which are in good remission, for long-term GVHD and long-term survival and quality of life by using a bone marrow. And then obviously artificial intelligence algorithms. With that, I'm going to end the talk, open for discussion, and I'm going to emphasize, do not blindly follow what everybody else is doing just because this FDA of a particular country is approved. Think about the data, think about your patient, think about the whole world, think about cost effectiveness. Thank you very much.
Thanks so much, Dr. Sharouk, for the excellent talk. I'd like to open the floor for questions for Dr. Sharouk. Any? Dr. Nahla?
Thank you, Dr. Sharouk, for this excellent presentation. My first question is, if I have a patient with recurrent graft-versus disease and off immune suppression after steroid, I'm thinking of starting Jakavi. Should I start it like a single agent, or I should resume the immune suppression targeting at therapeutic level like tacrolimus or cyclosporine?
Well, that's a very important question and a very practical question, because what is the peak incidence time for chronic GVHD in the CIBMTR studies? And the answer is 6 months. Actually, and the reason is that by 4 months, a lot of people in America, they really taper down the tacro and cyclosporin. Rule number 1, when you tapered off the tacro and cyclosporin, and they were protecting against the GVHD, and suddenly the GVHD happens, within 3 months, you restart the tacro or cyclosporin, the same drug, because we know it works. And then obviously, if they don't work at all, then I would start steroids first. I would not jump to the Jakavi or ibrutinib or belumostil. Steroid therapy, 1 mg per kg per day, not the 2 mg per kg per day for acute, but 1 mg per kg per day. And if it doesn't work in 2 weeks, according to definitions, then I would start. Number 1 recommendation from the European guidelines that were just published by Olaf Pennak, our colleague from Germany, is actually ruxolitinib. You're right, because it has a phase 3 trial. None of the other drugs have a phase 3 randomized trial published yet. So you're right, but do start the original medication first, steroids, and then Jakavi. Thank you.
So my second question and last question, if I have a patient with recurrent chronic graft-versus disease requiring multiple line of immune suppression, what is the acceptable response for such a patient that allow him to rest from immune suppression for a while? Is there any, you know what I mean?
Are you asking, like, when can we stop the immunosuppression after starting with recurrence?
Should we look for complete response, or we allow like grade 1 graft-versus disease chronic?
Well, that is an excellent question, because some of the patients with only grade 1 skin or grade 1 mouth can live with that normally. And if the patient tells you that my quality of life has returned back to near normal, I think that's a win-win situation. I do not taper off completely if the patient is on low-dose tacro or low-dose ruxolitinib or low-dose ibrutinib or cyclosporin for years, in fact. In fact, we just published a paper in BMT Nature on the recurrence and thinking of relapses of GVHD, then how important that is. And that editorial was about last year. And actually, it's called the Lazarus, in fact, that's about GVHD. We have to think of GVHD as myeloma. You stop the drugs, immunosuppression, it will recur again. You don't need to put Jakavi like 20 milligram a day for the next 5 years, but even 5 milligram of ruxolitinib will prevent the relapses of GVHD. Tacro, I have many patients for years, in fact, even 5 years, 6 years, 7 years, 8 years on low-dose tacro or cyclosporin, and they're doing well. I'm not taking that off because I know the kidney is fine, the blood pressure is not a problem. I screen for skin cancers as well. In those cases, you can continue So you're asking a very, very good question. Do not completely taper it off when the patient is very stable and having no side effects. Very low dose will really help a patient. Thank you.
Thank you so much. Appreciate Dr. Sharouk. From my own personal experience, I know sometimes it takes time in the clinic to fill the NIH scale, but with more practice, actually, it becomes faster and faster. Thank you so much, Dr. Sharouk, to proceed with the next talk. Allow me to introduce Dr. Marwan Shaheen, our colleague consultant at hematology and transplant at King Faisal Specialist Research Center Hospital in Riyadh. The floor is yours, Dr. Marwan. Going to be talking about acute, optimized second-line treatment in acute GVHD.
Thank you for the kind invitation again. Today, my role is to speak about the second-line treatment in acute GVHD. So first, I will remind you about what will happen if the donor-derived immune cells are transferred to the recipient with the graft, with the cells, with the stem cells. The host cells will recognize this as a foreign body and will attack. If this happens in the first, the slide is not moving. Yeah. So if this happens in the first 100 days, we call it the classic if there is no other feature of chronic. And for the chronic, usually there is no limit. So there is nothing called 100 days. If you see the risk factor for acute and chronic, they are not vary. So the only some difference in some of the disease like CML usually give acute. And if you do post-transplant donor lymphocyte infusion, you are susceptible for chronic mainly features. If you have a history of the patient have a history of acute GVHD, especially acute grade 3 and 4, he is at very high risk to have chronic. So the timeline and the symptoms, both very important in classification. The feature of erythema, maculopapular rash, acutely, nausea, vomiting in the upper GI, perfused diarrhea, alias in the gut, and the cholestatic liver disease features. If this has happened in the first 100 days, this is acute GVHD classical. If persist beyond day 100, still we call it persistent acute. If it's recurrent with the acute feature, we call it recurrent acute. And if it only comes after day 100 with the classical feature, we call it late onset acute. And if there is both features of chronic and acute, we call it overlap syndrome. What is the pathophysiology for acute GVHD? So what happened is in the pre-transplant conditioning regimen, it will damage the host tissue, damage the tissue. And this will produce inflammatory cytokine. And there will be like TNF, interleukin 1 and 7, which will be released from the damaged tissue and will activate the host antigen-presenting cells, ABC. So the antigen-presenting cell is activated, and this will will reduce donor T cell in this time, and the T cell of the donor will proliferate and differentiate and migrate to cause the phase 3, which is the target cells apoptosis, which damage the organ more and more with cytotoxic T lymphocyte stimulation of the killer cells and the apoptosis. We still use the MAGIC criteria for staging. It's mainly in the skin. We use the same as the body surface area map of the burn. And in the liver, we only use bilirubin, not the ALT/AST. And in the lower gut, we still use the number, frequency, and the amount of the stool, which is really challenging. Some patients are not compliant with the measurement, and we are not giving them the plastic hat that we use to collect. Now, in the skin, if there is more than 50% and a bullous formation, this is very, very severe, and it goes to stage 4. And in the lower GI, if there is any blood stool, actually gross bloody, regardless of the volume, this is stage 4, as we know. So after you stage, you go to grade. You use also many criteria, but most of the people, like in our center, we're using CIP-MTR because we are one of the centers of the CIP-MTR reporting, but also MAGIC criteria is there and difficult to memorize. So usually you have to open it and check where is your patient. This is important. The grading important in decide of how aggressive you should go with the treatment. The grade 3 and 4 acute GVHD is slightly improving in the over time slight, but still it's a very big issue and carry a big mortality. In the treatment, in 2015, we start the ruxolitinib studies. And as Dr. Sharouk mentioned, this was very encouraging by the retrospective analysis, which showed marvelous change, up to 79% mortality survival gain in 6 months. And that's why Novartis did this REACH 1, 2, 3. In King Faisal, we participate in REACH 2 and REACH 3. REACH 2 for the acute, REACH 3 for the chronic. And they defined the steroid refractory in acute GVHD that if there is any progression of the disease within a full dose of 2 milligrams per kg per day within 3 to 5 days, this is a refractory or failure, and you can quickly start the second line. If there is failure to improve within 7 days, like not a progression, but no improvement, 7 days enough to shift to different one. And if there is incomplete response by 28 days, this is also eligible to say that this is the steroid refractory. Dependence, if you cannot taper, and intolerance if there is emergence toxicity. So this is the REACH 2 that led to the FDA approval of ruxolitinib in end of 2019. It was published in the New England of Journal, and the study was randomizing ruxolitinib 10 BID plus steroid plus they allow calcineurin inhibitors. And in the other side, there was also, they allow steroid with the best available therapy in the center. In our center, King Faisal Riyadh, we put ECP as a BAT at that study. They allow transfer or shift to the ruxolitinib arm. By the way, we allowed platelet to be, platelet must be more than 20, and we start with 10 BID if the platelet more than 20. And of course, the key secondary endpoint was the durable effect by 6 months. The results showed overall response of 62% compared to 39%. It was durable in around 40%. And when they studied the duration of failure-free survival, they found that ruxolitinib gained 5 months, and in the controlled study, it was only 1 month. It was reasonable outcome. And after this study, if you can keep a secret, we keep using, before even the approval, we used the ruxolitinib from the Novartis supply of the myelofibrosis in our hospital. And the pharmacy was very angry that we have really to help the patient, the mortality rate high as we know. Our ECP started in King Faisal. The extracorporeal photopheresis was started long time, but it interrupted and only resumed in around 2016, if I remember correctly. So as Dr. Sharouk mentioned, we not know how it exactly works, but it's a relatively safe procedure. There is no immunosuppression. Patient will stay for 2 hours each session. They will use the same IV in the arm, the vein, peripheral most of the time, but unfortunately some of the patients need a Burma cath because of poor IV access, and the patient will stay for 2 hours. This is the first session, and because it's 2 hours, we're not sure how much of the blood treated by the ultraviolet stream. So we give usually back-to-back test, and they come another day. So for example, Monday, Tuesday, or Tuesday, Wednesday, and he said for another 2 hours. We use this in acute. We use it on a weekly basis, 2 sessions per week. And if some patient is very sick, we use 3 sessions per week initially till 8 sessions, then we shift to a weekly or twice weekly. What is the clinical data? There is multiple study about ECP. Here there is, for example, 12, which was published. Out of those 12, only 3 or 4 prospective, and you can see that the overall response is variable from 60 to 80, I would say. And the overall survival is variable. I chose 3 or 4 study to highlight. This is was published in 2002. It was a retrospective study of 31 study of out of those 31 study, 11 acute GVHD, and the number was in total 76 patients. The overall survival was 53. And if you go to the detail, which is very important, and what is matter really for us, not the liver, which is work, but not the skin, is really the gut. This is the organ that carry the most mortality. So I focus on that. So it was like 54% here, it was 61% here. They use the same protocol that we are using, the twice weekly, every 1 to 2 weeks initially, and then they shift. And here, for example, also in this study, which was again retrospective, but it shows in the gut, in the 75 here, some of them, they are reporting both upper and lower, but most of the centers are only including lower in the study. There is a meta-analysis, which is important to do, only accepted the prospective trial. So they study or identify 378 trial. Out of them, only 48 were selected because others were not involving ECP or not prospective. From the 48, they exclude 39, and then they found only 9 study. Out of those 9 study, only 1 is randomized clinical controlled trial, 8 were single arm. In those study, the overall response was around 69%, the complete response 53%, and if you go by organ, the liver was 84%, the gut was 65%, here liver were 55%. There is, of course, a challenge and limitation, but this is what only reported. So now, what is the treatment option available for a second line? So in any steroid refractory acute GVHD, we can use, before we were using alemtuzumab, now it's not available. Alpha-1 antitrypsin, there was a study about it, the ATG player, the basiliximab in very sick acute gut we used. Of course, the calcineurin inhibitors, the etanercept, the ECP, infliximab that also we use in very refractory gut GVHD, sirolimus, which is Dr. Shahrukh preferred medication, MMF, pentostatin, rocatinib, and there is ongoing trial. If you want to optimize, and my topic today, how to optimize the second line, first, you have to start from the beginning, from the donor selection. We need more artificial intelligence help maybe in this matter to choose the proper donor with less GVHD, and this is a lot of work ongoing in this matter. Also, the prophylaxis. So start with the prevention. If you start with the prevention, this will give you a significant improvement. And in different institutes, there is different regimen. Even in North America and Europe, there is no one regimen for transplant. People are moving now to the post-transplant cyclophosphamide. In our center, we are doing now a randomized study, which wait to complete 80 patients. This would give an idea because really there is lack of studies. The CIBMTR data start to do the studies. They call it Progress. It's a phase 2. It was covering the 7 and 8 out of 8 HLA matched donor, and including only reduced initially And then when they choose one of the arms, which is the post-transplant BTCY, now they are doing another study to confirm the results. And for Progress 2, which is a phase 3 study between 2013 2021, they only choose the 8 out of 8 matched and myeloablative regimen only, and they found that still tacrolimus methotrexate, which we use in King Faisal and in Saudi Arabia in general, still this is the standard therapy. And they did like a recommendation that in matched and unmatched, in matched, related and unrelated donor, the prophylaxis should include calcineurin with antimetabolite like methotrexate, and both tacrolimus cyclosporine roughly equivalent. The methotrexate recommended in the myeloablative, and the ATG recommended if there is a match unrelated donor, which we use as well. The MMF can replace methotrexate for myeloablative, and this is lower quality evidence and no supported data. The MMF is recommended in patients receiving non-MAC condition and RIC. How to improve? Also by early detection. So early detection from the biomarkers, there's a lot of work in the biomarkers. They identify for now 2 in the acute setting, which released from the, when there is a CRIP damage in the gut GVHD, the REG3 alpha and the ST2 were studied, and you can measure this with the liquid biopsy. And they are now doing a long-term follow-up for those patients, trying to identify if those biomarkers can help. And one of the early publication about this, that this biomarker can put you on a GVHD risk, so it can identify the non-relapse mortality in those 3 categories of GVHD, and it can tell you that your development of GVHD put you on the risk of non-relapse mortality, and the overall survival as well was validated with those 2 biomarkers. Also, those biomarkers helped in putting you on the same grade. So if you have grade 2, with doing the biomarker, still you can see that it's all grade 2, but you can see that there is a difference between the grade 2 itself. So this is also encouraging that in the future, we will identify severity and we detect early the disease. There is a lot of novel ongoing study about acute GVHD. We're not sure what will be positive or what will show really. And the future, I think, in my opinion, that it will be the combination, maybe 3 medication. In our current practice, we used always ECP with ruxolitinib based on data demonstrated in number of study. Still, there is no final conclusion on those, but really all the BI that we discuss with them, they say that the combination of ECP and ruxolitinib for the time being is the best outcome. In conclusion, still there is high unmet medical need. The steroid still the standard, but only 50% responded. There is limited second-line options and poor prognosis. ACP safe, and a number of guidelines they recommended as a second line. Also, there is ongoing study for ACP with combined with ruxolitinib, and also there is now a study that put ECP as a first line of treatment in the acute. They think because it needs time to work, why not to start very early, even before the steroid refractory. Thank you very much, and I am happy to receive questions.
Thank you so much for the excellent presentation, Dr. Marwan. We have learned a lot. I would like to open the floor for questions, if anyone would argue against using ECP rituximab as a first line option, or like to use different thing in their centers? You go, Dr. Saad.
It's just a comment from a pediatric BMT perspective. We found it rather than refractoriness, it's in compliance and tolerability in most of our patients. This is from our experience.
Totally agree, because
It's
ruxolitinib have the rebound effect. So if you stop, or the kids or the mother not keen to give it in a BID on the proper dosing, or if there is, because it's relatively expensive medications, so the pharmacy will give only 1 month, and then their appointment is after like 10 days, they will wait. And this is bad. So the moment we prescribe ruxolitinib, we should educate the mother or the patient that there is a rebound effect. You shouldn't stop. You have, even if you want to stop, you have to taper. There is also a challenge about the infection, and we saw some zoster, active zoster, or reactivation of herpes zoster and some other infection, and that's why we are encouraging for adults to do the Shingrix vaccine for those patients.
Thank you, Dr. Marwan, for this excellent presentation. Again, when you consider the use of ECP and Jakavi for chronic graft-versus disease, is it an option for all patients or for selected patients?
In chronic, you mean? So usually we start with the steroid and we give the tacrolimus or imatinib in some of them. And if there is no significant improvement within 12 weeks, we consider ruxolitinib. Some of the patient you can tell from the beginning that they present for you late. So in those patients, we not wait for those duration. We quickly initiate ruxolitinib, give another 2 months maybe with ruxolitinib, and initiate ECP. Some of the patient again will have sclerotic skin, lung GVHD, so I will not wait for ruxolitinib alone, and I will start quickly ECP with ruxolitinib and try to taper steroid in those patients, because I know that they will require long duration of therapy.
Thank you so much, Dr. Marwan. I have one last question from my own point of view. It's about ocular GVHD, where it actually sometimes requires an interested ophthalmologist to be working in the same center, who has more, like, let's say, more accommodation to our patients. Do you have any take into that perspective?
Exactly. This is very important point. Unfortunately, when it's only the ocular, you are giving your patient systematic therapy, you are producing side effect where they can help in the ocular. We used to have Professor Tabara and King Faisal who doing the ductal, so the lacrimal, sorry, duct closure or block, and sometimes even cautery if this is not work. Nowadays, they are giving, actually since 2012, when I was in Princess Margaret, they were doing the albumin eye drops, which help a lot. And nowadays, they are doing in King Khalid Eye Specialist Hospital in Riyadh, they are giving the fresh frozen, the frozen plasma from the same patient. And they get, this is enough for 1 week. They give him a bottle to put in the fridge. They can use it for a whole 1 week, and the patient see significant improvement. The other problem that sometimes the problem not only GVHD, like patient will keep saying, and I have blurred vision, so you increase the immunosuppression, and then when the ophthalmologist examine, 2 or 3 of my patients have cataract, bilateral cataract, and this what really make the vision issue to them. So when they did the surgery, the symptoms decreased significantly. So I agree with you totally. We need specific multidisciplinary team that you deal with. He is expert, and he's willing to accommodate and help. Your point is very valid.
Thank you so much. By this, we conclude this. Oh, we have one single question, sorry.
Assalamu alaikum. This is Marwa Al-Hadidi, clinical pharmacist. Dr. Marwan, I would like to ask about the incidence of TMA with immune suppression. Which immune suppression having the highest incidence of TMA, and what is the preferred immune suppression if patient has developed TMA with cyclosporine or calcineurin inhibitors? Thank you.
So we saw with both cyclosporine and tacrolimus. To be honest, I feel that the cyclosporine induce was lighter and very easy to manage. We only hold the cyclosporine. On the tacrolimus, although it's very rare, and we see like we are doing around 200 allogenic stem cell transplant per year, and we saw only 1 or 2 secondary TMA to tacrolimus, because now we shift completely to tacrolimus. And this is also easy to manage, and only maybe 1 every few years would require plasma exchange. I don't think that they need plasma exchange. I think we overdo. And sirolimus is relatively safe. I know that there is a study say that there is a cross indication, but sometimes when we put them in sirolimus, this will not recur.
I think by this we can conclude the session. Thank you so much, Dr. Marwan, for your great participation. Thank you.
Thank you. Assalam.
Awesome. And now it's my pleasure to introduce our colleague, Dr. Badr Al-Ahmari, adult consultant of hematology and stem cell transplant from National Guard Hospital, Riyadh. And today he will share with us one of the challenging cases in graft-versus-host disease. Dr. Badr, the floor is yours.
Assalamu alaikum wa rahmatullah. Do you hear me?
Yes.
Yes, thank you, Dr. Nahla, for the introduction. And I would like to thank the organizers for the invitation to this excellent conference. It's a pleasure to be with the expert in the field of stem cell transplant. Can I share the slides from my side?
I believe yes.
Okay, let me try this. I hope it is clear now.
Yes, it is.
All right. So I was given the assignment to present a challenging case, challenging GVHD case, and it's a pleasure to do so. I have this gentleman who's 26-year-old, not known to have any chronic illness, diagnosed in 2015 at a local hospital with classical Hodgkin lymphoma, nodular sclerosis subtype, stage 3B bulky. His initial lymphoma management, he received 6-cycle ABVD. He responded initially, but at the end of treatment, there was some evidence of disease progression. So he was given 2 cycles of ESHAP, did not respond. Unfortunately, then he was referred for stem cell transplant, autologous stem cell transplant. At the transplant center, he received IGIV 3-cycle. Unfortunately, patient still showing evidence of disease progression and was considered for palliative care. His care was transferred to our hospital in the late 2016. And at that time, he received, we give him bendamustine, brentuximab vedotin, 3 cycles. He showed for the first time a response, and he showed some partial response, which really a deep response, some residual disease by PET scan, including some lung nodules. So he underwent autologous stem cell transplant with beam conditioning, followed by brentuximab maintenance. However, he showed disease progression at cycle 10. For some reason, I cannot control the slides. Okay. Let's see this. All right. So subsequently, because of his disease progression, he received nivolumab up to 15 cycle. During the course of treatment, he actually showed remarkable responses, and he was almost near complete remission after 15 cycles. We identify a donor for him, which was matched sibling donor, and we decided to go for allogeneic transplant, thinking that this is the best time for him to go for allogeneic transplant if we think about cure for him. So in 2018, he received his allogeneic transplant from fully matched donor, sibling, and the conditioning was Flumil with the GVHD prophylaxis standard CNI plus methotrexate. So the transplant procedure was well tolerated, engrafted successfully, and discharged home on tacrolimus on day plus 20. So at day plus 35, he was hospitalized with large amount of diarrhea, more than 1.5 liter, and with a severe abdominal pain and some skin macular papular rash occupying around 50% PSA. So he was managed initially as a grade 4 acute GVHD with IV methylprednisone, 2 milligram per kg, optimizing his tacrolimus as well. He underwent sigmoidoscopy, and biopsy was consistent actually with a clear pathological feature of acute GVHD, and immunostain was also positive for CMV colitis, which is a challenging situation when you have GVHD and colitis at the same time. So management of colitis, CMV colitis was started at the same time. He was started also on TPN as per our institutional GVHD nutritional protocol. So at day 7 after the steroid initiation, he showed minimum response. His responses was not optimum, and it was also at the same time confusing that this is due to his area currently predominantly due to CMV colitis or due to the GVHD. However, we elected to start ruxolitinib at this time with the aim to minimize the steroid. So ruxolitinib was started. And during the course, also, unfortunately, he developed calcium inhibitor-induced thrombotic microangiopathy, which was severe enough to make us stopping his FK because his creatinine was high and he was showing a lot of proteinuria at that time. So we opt to taper down his tacrolimus. And as we know, that thrombotic microangiopathy are highly associated with acute GVHD. Based on multiple study, but this is one of the remarkable landmark study that showed highly association of TMA with acute GVHD. So luckily, over the next few weeks, we were able to taper off his TPN because the diarrhea was less than 500, and his diet was advanced as per GVHD diet nutritional protocol. His GI GVHD and CMV colitis recovered 6 weeks after the diagnosis. He was hospitalized during the whole this period. Of course, subsequently, he developed multiple complications. One of it, like we found that he has CMV esophagitis, resulted in esophageal perforation, evident in CT scan that showing thickening of the distal esophagus and posterior mediastinum, pneumomediastinum at that time. With a high CMV titer, so this make us restarting his CMV treatment with foscarnet and IVIG cytogam. During his bronchohospitalization, also developed tachypnea, hypoxia requiring oxygen. CT scan showed he has evidence of pneumonia. However, after consultation with pulmonary infectious disease, they want really to do bronchoscopy and to proceed with bronchoalveolar lavage. The pulmonologist, he actually did a transbronchial biopsy, which led to development of right pneumothorax at that time. The BAL was negative, and even the transbronchial biopsy was non-conclusive at that time. However, Alhamdulillah, he was successfully treated with antibiotics, and we were able to discharge him 5 months after hospitalization. So he was admitted initially with GVHD, CMV colitis, and he developed this multiple complicated course, and we were able to discharge him home after that. He was followed in the clinic while in a table dose of Jakafi. We were able to achieve 5 milligram daily while on infection prophylaxis. Few weeks after discharge, which is almost now, he's 7 months post-transplant. He started to have exertional dyspnea, unexplained. CT scan showed resolution of his previous pneumonia with no evidence of air trapping or any evidence of new infection. So we did a PFT and we found that he's having very low FFP1 at 20%. Total lung capacity was 130 and residual volume 400, very high. And at that time also he had some dry eye symptoms and some mouth manifestation. He was managed at that time with topical management. So we scored him 3 lung NIH at that time, and we start actually steroid 1 mg per kg for him, and we start the FAM protocol, which is the Symbicort with azithromycin and Montelukast. Of course, probably 2 to 3 weeks after this initiation of treatment, he actually presented with new onset respiratory symptoms, and we found that he had spontaneous pneumothorax at this time, which was optimize the treatment. Do you hear me?
Yes, now we can hear you. Your voice was interrupted.
In the mid 2019, when we initiated the ACB, this was his lung, which showing the evidence of, you can see the expiratory and inspiratory phase. There is no clear picture of air trapping, but we have this bronchiectatic changes in the right side, right middle lobe, which was there since before the autologous transplant, because he has an avidity at that time in the PET scan, which was consistent with his disease involving this area. And post-treatment, he developed bronchiectatic changes. And you can see there's some pneumothorax in this picture. So ACB was started because it's available on our institution, and we prefer it as a second line always. There are some, I think Dr. Hashmi already discussed in detail the data related to ACP. But I want to highlight one of the meta-analysis, which he was actually the author of this meta-analysis, involving more than 500 patients, including 18 study, and showing that the response rate in the lung around 48%. And there is another study that showed, it was match control cohort, showing an excellent response in terms of symptom-wise, but also improvement in the overall survival based on multivariate analysis. So his symptoms improved significantly. BFT 3 months later showed no change from the baseline. 6-minute walk was tolerated, no desaturation. His subsequent chest CT started showing some feature of air trapping actually, but it was minimum. So he continued ACP for a total of 12 to 10 months. However, this was discontinued because of multiple catheter-related issues and multiple reinsertions. So we elected to stop his ACP. He continued in Jakafi with minimum steroid use, and BFT to continue to be the same. His function status improved significantly, and his symptoms also improved. He started to resume his college study, and then subsequently during the pandemic, we start to minimize his clinic visit, and we keep monitoring his BFT. However, we start to find that in 6-minute walk test, he's having some desaturation at that time, although mild. So we did a CT scan, which showed actual persistence of his bronchiolitis obliterans picture. And we are now 2 years post transplant. And this was his CT scan at that time. You can see the expiratory and inspiratory images. In your left side, the expiratory showing clearly some area, mosaic pattern and some area of air trapping. So his case was discussed in the multi-D meeting with pulmonary and thoracic surgery team. And the idea was whether do we need to consider lung biopsy? Are we dealing with a different pathology in this situation, especially as this bronchiectatic changes since before the transplant? So we decided not to go for this procedure because it's hazardous and it carries some risk, and he had previous recurrent pneumothorax. So at this time we decided to, because maybe he's progressing over while on Jakafi, so we stopped the Jakafi and we initiated imatinib. And surprisingly, he was actually improving with imatinib, and subjectively, and over the next few weeks to months, he improved with the use of imatinib. He completed his college study, and he actually got married. So he kind of showing some excellent responses based on subjectively based on the response to imatinib. So imatinib was tested in multiple, was reported in multiple retrospective data showing that there are good responses with the imatinib use, can reach up to 35% in one of the retrospective studies. And those who receive imatinib, and when they did the match analysis, showing improvement in overall survival even. And lately, like 2 years ago, a multi-center phase 2 study was published showing that an overall response rate of lung GVHD of around 25%. So over the next few years, like 2021, 2022, his subsequent 6-minute walk showed an improvement without desaturation, and his BFT were completely stable, and he's symptomatic-wise, he is stable, although he's not 100% symptoms-free, but he's not showing any progression. And he never required actually any admission since 2019, the admission for the acute GVHD at that time. He doesn't have any recurrent infections. He's having normal immunoglobulin, normal lymphocyte subset. His vaccination are up to date, showing full donor chimerism. His latest lymphoma assessment actually was showing no evidence of disease in 2022. And this is one of his latest images showing clearly a picture of air trapping. You can see it in your left side in the expiratory phase. He has maintaining on his current medication, including the imatinib, as I mentioned, and the FAM protocol, but he's not on steroid. He's following regularly with our pulmonary, because we have a pulmonary SCT clinic, combined clinic with the SCT program, where we follow those patients, and he underwent pulmonary rehabilitation program. We found that in the late 2022, his 6-minute walk, again, showing some desaturation. Without changing in his baseline BFT, and his also CT chest did not show any significant changes or any evidence of ILD or any other finding. There was no other sign of other involvement of organ in terms of chronic GVHD. His respiratory symptoms were not that significant. His latest BFT showing FFV1 of 24 with a ratio of 55%, total lung capacity 103, and residual volume 290. We discussed in an MTD meeting, and our colleague in pulmonary and thoracic surgery, they actually recommend highly to refer him for lung transplant. So we actually refer him for lung transplant, and he's currently on the waiting list, basically because of his respiratory symptoms that are not progressive, and also based on his intermittent desaturation. Actually, we repeated the 6-minute walk later on. It was actually did not show that significant desaturation again. Quick slides about POS. It's characterized by new onset airflow limitation after allogenic transplant, and diagnosis highly associated with increased risk of death, impairment of quality of life. There are multiple risk factors that can lead to a POS. One of them, some of them are including conditioning regimen, the use of busulfan, APO mismatch, the use of peripheral blood as a source of stem cells, but other protective factors, including the use of ATG, those who received cord blood transplant, and those who received reduced intensity conditioning regimen. These are the criteria, diagnostic criteria for POS. And in terms of management, we already discussed some agent, and Dr. Hashmi already highlighted some important agent. Palmosudil, one of those agents that in one of the study, when they pulled the data from early phase studies and the latest phase 2 study, showing that there are good responses for management or for those who develop lung GVHD, but all these responses are only limited to those in early stage disease and did not help those who had advanced stage disease. There are some promising agents, including abatacept. Abatacept, we know that is currently approved as for GVHD prophylaxis. And it is a selective agent that modulates the T cell activation and block the co-stimulation. In one retrospective data, it was for those with refractory chronic GVHD, showing promising data, although small number retrospective study, but the response was, overall response was 89%. And 6 patients has improvement in the lung severity score, and 4 patients showed stabilizing the lung function, and 3 patients show both actually improvement in the score and stabilization of the lung function. So there are prospective studies now testing this agent in the chronic GVHD setting. Axatilimab was published recently in JCO early phase study. It's a clone stimulating factor 1 receptor antibody. That actually in that study showed a partial response of 40% specifically for lung GVHD patients who failed multiple lines of therapy. With regard to lung transplant, so the outcome of lung transplant post allogenic transplant were compared to other recipients of lung transplant outside the setting of allogenic transplant, and the overall survival was equivalent. 1 and 5 year overall survival was equivalent between both study, and which was a match control study. Another retrospective study also showed the same, with a 5-year survival of 67%. And what's important here that one factor was common between studies, which is recipient of lung transplant within 2 years after allogenic transplant was actually associated with higher rate of mortality. So selection criteria for transplant candidate, this is based solely in the International Society of Heart and Lung Transplantation, which stating a clear absolute contraindication, which is recent history of malignancy. So they want at least 2 years of malignancy-free interval in general, but there are specific tumors that need at least 5 years. One of them are hematological malignancy. But again, this number really is not a magic number and can be negotiable, because this is not really based on solid evidence. Of course, if there is any chronic infection that are poorly controlled, consider also an absolute contraindication. And the indication for lung transplant actually based on how much predicted survival after recipient of the lung transplant, how much they're going to live, what's the chance to live, for example, 1 year, 2 years, and 3 years. And based on that, they will decide whether the patient is candidate for lung transplant or not. So with that, I conclude, and I'm happy to take any questions.
Thank you so much, Dr. Badr, for sharing this challenging case. Any questions? I believe because we ran out of the time, I would like to thank you for your great contribution, and see you next year. Thanks so much.
Have a good day. Bye.
Assalamu alaikum Jameen. Okay. My name is Binyam Usman. I'm one of the hematology consultants working in King Faisal Hospital in Jeddah. Welcome to the conference once again. We have three exciting talks lined up by our international speakers. And this is going to be the quality symposium. And there will be three talks. And as you know, the importance of quality management is increasing in cellular therapy and bone marrow transplantation. For more than 20 years, transplant physicians all over the world have been using FACT and JASI standards for as their guidelines and framework. So the first talk would be by Prof. Dr. Christoph Schade, who's a senior physician and head of cellular therapy and stem cell transplant in the University of Cologne. Dr. Mohammed Bayoumi sends his regards and thanks for Nick and Prof. Schade for delivering these talks. And I would invite Professor Schade to start his talk now on CAR T-cell from a management and organizational perspective, from a point of view of the clinical program director. So the floor is yours, Prof. Schade.
Hello, thank you very much for the kind invitation. I hope that you can hear and see me well. And,
yes, we can hear you and see you very well.
Excellent. So many thanks for this kind invitation. I would love to be on site, but obviously time is limited. So we benefit from this possibility to share thoughts and ideas online. I try to share my slides. So I think you can see my slides now.
We can see the slides and it's in slide mode now.
Excellent. So yes, just to tell you about my background, we are here in Cologne, the, let's say, middle of Europe, halfway between Paris and Berlin. It's a busy area, many inhabitants here in this area to care for. So we cover about 4 million inhabitants in this region. And we are a big university hospital. And I keep saying by now we have 3 different cell therapy programs. So autologous transplantation is obviously a bread and butter work. We do between 120, 130 a year. Allotransplant just below 100 per year, very stably over the years. And as a third line, I would say CAR T-cell therapy is really emerging. And if I project into the future, I would say we will have a slight decrease in autologous transplantation and an increase in CAR T-cell therapy. So I guess it will be the same size of programs. So I think we have to think of the 3 cell therapies as equal partners, really. And I'm lucky to really have all this in my program. So we have a seamless transition between the therapies, because many patients have an autologous transplant before or after CAR T-cell therapy. Or if you think of ALL patients, they might have an allotransplant, then at relapse go for CAR T-cell therapy. So many patients have several cell therapies in their career. And so that's why I think it's very useful to have this in one program. And as you can see, we have to deal with 4 different companies offering us 6 different CAR T-cell products commercially available. So we're one of the centers in Germany who have access to all these agents, which is great, but also quite time-consuming. So when we think of a standard cellular therapy, a routine therapy, I would start with, as I said, the bread and butter. Autologous stem cell transplant for us is really quite straightforward because we have our own apheresis under the program. We have the lab under our direction, so there's no blood bank involved. Everything is in one team. So we just check the patient, the indication, the patient fitness. Venous access obviously is a important issue. to check for the apheresis. Then we have to be sure that the infectious disease markers are present. We have to use our own biology lab because this is approved by the authorities as our infectious disease markers, and it must be within 30 days. So if the patient had HIV markers 31 days ago, we have to repeat this. So this is quite strict. It's regulatory work, but I mean, everybody knows this. It's really in our DNA by now. And then all we have to do is really schedule and perform the apheresis. We have to have approval for that apheresis, both on the local side to be able to perform it, and also from the national side. A stem cell product is a drug, so we need permission to produce and also apply this drug from our national regulators. Then the cryopreservation is just the lab next door to the apheresis. So the bag goes to the lab. So this is very, very straightforward. It goes to the storage area. And then we have this available and just have to really watch for the release of the product. And then the nurses have to schedule the high-dose therapy and transplantation. So this is about a 3 to 4 week inpatient stay. And then afterwards, we look after the patient for about 3 months. So this whole package is really I would say 6 month package. And then the patients go back to their referring physician. So this is really a routine workup, very well established. And so this is where I come from, really, thinking of CAR T-cell therapy. And obviously, how can we now embark on CAR T-cell therapy? And we've been through this from 2016 on with the first studies. And so over the last years, I've spent a lot of time being a transplanter, but actually I was more a CAR T-cell therapist than a transplanter because it's so time consuming to discuss all these things. So obviously the starting point very often is clinical study. So the company comes to the center and things are, I would say, quite straightforward. It's still complicated in the details, but the framework is quite clear. There's a study protocol with all the details and the apheresis and everything is part of the study protocol. The protocol as a package is approved by the authorities. And with this protocol, also the product is approved. So it's an approved investigational agent. So everything is covered in one field of authority. And then we have one clinical trial agreement between the university hospital and the sponsor. So everything is in that agreement, data protection and budget and everything, responsibilities. So again, this is just one body of contract and everything is in there. And so it's really a two-sided program. There's the sponsor and the study side. So everything is really covered in this package. So you might think, okay, we just have to transit now from using a product in a study to just using this in the clinical routine. And so it sounds easy, but in fact, in our experience, it was really a very time-consuming and lengthy process. And so we have to discuss many aspects. So what is the apheresis? Is this just part of the patient care, or is this really production of a drug? Do we have approval to make this apheresis? So in our hands, we need to have approval to make apheresis. And this might be really specific for the indication. It might be specific for the product. It might be generic for CAR T cells. So allophoresis for CAR T cell production, or it could be more generic. And I'm really, at the moment, we have a CAR T cell apheresis approval. And I plea to make this broader to say apheresis for immune therapy, because then everything is included like T cells or monocytes or so. But at the moment, it's quite limited to CAR T cells. But you have to check that, obviously. Am I allowed to make apheresis products and hand them over to other companies? Then plenty of contracts to organize, quality agreements, apheresis agreements, delivery, who's delivering, where is it sent, and so on. And then accounting. I mean, this takes quite some time also to check all these flows of invoices and checks and so on. We have plenty of hospital structures to implement, to have a coordination, quality management. The delivery must be organized, storage must be organized. So plenty of things to think of. And this is obviously very different from hospital to hospital. Even in one country like Germany, every company has to go to every hospital and check their details. And then if you look at several countries, obviously there's so much granularity. So this is a very difficult process because big pharma companies with a global perspective have to talk to local hospitals to think what's the detail about delivery and storage and so on. So for this, the pharma companies have designed onboarding processes which may or may not fit to your structure, to your hospital. Again, this mostly is designed in the US and considers US standards. And so this process has to really be tailored to the local needs. We have to do dry runs sometimes, or mostly, so to send mock shipments with a mock apheresis product to check the courier systems and the documentation and so on. So this is also quite time consuming. And then we have the pleasure to have initial and repetitive audits by every pharma company. So again, this needs to be prepared and performed. This takes a whole day. And so, you have to think about that, how to organize this. And then when something goes wrong, and this is Murphy's Law, everything can go wrong in a complex process. So these CAPA processes need to be handled. So either we think something was wrong, a labeling was not correct, or a seal was broken from a transport case, or the pharma company says, well, your apheresis was not good, we had low cell count. So there's plenty of paperwork to do in both directions. So plenty of things to think of and to organize. So in the beginning, we really try to make things clear with the pharma companies, saying, okay, now you come with your ideas based on US experience, but we have to really make things clear as a framework. So what are we talking about? So we said very clearly, look, apheresis, in our hands, we think of it as part of patient care. And certainly it's not a contract service. We're not contracting the apheresis. You could do that. A blood bank might think like that, but we said we are clinicians, we are the caring physician for the patient, so we cannot perform a contract service on our own patient. So this was one of the kind of corner points. Then the apheresis product, at least in German legislation, is part of the body of the patient, and it remains in the ownership of the patient. We're handing the apheresis product, we're sending it away, but the patient needs to authorize each step. And we're just doing this on the demand of the patient, but we never can sell this product anywhere. We're not owning it. So it's really not a product, but it's the extended part of the patient's body. Then we think that apheresis should be paid by the health insurance because we believe it's part of the patient care. However, at the moment, that's not the case. So the German view, the administrative view, is that this is part of manufacturing. So at the moment, we have to ask the pharma companies to pay for the cost, because we say, so far we have not been successful in getting this cost paid back by the health insurance. So we need this money from pharma, but I think it would be, for me, much more clear to have this paid by the health insurance. Then once the card product is manufactured, then it's a transition, a new product is generated. So this now is in the ownership of the pharmaceutical company and is sold to us. So that now it becomes a merchandise, let's say, and it's sold to us by the pharma company. And if we audit it and the invoice comes in, then we have to pay it. I mean, this is really quite clear, and this is a big burden for our budget, as you can imagine. And then many times we have a card product that are out of specification, where the company says, well, the product is okay, everything is fine, but a small detail was slightly above or below a certain threshold, so it cannot be released as in spec, so it's out of spec. Well, do you want still to have it? And since it's this patient-specific product, for ethical reasons, we have to claim, please send the product to us so we can give it to the patient if we think it's safe. But certainly, at least that's my position, or our hospital's position, this is not a product that can be sold. It's not produced in the way it should be produced. There's an error in this product, let's say, so it has to be delivered, but free of charge. So this is an ongoing discussion with some companies, but we think really that a drug product can only be marketed if it's within spec. Otherwise, it can just be delivered if the physician signs the need for this and the patient wants it. So, but this can be different from country to country. Then we have to think of many, many standards. So we have the national approval, the European approval, obviously for products. We need manufacturing permission if we don't want to make local manufacturing or apheresis as a part of a manufacturing process. Obviously, we talked about good manufacturing practice, JC standards. We have a national health technology assessment organizations who define quality guidelines and standards. We have medical guidelines. Let's say I'm writing the myeloma guidelines. So obviously now CAR T-cell therapy is a major part of this new version. We have reimbursement standards where advisors to the health insurances say, okay, what's the indication and what's the requirement to perform a CAR T-cell therapy to be able to have reimbursement. And then obviously pharma is very keen to bombard us with documents regarding their products. And obviously, because we have signed contracts in the beginning, we have to comply with this. So we have to teach risk management programs to our physicians and so on. So plenty of things that are really a burden for us. And then we have to also think of the general expectations in the public. So patient groups might say, we need more CAR T cells. We want to have sequential CAR T cell therapies. We want to have broader indication. Politics might say we need more advanced medicine. We want to have high-tech medicine. Or they might say this is all too expensive. You know, we are spending too much money on single patients, and this is documented. So small details. Obviously, the patient was seen by a doctor, but he failed to write down a sentence in the patient file. So this was a finding. Then the pharmacist must be involved with all the ordering, delivery, documentation, accounting. So this is quite a heavy job because the budgets are really high. If you think of 300,000 or 400,000 euro per product, and you take this times 100, this is a large sum per year to handle. Then obviously apheresis and lab staff must be really well trained and fit. Then we are working on inpatient, and especially now we're working on outpatient care teams to be able to maybe deliver at least part of the therapy for CAR T-cell in an outpatient setting. Documentation teams are important, quality management, accounting. Your legal department must be really understanding this business of CAR T-cells with the manufacturing part and the application part. And then training of team members and audits, as I mentioned, is a very time-consuming task. Communication is enormous around CAR T-cells. I just made some examples here how the team talks to the physicians and the patients, and coordinators have to talk to patients and feedback to the physicians, and pharma is contacting physicians or coordinators, or pharma might really interact directly with the lab or the apheresis team, and then they come back to me and saying, okay, this company called and they had this remark about our last apheresis. Then the quality management needs to interact with coordinators, with physicians, pharmacy, accounting, you know. So you see, it's plenty of communication, plenty of emails, and sometimes really an email doesn't get to the person that needs this email, but to 7 other persons. So we're currently working very hard to find ways to have single points of contact. So really to organize things in a more strict way. So information is really passed to one person or one team and not spread by email to maybe 20 people, and nobody is then really in charge and nobody takes notice of this email. And so we are thinking and establishing a cell therapy manager. And actually Nick van Zinderen is as our cell therapy manager, who is more and more really trying to focus things and to, let's say, to filter information. So this is my desire, really, to have plenty of involved parties, and then this really should feed to maybe 2 points of contact. Is it a patient issue? Then it goes to the coordinators, or is it a general cell therapy issue? A quality issue, an audit to be planned, you know, a CAPA process, then this should really go to the therapy manager. And then so we have a kind of filtering of information, of tasks, and then we can really selectively put this into the CAR T team and really work on this and then feed back to these single points of contact so they can go back to their contacts. So I think this is a tremendous help really to channel information and not to lose information and not to keep 10 people busy on the same task because they work in parallel, because they've been contacted by let's say a pharma company in parallel, and then they all think, oh, I should do this, and then they do the same thing in parallel. So what is my wish list? Where do I want to go? So I really dream of having an easy slot booking. So not going through planning discussions and planning meetings and say, can I have a slot in 4 or 6 weeks, but rather make it like a stem cell apheresis 1 or 2 weeks in advance. I see the patient, I see the venous status, and as we say, go ahead, let's have the apheresis in 1 or 2 weeks. And so we check our apheresis team, we check the pharma company, and then this is easily booked in an electronic calendar. But this obviously needs capacities, and if we talk with international colleagues, and like in this conference here, we have to think of the global need, not only at our hospital level or the national level. At the moment, I think the capacities are much too restricted. We need really to cover a global need for cellular therapy. Obviously, I would love to have very early communication of delivery date or production problems, so we can really plan the patient accordingly, not waiting 6 weeks and then hear, oh, there's a problem with the product. And this is obviously linked to transparency. So I would love to really be able to see the product develop and have transparency on the production. At the moment, really, we have insight into production problems only in the out of specification products. So then the company is kind of forced to involve us and to tell us about the production and the checkpoints. But I keep asking them, can we have this on a general level? Can't we just have a quarterly review of our products and see how they're performed in the lab? But then obviously this is about protecting the production and the knowledge of the production, so companies don't like us looking into their pots really. And but I think in this field we would need a more transparent communication. Then obviously there's not only parallel communication, but there's always this kind of plenty of ways to contact us. So we have electronic platforms where we have ordering platforms and feedback on there, or we get emails or phone calls. And so mostly we have these phone calls like, did you see on the platform there's this remark, or did you see my email? And so I would really focus this to say, okay, choose a platform so we know everything that comes from your side, from pharma's side, goes through a platform or through an email, but not everything in parallel. Then obviously as a clinician, I would love to be in charge of my own standards, or have, let's say, national or international, like EBMT standards defined by clinicians. I don't like to see that pharma companies come up with clinical recommendations. This is currently the case. We have these risk management programs from every company, and these are kind of detailed recommendation about how to handle complications on. But this is really confusing, and my staff is really asking me, why do you show me different things about the same issues from each company? Can't we have just our own standard? And we have our own standard, in fact. So we have a clinical standard for everything, but I'm forced currently, at least, to provide information given to me by the companies. And also, I think insurance companies should not be in charge of defining clinical standards. So we need, I think, to push back all these influences, both from pharma companies, but also from the insurance side, to really have clinical standards defined by clinicians. And then again, I said training should be a clinical task. So I should be in charge as a team leader to teach my team, and it should not be a task of pharmaceutical companies. And having just had the JC audit a few weeks ago, I mean, this is a lot of work to prepare, and we had spent 2 days with the inspectors, and we will spend a lot of time working on the findings that we get from them. So after all this work, having this nice JC accreditation again, I would love to show this to anybody, but as it stands now, at least here in Germany, no authority, no pharma company will accept this JC accreditation. It's nice to have, but it has no status whatsoever currently, and I think this is really a disaster. That we put so much work in an academic accreditation. I'm really a believer in this JC process, but at least in Germany, it's not really taken account of. And I think this should really replace other audits and checks by pharma companies. So if we think of the practicalities, it's still a lot of work specific to the CAR-T therapy. Checking the patient data, check the indication, really document the decision in a cardboard. Is it in label? Is it off label? Do we need health insurance approval beforehand or not? So I think a lot of this extra work really that is really specific to CAR-T therapy. And I love to change this. And if I go back to my autologous transplant program, where things are so straightforward, a few steps, very easy to go through. And I would love to check, to make CAR-T similar really. And if you just swap between these two slides, you see only the manufacturing process is the difference, and the rest should be just routine in our hands. We should do this as we are doing this with the stem cells, and just the manufacturing side should be a production step that's outsourced to a pharmaceutical company, or we are working very hard on our own CAR-T cell lab. So I would love to see manufacturing on site, because then the difference to stem cell therapy is even less. And then we would really see this as a routine standard cell therapy in hands of clinicians, and not so much a very special and demanding and complex process as it is now. And I think with this, I would finish, and thank you for your attention.
Thank you, Prof. Sheed, for that very practical overview of the CAR-T cell.
From transportation, how you prepare things, and it looks like every company has their own regulations, and this is make it difficult for the institution. So how come we can overcome this? You mentioned that they don't even look to the standards of JASI, and they accept it as a standards for preparation of the stem cells. So do you think how come, because we are going to face this at one point, that we are going to deal with different farm companies, which with different regulations, everyone and come and do inspections, his own regulations. This is a question that came to my mind when I came over to your excellent institutions in Cologne. Thank you.
Yeah, it's really I think one of the most central questions, and I think what we need as clinicians is to do really convincing the authorities that we are in charge of cell therapy, and this is our daily business. And JC accreditation is really a great way and quite a time-consuming way to establish these standards, to check these standards. So I think it's a very good system. And I was inspector in Switzerland, and the Swiss authorities recognized JC as the quality control for let's say an apheresis unit. So we see examples even in Europe where JC has this status, and so we try now at the moment to really talk to regulators, say, okay, what do you have in mind when you tell pharmaceutical companies that they should inspect hospitals and should audit the way clinical CAR-T cells are applied clinically? So I think it starts at the regulatory level, and I think that regulators like EMA and the national regulators in Germany are not enough aware of the higher standards we have in the cell therapy field. So I think we need to convince them to trust us we have experience for many decades in transplantation. And so CAR T cells for us is a very similar cell therapy product. So don't make the companies teach us about cell therapy. This is ridiculous if you think of it. But I think it starts really at the regulator level. And so I would just advise you to use your contacts to politics and avoid that regulators tell the pharmaceutical companies to intervene with the clinical standards. And we do the same on a national level, and we try with the EBMT also on the European level, really to raise the awareness. But it's tough because I mentioned politics, you know, if the authorities have the impression, okay, there's a kind of liberal approach to pharmaceutical company, which are selling cell therapy products for enormous amounts of money, you know, it could look like there's a camaraderie between the pharmaceutical companies and the authorities. So I think the authorities try to be very strict to say, okay, it's an expensive product. So we ask a lot of tough tasks from the drug companies, but also from the hospitals. And this is political pressure, which has no clinical meaning. So I think we have to reduce this and really go back to clinical practice. So I think it's about lobbying and politics.
Another question, the role of the pharmacy. They consider the CAR T cell after do manufacture, they consider it as a drug, a medication. And I can see it when I came in that it has to go through the pharmacy before it will reach, even though the pharmacy has nothing to do with this. And it should be the work for the processing lab, where they are going to receive it and cryopreserve it until it will be infused by the patients. So another issues, yes, it is considered as a medication, but at the same time, there is no role for the pharmacy in these issues. Also, another clarification from your side. Thank you.
Well, thank you for this excellent question. This was exactly our experience when we changed from clinical studies to routine products. You know, within a clinical study, obviously the cell product goes from our team to the pharmaceutical sponsor and comes back to our team, back to the stem cell lab. So everything was easy. It was like with the stem cells. So it was just quite a strict two-way process. As soon as we started with the commercial products, then suddenly this is a drug on the market. And then we have very strict regulation that a drug cannot be ordered by a physician directly. It must be ordered by a pharmacist. And so we have this really strange situation that a pharmacist who has no experience whatsoever to handle cell products, no experience, no facility, you know, he's not really able to perform this task. But the authorities were quite strict that they even said the drug must be received in the pharmacy, because we proposed, can't the pharmacist just come over to our lab and have a look at the transport case? But the authorities, at least in Cologne, said no, it's an official task by the pharmacist, so he has to be in his own environment. Yeah, so again, something where the legal structures are completely out of tune with the practical demands. So I keep saying it's like a procession. The courier comes to the pharmacy, and then like a religious procedure, then pharmacist comes over with the product to our lab to supervise that we are storing the product correctly. So again, I would love to change this, to say, okay, let's make this a bureaucratic process for the pharmacy, but only by bureaucratic. They should be out of the practicalities, I think. They have no rule in this, in my view. It's just a pro forma activity.
Believe me, it's not only in Cologne. It's when I went to Karolinska University in Stockholm, has the same things, has the same concern. It just go through the pharmacy just to touch it and it go to the stem cell processing lab. Thank
So,
you very much, Dr.
if you have influence in your situation, you might really think of that and maybe talk to the authorities and say, let's have people do tasks that are trained for these tasks, and let's not keep the pharmacist out, but give them the role that they should deserve in this process to be really the, let's say, administrative side of things, but not the practical side. I don't see pharmacists really buying nitrogen tanks to store cell products. They don't want that. They don't have experience with that. So it's again, we should learn from experience so far. And I think in Europe, we are really caught a bit in this problem that the pharmacists have this role and can't provide it.
Yeah, well, طبعا with all respect to our pharmacist.
Thank you, Prof. Shi. One last quick question regarding leukapheresis. Our center is on the verge of starting CAR T-cell program, and we are a JASI accredited center. We do our own leukapheresis usually. So the specifications, is it different for different pharma companies, or you know, with the existing machines and training, we can do that easily?
Yeah, it's really small details. So our idea was to have one SOP where we describe only the differences, saying, okay, let's do the apheresis as we are used to, and then we can refer, okay, if something is special, you know, one company wants a certain length of the tubing be connected to the bag, you know, for their production procedure. So the minimum length of the tube attached to the apheresis bag must be, I think, 15 centimeters or so. So you can put down somewhere these details. This is much easier than to make the team look through every leukapheresis handbook. Obviously, every company has their apheresis handbook. Luckily, they got shorter and shorter with time because I kept complaining to the company. When Novartis started with us, it was an 80-page handbook, you know, and very few information was in this book. Many graphs, many explanations. So it was a very lengthy document with little information. So it's really about the specifics. And just as a word of caution, the biggest issue is always labeling. Because we say we have our apheresis bag label. That's our label, it's our product, and there's information on it that we need to be on there. We can't put a company label just there like that on the apheresis bag. So what we discussed with many companies was we might put an additional label on the bag so that the company can put some information that they need on the bag with an additional label. But that's a typical issue that came up when we changed from study products to routine products. And in a study product, I put the study name on the bag because it's a study procedure, it's a study patient. So you have a patient name and this a number, you put this on. You know, once you come to a routine, you have to think, what is my routine apheresis label? And how much can I adopt this label? And I said, I don't want to adopt this label. So we just allowed for either additional label or additional paper to come with the apheresis bag.
Thank you very much for that excellent session. Let us move on to the next talk, and it's my great pleasure in introducing Dr. Suzanne van Dorp. She's a hematologist at the Radboud University Medical Center in Nijmegen in Netherlands. She's a CAR T-cell lead and has extensive publications in the field. And there was a recent publication that I was looking at, the Dutch CAR T-cell tumor board experience. We are really pleased to have you share your experience with us, Dr. Suzanne, and the floor is yours now.
Thank you so much. I hope you can hear me.
Yes, we can, loud and clear.
That's good. Thank you so much for the invitation and the opportunity to share our experience and for the kind introduction. I'm going to share my screen. One sec, I hope this will work. I'm afraid I cannot share the presentation. Nick, can I ask you to share the presentation? I send it to you as well.
Share your screen. You have share screen?
Yes, I have Dr. Susanna's presentation here. One moment, please. And then let's see, share screen. Also a good test. Me later on. Just tell me when to process the slides.
You can go on to the next slide, and maybe even the one after that.
Dr. Suzanne, if you can wait for a moment, we are just loading it on our screen here.
Do I need to stop sharing now, or please tell me?
Dr. Stan.
Ah, yes, I see, but it's the presentation of Professor Scheid, I think.
It's okay.
Oh, nice. So this is very advanced.
Can you share screen our side?
Nick, if you can share the slides once again, please.
One moment. One moment, please, please. What? Because I already closed it. Meanwhile, here again.
Yes, we can see the slides now from your end, Nick. Thank you
Perfect.
for that.
Yes, so I have some disclosures to share, and maybe you can continue, Nick.
Yeah.
And I would like to start with the case of a 46-year-old patient with an aggressive large B-cell lymphoma. And he was refractory after 2 lines of chemotherapy. And in not so past times, he would really have a bad prognosis, as you already know, also from the SCHOLAR-1 trial, that his long-term event-free survival is very poor. But yes, you can continue, Nick. We're all on a mission, and we would like to improve the curation of cancer patients in general. And especially for hematological diseases, we can not only use surgery or chemotherapy or irradiation, but also using the immune system in several ways to treat patients with residual or refractory disease. Next slide, please. And CAR T cells, I'm sure you have seen the pictures before. where we use the patient's own white blood cells. So I completely agree with Professor Scheid that it's the product is really owned by the patient because they share their own cells to make it. And we isolate and activate the T cells and engineer them with a CAR gene, and we can give them back to the patient. And I really, really believe that CAR T cells are a great promise to treat our patients. And they have some advantages over TCR-based cell therapy in the way that they can recognize antigens without MHC presentation on cancer cells. So next slide, please. So when we started, it was, I think, in 2018, we got in contact with pharmaceutical companies to be able to get an accreditation by the companies to be able to give CAR T-cell products to our patients. And as you heard before, it's a really, really long procedure. So after getting in contact with the pharmaceutical companies and get them really actually interested in our center to be a CAR T-cell therapy center, it took a lot of work to get this therapy up and running. And I was also very lucky to work with Nick because the communication part is key, and the communication with a lot of partners, and it's really necessary to make this work. I understand that CAR T-cell therapy and the implementation needs a lot of regulation and a lot of paperwork to be able to give this in a safe manner in a center. But we really have to realize that this takes a lot of time. So I think that when we started really with the kickoff with one pharmaceutical company, it took about 9 months before we were able to have everything up and running, contracts signed, and all the departments ready to provide this treatment for our patients. And one important issue is that, of course, it's a very new therapy. So there's also limited long-term evidence of responses, but also toxicity. And we really have to make sure that the data on this will be available and quality and safety assessments are done properly. So we can continue to the next slide. And this is a slide from the kickoff presentation by Kite Gilead when we started with them. And they showed, of course, the really extensive journey, as they call it, that a cell product goes through before coming back. And all the different parts need, of course, very strict checking and for quality and regulations to make this a safe procedure, and because it's of course an individual product, be able to really see on every time point that the product is from the right patient and goes back to the right patients. Next slide, please. So in our center, in the Radboud University Medical Center in Nijmegen, we are also lucky to have an apheresis unit present at site. So we do our own apheresis as well, which is really convenient. And we have a very nice collaboration between the Department of Hematology, our cell therapy unit of our laboratory, also the pharmacy, which is indeed very important because CAR T cells are considered a drug, and our apheresis unit. But getting this in place and getting everyone together to also together work on the protocols is essential, I think. Next slide, please. And then, of course, I had actually to get the whole hospital ready to give these CAR T cells to patients because, of course, also due to the toxicity. And we all know that CAR T cells are very efficient and they also give very specific toxicity. So the cytokine release syndrome and the ICANS. And to be able to recognize this and treat it properly, very different parts of your hospital should be aware of these problems and how to treat them. So I made the next slide, Nick. It's we actually called it an immune therapy task force. So every a department that was involved in this therapy, I went to them and talked about CAR T cell treatment and asked them actually to be involved in this team. And it's the ICU, of course, but also radiology department, the cardiologists, the nuclear physicians, the neurologist, but also, and I think that's very important, and maybe most important, the caregivers that take care of the patients after they have gone home, because they also need to be really aware of the toxicities, where they come from and how to recognize them. And that also means that they have to be trained to do that properly. And of course, our team on the ward, so the nurses and the other treating physicians, should be really aware of this. Next slide, please. So that takes a lot of communication. This slide is in Dutch, I'm sorry, but it's just to show you how many people and how many departments we were able to bring together to make this happen. And when I started, I really didn't realize how much communication and how many departments should be involved. And I learned a lot about legal affairs and the role of our legal department, our biosafety officer, the pharmacy in this process, and also, for example, our finance department for reimbursement of all the different aspects of the treatment. And it has been a really timely, procedure, but it was also really nice because this really makes you, because it's of course a very effective and interesting treatment. It took not so much effort to get everyone really enthusiastic. So that was really nice. And it's also really nice to be able to communicate and to work together with so many people in your hospital, and to get to know them and make this work really together. So that's a really nice experience, I think. So next slide, please. So what happened to our patient? Of course, I took an example of a success. He had the apheresis in June 21, and then in the waiting time before the CAR T cells coming back, he received our VIM chemotherapy. Unfortunately, the disease was stable; it did not progress, and then he received his CAR T cells. And I actually told him a lot of scary things, that he might get a lot of CRS because I thought the tumor load was high, that maybe there would be some neurotoxicity. The gut was involved, so I also prepared him for a perforation, and he did get some CRS, but it was very limited, and no perforation or other complications. So, and he was in a complete metabolic remission, and he still is. So that's really nice. Next slide, please. And I want to address the collaborations and the importance of that, because of course in the hospital it's very important for a safe and efficient delivery of this product to patients. But I also want to emphasize that for the harmonization of protocols for the apheresis, for bridging therapies, for toxicity management, the acute toxicity, but also the long-term toxicity, for example, prolonged cytopenias or infections, it's really, well, I think it's really important to do this not only in your own hospital, but nationally and also maybe internationally. So we have the pleasure of an immune effector cell working party, and we discuss with a lot of involved parties, for example, our health insurance, the government, the EBMT, pharma, and also our the working party of the hematologists all together to make strategic choices, to get the reimbursements running, to be able to also do trials with cellular therapy, and also to optimize the collaboration with the pharma, which you have heard from Professor Scheid is really a challenge, I think, as well. So next slide, please. So the Dutch CAR T-cell tumor board is a like a collaboration between all the CAR T-cell centers in the Netherlands, and we come together digitally twice a week to discuss all the referrals to our hospitals for CAR T-cell treatment. And this is how it then actually goes. So within 6 days, a patient most of the time is referred after the indication on a PET-CT scan for lymphoma disease to a Dutch CAR T-cell center, and we discuss them most of the time 1 day later. Then we can screen the patient and do the leukapheresis within 15 days. And then, of course, there's the bridging phase where we have to wait for the CAR T cells to come back. And this takes, before the infusion, around 35 days. And so next slide, please. And because we are actually really registering the patients very well, we can also share our real world national data. This is an example of the progression-free survival in our patients, which is really nice, I think, and looks also like the outcome in the trials. Next slide, please. So I believe that the CAR T-cell therapy is revolutionary, very promising for the present, but also the future treatment of hematological, but also other malignancies. It's a very time-consuming thing to implement in your center. And I want to emphasize that the collaborations are essential. So within the departments of your hospital, of course, also with pharma, and really, I'm also really trying to get them to harmonize the accreditation procedures, the communications, and also trust that we can actually perform this treatment, because we do it maybe in a little bit different way, but every day. So that's also something that we are trying to achieve. And so nationally and internationally, these collaborations are also very important. And I really, really hope that in the future we can harmonize all these processes to make this a more efficient therapy. And with that, I would like to thank you and answer your questions.
Thank you, Dr. Van Dop. I will ask the questions to be asked. So I'll start off with a question. Usually for our stem cell transplant program, we communicate with different members of the team through an email, letting them know, the stem cell lab, apheresis, everyone who is involved, that this transplant is going to happen. But with the CAR T cells and the possible requirement for ICU and ICANS and so on, do you take any extra measures like informing the other teams that there is a potential case we might need an ICU bed and so on?
Yeah, so when a patient gets admitted in the ward, they are all seen by our neurologist before, just to get a situation before the infusion. And then we inform the ICU. And I think they actually still like it to know that a patient is coming. Not so many patients have admitted to the ICU, luckily. So they were kind of hoping to see more of it, but we are lucky that they did not. But we are informing them that the patient is admitted, and then we just ask them when necessary if the patient gets a severe CRS or ICANS.
Are you seeing like apheresis failure or manufacturing failure? I mean, is it common, or what's your
Almost
experience?
none. We had one so it's 0.5% in the of failures in the last 3 years. So that's that's very good actually.
And I assume you wait for the product to arrive in the hospital before you start the lymphodepletion.
I did so before, but now the production is actually in Hoofddorp, which is at like 2 hours drive from our center. So I'm now trusting more that when the quality checks are okay, the product will arrive in our center. So I might already start the lymphodepletion, which still saves a lot of time, I think, and it's most of the time really precious time. So when I hear that the product is okay, the quality checks are okay, I do not wait for the product to be in our center, but I already start the lymphodepletion.
Thank you for that excellent talk and all the information that you shared with us. We hope to meet you in person in the future.
That would be really nice. Thank you.
So it's my pleasure now to introduce Nick Van Sinderen. He has been extremely helpful in arranging this quality session, and I would like to thank Nick on behalf of myself and Dr. Bayoumi for all the efforts. So Nick has been a JASI inspector for quality management since 2015. He is a member of the EBMT Quality Management Committee. Currently, he's a quality manager and advisor in the University Medical Center Cologne. He was previously the same in Nijmegen in the Netherlands. So I'll invite Nick to deliver his talk now. Thank you.
Thank you, Dr. Binjam, for your nice words. And it's a pleasure to be part of the speakers at this Congress. I will share my screen, and I would like to share with you some operational things we encountered in the last years in several areas. Let me see. I hope you can see and hear me very well.
Yes, the screen is clear.
Yeah, perfect. I have no disclosures. And I would like to tell you about governmental and other QM-related bodies, which you have slightly already seen in previous presentations. Differences and similarities. Then I would like to focus on the immune effector cells parts, because good manufacturing practices meets JASI, and focus on the industry and their CAR-T qualification processes. You can make some strategic choices in the future if you would like, and there are some takeaways. And you see on the right below part of the sheet, it's all about quality assurance monitoring. So when I see Saudi Arabia, Germany, and the Netherlands, we all dealing with lots of national and international bodies who want something from us. Your Central Board of Accreditation, for example, is comparable with the Paul Ehrlich Institute in Germany, and in the Netherlands, the Ministry of Health, called IGJ. Of course, you are dealing with the Joint Commission International. In the Netherlands, we can choose for a Joint Commission International or NIAS. Joint Commission International, of course, famous for its international patient safety goals. Your lab is probably dealing with ISO 15189, and for the medical equipment 13485, lots of figures. And we are all dealing with JC, and indirectly it's FDA or European Medical Agency. After FDA approval of medicines, also our European Medical Agency has to approve. And of course, and that's what we're talking about today, is the licensing and onboarding per ATMP. If you compare Jeddah, Cologne, and Nijmegen for JC, there are slight differences. For example, Jeddah and Nijmegen have version 7. We recently had the inspection for version 8, but we came from 6, and that was all because of COVID. JC accreditation is not mandatory by government, or is mandatory. That's a big difference. For example, England is mandatory, but Spain, for example, not. So that's something quite a big difference. Yeah, as for climate, in Jeddah we need a sunscreen, and in Europe we probably need an umbrella. Of course, this is maybe meant a bit funny, but I also want to emphasize that for the same topic, you might need different ways in dealing with them. And we see that back in the onboardings of the industry. Now, when we look at JC, in version 8, we are really going to deal with immune effector cells in one of the first sheets. Here we have to say which immune effector cell products we use, describe participation in studies, and what support services we have. And you see on the left side, the pharmacy is very strongly involved. And that is an evolution of the last 3 or 4 versions of JC, where the role of the pharmacy becomes more and more important. Example, in the standards, also pharmacy needs annual education of minimum of 10 hours. The hospitals where I was, and still am, have that role already embedded in their processes. And for example, in Nijmegen, the pharmacist is not only in the weekly visit of the patients, but it has also a role in the SOP where medical information is in. So every review or update of an SOP, it goes through the pharmacist to check on the medication. When you go further on the checklist, you see these blue items. You probably know it, you probably have seen it, and this shows the development of the JC standards regarding the immune effector cells. So the inspector who comes to your facility to inspect the B part, so the clinical part, will also take care of the immune effector cell part. One thing you saw in the previous sheet that in Cologne we went from version 6 to version 8, and that was because of COVID. It took a long time, 2 or 3 years, to get another inspection organized, and logically we went then for version 8. But because of the fact that the standards are updated every 3 years, and every 4 years, there's the audit cycle is every 4 years, could be, and it could also be for your facility, that you skip a version. So sometimes you have the choice, and sometimes not, but I can tell you from the experience in Cologne right now, if you go from version 6 to 8, you basically start all over again because the changes have been so huge. You have to check on every item again. And what you will also notice, and maybe you saw it a bit in the last sheet, that the good manufacturing practices and JC are approaching each other. And you will see an audit character. I always like to refer as the JC audit as a bedside audit, because the inspectors are from other hospitals and have experience in a clinic, in the apheresis, in the lab, and in quality management, where the industry has external people, which level of knowledge, and not saying better or worse or good or bad, but the level of knowledge is different, and that needs some adaptation. I will get to it in a second. And the EBMT has initiatives to get GMP and JC further together. There's a Go-Kart Coalition, you can see on the EBMT website. There are working parties, and each aspect of the organization, not only the standards, but the complete organization is adhered to, and also the industry takes part in this. So that's very good news. But having said that, it will always be the case that you, as a hospital, have to fine-tune your own procedures with other bodies. In Cologne, for example, we now took the initiative to address every pharmaceutical company and say, please think along with us how we can make our common processes more lean, more effective, more efficient. And you saw that already in the previous both presentations. Also on a management level and on an operational level, there's a they want it very badly because it takes so much time to get things organized in a good way. In the EBMT, but also on a national level, there are bodies who share knowledge, and I would recommend, because they're not only for example, Netherlands and the United Kingdom, to send an email to them and be a part of that. Because, for example, when I want an SOP on a specific topic and I mail that to representatives of the UK in a network, most likely within the hour, I get 10 examples of that particular SOP that you can use. Of course, fine-tune it with your own facility. But it's very, very valuable, and I see on a weekly basis exchanging information on several topics. In the Netherlands, for example, we have twice a year a meeting with the quality members, local on in a certain hospital, and there also speakers are invited and information is exchanged. So it's always good to set something up yourself or be part of such networks. This is a slide from a legal and practical perspective. I think Professor Scheid already mentioned many topics on that, and also Dr. Van Dorp. So I will go through this very quickly. And then I get to a topic which is quite tricky and also a bit sensitive, because when you go into discussion with external bodies, pharmaceutical companies, and you see the manufacturing process, a tricky question is this ATMP process or manufacturing process or a mix? The industry sees this as a manufacturing process and include with that, for example, apheresis and infusion. But historically seen. These are, of course, clinical processes. And yeah, how do you deal with that? Because it's very essential in the terms of knowledge that the who's going to decide how to do a process? Where's the expertise? Where's the knowledge? And if you have identified that, it's good to respect that field of expertise and not say, hey, you have to do this now because it's now part of our manufacturing process. Better is to advise the other party on how you see it so they can use it or not. So, and if you then ask, can fields of expertise be divided, or is there equality in knowledge? I don't think there's equality in knowledge. And I deliberately put question marks after every item because it's, yeah, it's for discussion, of course, to see who is better and what. But this discussion goes on and on and on. And every time you deal with an external party that makes an ATMP, you can strand in this discussion. I think it's a matter of balancing and being aware and knowing what you can and what the other party can, and so get to a good agreement on this one. Now, also very few questions I got from colleagues. I want to share 3 with you. On the left side, you see the commercial products now in use. Maybe there are some more in the meantime, but it's good to know that everyone has their own onboarding process. Also already mentioned, it takes time. It can be different in certain levels, and sometimes very difficult for hospitals to deal with it. So some time ago, I got a question from a physician, a doctor, and would it be good for a hospital to inspect the industry rather than they inspect us every time there is an onboarding? After all, the doctor is responsible. True or not true? So I know from a practical side, it's impossible for a hospital to go inspect all the ATMP manufacturers. So it's a matter of trust that they do their work the way they should do. And I think it's it also goes both sides. Like mentioned, apheresis and infusion, I think the experience, the decades of experience we have, kind of outline this topic. And then the second tricky question, do we need one extra driving license for each commercial CAR-T model? So if we are already onboarded and inspected by one pharmaceutical company, can't we say, hey, to the next one, we have already been inspected, JC was there, this is the outcome, please leave us alone. So that's another question I got. And what about new studies about the same process? Of course, there are differences. So do we need to go fully on board again? Sometimes there is a new study from the same company, and they also want, again, new, for example, dry run. And more and more, I see that hospitals are questioning and maybe also saying no to a company. It's not what we want. I have some quality management related for you. For example, we in Cologne have now, as Professor Scheid said, 4 companies where we're dealing with, and they also have 4 different portals. And these portals are used in the internet for ordering an ATMP, but also for uploading information, lab information, etc. And so we have now 4 different login names and 4 different passwords. And in one portal, for example, we can put in the lab results. But in another portal, for example, you need to download it from the electronic patient file and then upload it to the pharmaceutical company. So there's differences. Handovers, for example. And one company delivers the box to put in the cells one day before the apheresis. So everything can be checked. And they also have a spare box. Then another company, for example, has brings the box at the same day in the afternoon, and expects that the nurse puts in the cells, and he or she can take it away immediately. There's a risk, of course, because when the courier is stuck in traffic or what else, we need plan B for timely storage. The doers, there's also differences in the handovers and how they are treated, and also the shippers' requirements for internal transport. The monitoring processes, so this means auditing, deviations, etc., is also can also be different from an industry point of view. Like Dr. Schein mentioned, in Cologne we have a separate SOP that summarizes the operational differences between the manufacturers, just to have a clear and simple overview. What I want to talk to you also about is the risk management. We already discussed the competency, and you saw the communication in the previous presentations. Very, very important. The most major thing I have encountered a few years ago was a risk that the day 0 in a study from a pharmaceutical company was not there. The infusion day was at day +1. So normally you would say, okay, that is not a problem because everything just moves away. One day, it's done the day after. So if you read the protocol right, the SOP, then there is no problem. But my advice would be to have a prospective risk inventory, PRI, as we say it. So what if this change in the protocol, what could it impact if you, for example, have COVID-19 and you have a shortage of staff, and for example, someone else from another department or external comes and help you, and someone asks, hey, can you please do day +2 at room 8 for me, because we are understaffed and there's a lot of pressure on it. Could that be a risk? Could that have an impact? And a couple of years ago, a nurse came to me and said, hey, day 0 is gone in this study. What can we do? And of course, we solved the issue quite soon. And then it turned out that it also had an impact on the information technology, because the template of this schedule, day minus, let's say 30 until day +30, was hard-coded in the IT system. So if it would have been changed, really had a great impact, would have had a great impact on IT systems. So my experience is that not only operational consequences are involved, but also check always the impact on the information technology. And what Professor Scheid did in Cologne, way before I was there, is include a what if in all SOPs. So on the top, it says, what if this happens? What is the impact? And what must we do to solve the issue? And therefore, also on the right side, this image, expect the unexpected. So these were my experiences, awareness of differences in knowledge, communication, there are operational differences, and there was also an educational part. Every pharmaceutical company has its own regime of training. Some want to come at location at any time, but there are also online sessions, webinars, video, trainer programs, and you can also, for the same process, send info in a new treatment just to compare. And if there are any questions, then you can set up a meeting or something. So it's good to also there be a little leaner, as they say, so everything can be in balance in spending time on these items. So what about the future? What are we dealing with now, and what are what reading us from a quality management perspective? We now have stem cell transplantation, CAR-Ts, but also many hospitals are now preparing for making their own CAR-Ts. So that makes sense. It's less time consuming, it's cheaper, you're always in full control, but also very challenging. The advantage the industry always has is they are able to mass produce the ATMPs. If you have one clean room in your own facility, you can do one ATMP every 2 weeks, roughly said. So not as many, of course, as the capacity the industry has. There are point of care developments. So the bedside process, if you look it up on the internet, you will see that there are really studies going on that level. Bi and tri-specific medication, I have heard. Also studies going on, and if that will be a success, it would have a really, really big impact on quality management. Of course, also in other fields, but also for quality management, because 80% of the current hematology quality management would not be necessary anymore. Some takeaways. Balance the following for your hospital: GMP and JC. So GoCard, use it, but fine-tune also your own hospital. Daily practice, bedside, and the theory of the checklist. Education, cooperation with all stakeholders, also with your government. Tell them more and more external bodies want to produce ATMPs, and yeah, there are many, many differences. Look beyond 5 years and use also common sense. And the conclusion is in line with Professor Scheid and Dr. Van Dorp. Harmonization of accreditation procedures is needed to make this therapy more efficient and feasible. So, and in future, if you need any information or we can share, we'd be happy to, of course. Thank you very much.
Thank you, Nick, once again for sharing your experiences with us. We have a question from Dr. Bayoumi. While I wait for that question, can I ask you, do you have a traditional stem cell quality manager and then a CAR-T manager as a separate, these are two separate people?
Yes, in Cologne we have at this moment, but it's depending on the size of your facility, of course. I can imagine hospitals making this one job, so to say. So, and yeah, it's related to the amount of work you have in your hospital.
And it's a question to all of you. I know the traditional role of pharmacists in stem cell transplant is limited when it comes to the actual product itself, but because CAR T cells is mandating the pharmacist to be involved, do you have pharmacists attending any special training or going to some, how do you manage that?
Shall I answer that question, or
maybe I can add. So we have a close collaboration with the pharmacy. So don't misunderstand me that I want to exclude pharmacists. It's really just to make a clever choice of the shared responsibilities. So we have a clinical pharmacist being on the transplant ward once a week to discuss, all the drug interactions, drug supply, shortages, and so on. So this is extremely helpful, and we hope to have more of these pharmacists in the clinic, really helping us, a bit like we've seen in the US. So that's very helpful. And also with all the, Suzanne mentioned that, well, all these accounting details. I'm not so familiar with accounting as a pharmacist. It's amazing how much detail is there and how many platforms they have here internally. So that's extremely helpful to have the accounting people, the controllers from the pharmacy. All these discussions about discount costs and so on. I mean, it's plenty of tricks in this business. So I think we need the pharmacist, but it's really, we have to find a good role for them, both in the clinic, which I think is very helpful, and also in this kind of administrative side where they have this immense experience, which we don't have as physicians.
And may I add also one thing, because Professor Said, you mentioned that the treatment has to, the CAR T cells have to be actually received by the pharmacist in their own environment. And we actually made this deal with them that the CAR T cells are received in our laboratory and that they only on paper do the check-in. So, well, maybe we did convince our board of directors that was a feasible way to do so. So it is actually, I think, possible, but it takes a lot of work, and maybe that's also the experience they had before. And we do have one ATMP specialized pharmacist who is really collaborating in all these things. So that really helps to make the procedure as lean as possible.
Thank you, Nick, for your amazing presentation. Remember, Dr. Shed, I asked about the third-party agreement and regarding between the pharmaceutical company and the hospital, and because this is one part of one of the standards which is you have to audit it. And you mentioned to me that, and I would like to have these questions for three of you. Does it need it? Because once we already give the product to the pharmaceutical company, we have no idea what's going on in this for this product, even though this is a very precious product for the patients, and it could be the only products which we can have for these patients, and we don't know until they will send it back to us. So I think that you answered me, Dr. Shed. You would like to also to let the group here knows what's your answer about this. Apart from the financial agreement between the company, I'm talking about the product itself.
Yeah. So in a classical third-party agreement, we have two partners agreeing on a cooperation, like we have with Red Cross, for instance. So this is, I think, a very fair process where you really sit down and discuss the partnership. With all the contracts with the industry, it's a very unequal distribution of power. So we made many changes in the quality agreements, but in the end, we were quite a weak partner. And we kept having this answer, yeah, but the global team does it this way. And if you want to have access to these cells in the next year, you have to sign it. So there was a lot of pressure on us. And obviously we had the patient in mind. So we were really, I would say, forced to sign these contracts, but we have almost no rights towards the company. So they have rights to visit us as many times as they want. But I've never seen a contract offering us an audit to Hofdorf or so. You know, I would love to go there and have a look. But strangely, this is not part of the program. And so if I have a patient, I had a patient who had got Abecma, so a myeloma patient got CAR T cells. So on the back, it was written expiry in November 23. So the patient was asking me, what happens to my other bag? You know, this is bag 1 of 2. So there's a second bag, obviously. And this second bag will expire in November. So I asked the company, do you have any procedure for these extra bags? It's nothing worth to you. It's patient specific. So my patient said, I would like to have this bag in the hospital of Cologne. But I was asking for that, saying I can just mention this patient wish. So the company was kind enough to send this extra bag. So I have it in my storage. I can use it as a backup or so. But other companies are more strict on that. And it could be really in the next case with the same company that they will say, sorry, there is no provision of an extra bag just for courtesy. And nothing is written in the contracts about this. So it's really depending on a person at the company side to decide on these critical issues. And so it tells us there are plenty of questions, but this is not really put down in a contract. And we discussed that in the JC audit. In every contract, it's strictly confidential. So I would be very pleased to open these contracts and say, have a look at this. This is how our center cooperates with drug companies, but I signed that I will not disclose this contract to anybody. So again, this is against my will, really, but I signed it because I was almost forced to sign it. So this is all this part of this intransparency we have in these dealings. And I think this is not healthy that we as doctors are involved in processes where we are working more under a pharma-driven environment and not in our classical academic freedom.
I completely agree with you, Professor Scheidt, and I also would like to add that we, because I think it will be very hard to get really insight in the product actually, so what we give to the patient, and also to be able to explain why certain patients respond or not. It's of course crucial information. It's not the only important thing, but it's well, crucial. And so in the Netherlands, we now have the opportunity to perform a trial where we can compare one-to-one a point of care manufactured CAR T cells to standard of care, which is Axicell in our country. And of course, being able to give point of care CAR T cells allows us to get far more insight in the phenotype of the CAR T cells, the expansion. And I think that this will give a lot of information in the end on, of course, we already know a lot about it, but even more on what's important for CAR T cell efficiency. So that's one way where we try to solve this problem.
Yeah, thank you very much. Very explainable. The only things that Nick mentioned about there is a networking. This is a request from Nick that you do it every 6 months with other centers.
Quality network, yeah.
Yeah, so I will be happy if it is possible that we will join this kind of network to see the difference in standards and to explain the standards together. So if it's possible, I'd be happy to communicate with you and see if we can be part of this kind of network. I will give the phone to Dr. Abu Sada, the chairman of organizing committee, and my colleague would like to ask questions also.
Okay, thank you very much. It was a really enlightening session. I look at the quality of transplants and try to compare it to the aviation industry standards and the safety of the aviation industry. And it's a dream actually for me to, which is a very huge challenge, how much regulations or standardizations needed in order to achieve the optimal balance of efficacy, safety in our programs. I could notice there is a lot of variability between centers and centers. And the standards in the JASI trying to get the balance between flexibility plus getting the best quality of care. So how much, or let me phrase it in a way, can we analyze what is the best system? And we can drive ourselves to that best system in the subsequent standards. So probably if you are at the end of monitoring, looking at all the processes in different centers, you can, know exactly how each center is performing and in each standard. Can we look up for the best centers and try to get those standards across the board in a very standardized fashion? For example, if I have a successful SOB in one center, why don't we adopt those types of SOBs and how it is designed and how it's executed? It's a general question. I would love to listen from you guys.
May I just start maybe? I like the suggestion to think of the aviation as another field, and I just try to imagine if we let the pilots be trained by the manufacturers of the planes, that make feel us happy. I'm doubtful about that, So it's the same thing. You have manufacturers of planes who want to keep their secrets, but at the same time we need a certain transparency, and we need to be on control of running these airplanes and training the pilots and so on. So it's a very nice example, and I think I will use this many times now in the future to discuss this networking or this interface between pharma industry and academic hospitals, because it's a very nice example. And we have examples of problems where companies like Boeing were really intransparent of problems in their cockpit. And they needed several air crashes until they came up and said to the authorities, well, we have this problem and we know it as a software problem. So it could be the same thing. So I think we need to expand the academic domain, the control we have over processes like training, like risk management. And to the more general question, if I remember the last JASI inspection, that one we had, the ones I did as inspector, the authorities came in to check our local manufacturing of CAR T cells. My impression was really we are looking at the logics of the quality management. How do you approach the problem? How do you see risks? How do you manage this? So it was rather looking at the logics of the system, at the structure. How do you manage this, and not having a checklist and just saying how many times do you check the blood pressure or tell me the temperatures? So there's I think a shift away from checklists and just saying yes or no to a question, but rather saying, okay, I listen to you, explain to me how you have organized this. And I think this is much more useful to go to a center and see how they have adopted risk management and organized their way. So for me, this is a very different approach than I notice when a pharmaceutical company comes to us. They have their checklist and they just want yes or no to cross or not to cross this checklist. And if I give explanations, I feel like I'm wasting their time because they don't care about my logics and my system. They just want to have their checklist filled. So I think this is a good point.
I think in the interest of time, I think we'll bring this session to a close. I'd like to thank all three speakers once again for the enlightening session and the discussion. We will adjourn now, and the next session will start at 1:15 after the lunch and prayer break. So we'll rejoin here at 1:15. Thank you for all who attended, and thanks for the speakers as well.
Thank you. Bye-bye.
Good afternoon, everyone. My name is Ahmed Maghari. I'm the head nurse of the outpatient oncology treatment area in King Faisal Specialty Hospital. I will be the moderator for the nursing session today. I feel extremely glad to welcome everyone to the 5th HSCT and Cellular Therapy Annual Conference. Nursing Symposium will target all nursing specialists at all levels. The conference highlights the role of the nurses in transforming healthcare to optimize patient care outcomes, patient experience, research, evidence-based practice, transformational leadership, and professional development. And I would like to take this chance to introduce my colleague, Ahmed Al-Omari. He's the head nurse of the inpatient oncology hematology HSCT inpatient department. Ahmed Al-Omari is having experience with the bone marrow transplant more than 20 years. And he has the bone marrow American certifications, and he's a very active head nurse in our department. So Ahmed Al-Omari now.
Assalamu alaikum. Thank you, Adam, for this introduction. Good afternoon, everyone. It's my pleasure. I'm really delighted to have all of you today participating with us in our 5th conference. For the people who's here physically or the one online, we are really happy to see you. This is our 5th conference. This is the nursing session. I'm sure that you will have or you will gain more knowledge and update about the BMT in this session. Also, today we'll focus on presenting some data from our hospital. We know that the time is really very tight for us. It's only 1.5 hours, but we'll try to give you more update about our practice in our hospital. Now, please allow me to welcome our first speakers, Mr. Mohammed Badawi. Mr. Mohammed Badawi is a nurse clinician in adult oncology, hematology, and bone marrow transplantation. Mr. Badawi has a bachelor degree in nursing. He have more than 18 years experience in nursing, especially or focused on oncology and bone marrow hematology and bone marrow transplantation. Mr. Badawi is responsible about the staff education, staff privileging in adult oncology. Mr. Badawi, please join us.
Assalamu alaikum, everyone. Assalamu alaikum. Shukran, Ahmed. Thank you. And good afternoon, everyone. I'm glad to stand here and give the overview about nursing role in transplant. And I would thank the committee to choose me and stand here to talk about the tremendous role of nursing in transplant. So working in transplant needs some qualities, and it's not easy, and not anyone can work in oncology. On bone marrow transplant setting. They need to be qualified, trained, and competent to do these roles in a transplant setting. Everything nurses do is described in a policy, and everyone performs the same care that delivered to the patient, and which is better for all the patients. Nurses are good communicators with different professionals such as pharmacists, physicians, social worker, which improving the way working together. And the new nurses that they are exposed to the BMT setting, they have to work within the clear tool, structure, and process while they are exposed to the BMT patients. Also, nursing have a key role in treatment management and requires specific training to understand, prevent, and management of the early and late complications of transplant. They have to be trained to take care of the high risk of patient, as most of the patients are at risk of many complications. They have to be trained about educating the patient and their caregivers for the entire process of the transplant. They have to be trained how to safely administer chemotherapy and rest of medication and stem cell as well. And they have to be trained how to manage the central catheter, while all the entire process of the treatment during stem cell transplantation being used with the central lines and give emotional support for patients and their families. We know that the transplant is very fast in developing and updating in terms of theory and clinical. It's been like 7 decades now for the first transplant that's been done, and it was done with a little of success. The update and the development in this field is very fast. That's why all nurses and healthcare workers have to be continuously educated and updated for the new settings. Of course, nurses, they have to apply the theories with the clinical in order to deliver the high quality care for our patients. So they have to enrich their information with the updates and informations. So they have to know that the goal of transplant is to cure the diseases of patients and types of cancer. It's there to replace disease non-functioning bone marrow transplant with a healthy one. And we give the transplant to regenerate a new immune system that will fight the remaining leukemia or cells that have been not killed by medications, replace the bone marrow and restore its normal function. And there are 3 main types of transplant, depend on who's the donor. The allogenic, where the bone marrow taken from same genetic types of the patients, like haploidentical, where there is half match and the stem cell being taken from the parents, and syngenic, where the stem cell is harvested from identical twin, and match unrelated donor that being taken from a national bone marrow registry. Also, autologous transplant, where the donor, the patient, him or herself, and the umbilical cord transplantation, the stem cell is taken from the umbilical cord immediately after delivery of an infant. So how the donor and the recipient are matched in allogenic? So it's depend on a certain human leukocytes antigens. There are more than around 100 HLAs, but not all the 100 HLAs are major and significant affecting the successful of the transplant. There are like specific HLAs that is important in transplant, and the higher number of matching HLAs antigen, the greater the chance that the patient body will accept the donor cells. And of course, that will lead to less likely to develop a complication like graft versus host disease. The source of the transplant either is taken from the bone marrow itself or the peripheral bloodstream or from the umbilical. And it's the process of the transplant is go through main phases, starting from mobilization, passing through the conditioning, and at the end, the engraftment. When we talk about the mobilization, we talk mobilizing the hematopoietic cells from the bone marrow to the peripheral bloodstream by using either granulocyte colony stimulating factor alone in allogenic, or using this stimulating factor with chemotherapy in autologous, and that will help the collection later on for the hematopoietic stem cell that is coded by CD34. The conditioning regimen also is part of the transplant, where there are 3 types of conditioning: myeloablative, non-myeloablative, and reduced intensity. And these types of conditioning that will switch different type of patients. Usually it's combined of chemotherapy with radiation plus minus immunotherapy. And we use the TPI as kind of additional treatment with some of the conditioning in order to kill the remaining stem cell that not being killed or reached by the chemotherapy. For the immune therapy, there is two types are sometimes used in bone marrow transplant, the non-cell-based therapy like monoclonal antibodies, immune checkpoint inhibitors, and therapeutic antibodies and vaccines. And these, most of these medications are targeting certain cluster differential like CD20, CD22, and CD33. And cell-based immunotherapy has been used and start to be used. And there are many processes that go through, and it's focused on the T cell, the T cells, such as tumor infiltrating lymphocytes or injured T cell or CAR T cell, or even use the natural kill cells rather than the T cells. So mainly the purpose of the preparative regimen in autologous, it's aimed to eradicate the disease, but in allogeneic, it's also added to the eradicating the disease. It's used as immunosuppressive for the immune system and creates space for the new stem cell when it's been infused. So there is a lot of complication along with the preparative regimens, and there might be like acute and chronic side effects due to the toxicity of the treatment. Nursing is playing a significant role here in order to educate the patient about the toxicity and the assessment of the toxicity. Close monitoring and action plans are very important role. And the majority of the complications such as mucositis, sepsis, hemorrhagic cystitis, and sinusoid obstructive syndrome or veno-occlusive disease. And nursing here working a very important and essential role when it's come to this complication. So nurses, they are doing like non-stop educating on the assessing the oral cavity of the patient in order to find any other abnormalities that will be post the chemotherapy, educating the patient and encouraging the patient to take care of their oral hygiene as well. On sepsis, of course, there is like a non-stop checking for the vital signs of the patient and reporting any other significant disorder or like predicting the early signs of symptoms that can be treated early. Hemorrhagic cystitis is like a complication along with some of the chemotherapy. It's giving like cyclophosphamide during the regimen. And nurses are, they should be vigilant when it's come to look after this complication, assessing the patient urinary tract, any complication from the urinary tract, and urine analysis have to be checked, and they look after the red blood cells in the urinary analysis and report this effectively to the physicians. Sinusoidal obstructive syndrome, also nurses have to be looking for any other symptoms, like predicting this kind of complication in terms of looking after the weight of the patient every day and looking after any significant changes or increase from about like 5% from the baseline, and looking after the daily abdominal girth, which might be indicated for fluid accumulation and ascites. Also, liver enzymes that have to be checked on a daily basis, and they have to be aware about the normal level of the bilirubin and the rest of the liver function test. So during the infusion time, nurses also, they are working in a team in order to give the care for the patient pre, during, and post-transplant. So pre-transplant, they have to, or pre-infusion, the nurses have to make the environment safe for the patient in order to manage any serious complication during the infusion. Emergency medication, emergency equipment have to be prepared, and taking the vital signs at baseline, making the patient prepared for infusion and IV line care, giving the patient time to do their routinely care and hygiene, and giving psychological support. During the infusion, the nurses taking care of the line care, using non-touch technique to prevent any risk of infection and monitoring the vital signs. Also post-infusion, the nurses have to continue monitoring the vital signs hourly for the next 2 hours, and then every half an hour for the next 2 hours, then hourly for another 2 hours, then every 4 hours. Transplant has a lot of side effects, and the nurses have to make sure or to understand the phases of the engraftment, which is a pre-engraftment phase, early post-engraftment, and late post-engraftment, as there are a lot of complication along with each phase. So when the engraftment it's happened mainly on day +15 and day +30, and the engraftment might be delayed for because of infection or certain medication, although donated stem cell count or engraftment failure. So the engraftment might take more than 30 days, it might take months, it may take also years. To summary the nursing role, nursing play an important role as coordinator of all the issues, including coordinating procedures and care activities within the interprofessional context before, during, and after the transplantation. And also it includes the organizing all necessary diagnostic tests and checkups prior to transplant. Nurses, they have to be effective communicator in order to communicate all the diagnostic tests there and the results, and they have to translate to the patient all the medical finding or any other medical plan for the patient in a way that he can understand. Nurses are a preparer and educator of patient for transplant and the period after transplant as well, and they give social support and motivate the patient during the entire of the transplant process. So it says that nurses are implementing practices to prevent and manage infection and other serious effects following transplant. We mentioned about the sepsis and bleeding risk caused by thrombocytopenia, as platelet is the last cell that it's recovered in engraftment period. So nurses, they have to frequently checking the any signs, symptoms for bleeding, administering the blood and blood product when it's needed. So also patients might complain from tiredness and fatigue caused by decreased hemoglobin level, and nurses are infusing the blood and the rest of blood products in order to restore the patient's energy. Pain due to mucositis, and this is continuous to be done by the nurses, and reduced nutrition, also one of the complications that need nurses to follow up and educate and motivate the patient to take frequent meals. Sinusoidal obstructive syndrome and acute GVHD is a part of the life-threatening complication during the transplantation. So nurses have to check frequently the skin and check frequently also the liver function test, hepatomegaly, and checking also the GI tract every day. Psychological And psychosocial distress is one of the also complication of the transplant that need frequent motivation and pushing forward the patient to stay strong during this transplantation. So what's new now in transplant? And so there is a lot of new in transplant that immune system are being boosted by drugs and shown the ability to shrink or even eradicate the tumors, even in the late stages. Drugs like immune checkpoints inhibitors also, it's been implemented, and the CAR T cell as well. So they said that we know the past and we see the today. We live in a rapidly evolving world of industrial revolution, dominated by globalization, digitization, and personalized medicine. Targeted therapy promised cure, gene-modified cell destroy untreatable cancer, immunomodulation with the checkpoints has become a reality, and we are waiting the future to give more for transplant. Thank you so much.
Thank you, Mr. Badawi, for sharing your knowledge and information with us. Now, I would like to invite our honorable speaker, Ms. Ghada Al-Khatib, to share her knowledge and with us. Ghada Al-Khatib is the BMT coordinator in King Faisal Specialty Hospital since years. She's very dedicated to the patient journey. She has a good experience preparing patients for bone marrow transplant and follow the patient as a post-transplant as well. Thank you, Ms. Ghada, for joining us.
Assalamu alaikum. Okay, my name is Ghada Al-Khatib. I'm a pediatric BMT coordinator. Today, my lecture is about BMT coordination and pre-BMT workup. So, as a BMT coordinator, we work in collaboration with the multidisciplinary team to plan, direct, and evaluate the care provided to our patients who are going to bone marrow transplant and their families, and then provide a good, effective feedback to the team about the progression of our patients. So as a BMT coordinator, we should have good communication skills, problem solving, team development strategies, efficient time management, and setting priorities, demonstrate knowledge and competence. So what is the BMT coordinator role in the transplant? We follow the acceptance of the cases in the eligibility department. All the cases of the BMT cases will be discussed in the multidisciplinary team as a weekly meeting. These cases can be external referral from outside the facilities, or internal referral from our hematology services. If the cases got accepted from our HCT board, they will be given appointment in the clinic for HLA testing. So what are the types of cases accepted in King Faisal Jeddah? Multiple myeloma, leukemias, lymphomas, neuroblastoma, germ cell tumor, bone marrow failure, benign hematology as sickle cell and thalassemia. Immunodeficiency, we used to accept these cases, but now we are referring them to Riyadh, inherited metabolic disorders. Then we initiate the HLA typing. It's a special blood test to be done for the patient and their family to determine whether the patient has a suitable donor for blood for bone marrow transplantation. This test can take until 2 weeks to get the results. About 30 to 60% of the patients who needs a bone marrow transplant, they don't have a full match family donor. So the HLA results will be reviewed by HSCT team, and they will determine if the patient is qualified for a fully matched transplant or a haplo transplant. All the donors has to be screened and a medical history will be taken to check if this donor has any comorbidity or risk factor which can affect the selection decision. Then we book the patient or donor in the pre-BMT clinic for counseling. And this first physical visit for the patient, we do the counseling, consent explanation, evaluate the patient's condition and taking a history with physical examination, provide patient and donor with their family about all the education that they need, provide information about the HSCT process, including goal of transplant, conditioning, complications and side effects, initiate a pre-BMT workup, and refer the patient to the social services. For the pre-BMT workup for the recipient, we do routine laboratory like hematology, chemistry, and serology, special genetic testing if the patient is Fanconi or aplastic anemia like WES, chromosomal breakage, bone marrow aspiration, ultrasound-guided liver biopsy for thalassemia cases, ECG, echo, pulmonary function test, chest X-ray, MRI, and ultrasound. Then patient has to be consulted and gets cleared by dental, radiology, endocrine, and pulmocardio if needed. And this is the form according to the our policy for the workup for the recipient. Then we got screen also the donor. He has to do a full routine laboratory and special genetic testing if he is a donor for Fanconi or plastic anemia. They will do ECG and chest X-ray, and they will be referred to any specialty if needed. Then as BMT coordinator, we have to organize all the aspects of care provided to patients pre-transplant. We make sure all the documents and all the required consultations follow-up are completed. Follow up with the send out labs about the special results. Arrangement of total body radiation, consultation and preparation with the King Abdulaziz University Hospital team if needed. Make sure all patients, donors are followed routinely in the clinical specialist virtual clinic. It's a daily clinic for us, and we follow all the patients there. Arrange required preparations for patients going for surgical interventions or diagnostic testing. If the patient needs a blood transfusion pre-OR, we do book the patients in day procedure unit or something like that. We coordinate also the HSCT clinic for follow-up for the recipient and donor. Then we provide education support for patients, donor, and their family. Education, it's a continuous process whenever we start transplant, from the first visit until they finish pre or post transplant. So as BMT coordinator, we teach, explain, and provide patients, donors, and their family with the needed information about the HSCT process, support and facilitate hospital visits for patients who are coming from outside Jeddah, especially for the housing, and we get the support from our social services. Prepare the cases and for review and clearance by primary consultant. So make sure all the workups are completed. Prepare all the needed documents to be signed by the consultants. Get the clearance from the primary consultant, from the donor and the recipient to get the transplant admission. And these are the needed documents to be signed. Then we arrange for a BMT admission with the case managers according to the bed availability, book patients for line insertion, arrange for donors stem cell donation in OR if bone marrow harvest or peripheral collection, endorse patients package and roadmap conditioning to the inpatient team once they got admitted, communicate with the BMT lab about the BMT details and day zero through the eDolphin system. For the last step, it's prepare patient and family for discharge, and this we are working on it from day one to give discharge education and instruction how they can deal with the patient at home. What are the follow-up routines as outpatient clinic? Explain the routine timing of the medication taking and lab extractions. And my colleague Hakeem will explain more about the outpatient care for our patients. With this, I'm finishing my talk. Thank you for listening and have a nice day.
Thank you, Ms. Ghada, for this great presentation. I think you cover all the parts from the role. Now, please joining me in welcoming Ms. Tidullah. Ms. Tidullah, she has an excellent experience in pediatric oncology and bone marrow transplantation. She is the senior nurse and the short nurse in pediatric oncology. She will talk to us today about her experience and the pediatric oncology journey to have zero CLABSI. Please welcome Tidullah.
Thank you so much, Mr. Ahmed, for the well-said introduction. Today, I'm going to share to you about the journey to zero CLABSI and pediatric hematopoietic stem cell transplantation. Hematopoietic stem cell transplantations, or HSCT, has become a widely used modality of therapy for a variety of malignant and non-malignant diseases. While many advances have been made in the field, infection remains one of the most severe and frequently encountered complications of HSCT. In these presentations, we review the defects in host defenses and important risk factors predisposing an HSCT recipient to infections, the major categories of infections and their time courses following transplantations, and preventive strategies. Infection is a major cause of mortality and morbidity in the hematopoietic stem cell transplant population due to regimen-related toxicity. Improvement over the past couple of decades, especially in supportive care, have helped to reduce the risk. We will also discuss the common bacterial infections that our transplant patients develop. You can see in this background, these are the diagnoses that were usually handled, and the sickle cell anemia is the highest percentage, and the other side is the transplant that we also handled, the allo, the auto, and haplo-BMT, and the allo is the highest percentage. There is a timing of opportunistic infection in HSCT recipient. The 3 periods of immunodeficiency occur following hematopoietic stem cell transplantations. The first one is a pre-engraftment, which is day 0 to 30. The second one is the early post-engraftment, which is days 30 to 100, and the late post-engraftment until day 100. The immune suppression that takes place during each of the periods conveys a particular risk for infection and drive the use of standard prophylaxis following transplantation. These 3 phases, if you can see in the graph, the pre-engraftment, the post-engraftment, and the late paste, the risk factors, all patients have this neutropenic. All these T cells and B cells are depressed, and there is already presence of GVHD. And for the bacterial, there's a presence of gram-negative bacilli and encapsulated bacteria. Fungal, you can see the Candida, the Aspergillus. And for the viruses, there's a presence of herpes simplex virus, CMV or cytomegalovirus, and other viruses. MDRO, or multi-drug resistant organism, have emerged as significant pathogens in hematology and hematopoietic stem cell transplants recipients. Neutropenia and malignancy are independent risk factors for MDRO invasive infections. These are the common bacteria or organisms that our patients having or have the Streptococcus pneumonia, and these are the number of days. The highest one is the Rhizobium radiobacter, which is appear within the day +1 to day +22. Pathogens in the immunocompromised host typically suffer sepsis at the hands of known or familiar enemies like E. coli, Pseudomonas aeruginosa, Klebsiella, Streptococci, Staphylococcus. An immunocompromised neutropenic host has much more to offer to a bacterium with ambition. There is some list of organisms which one needs to consider in addition to above. These are the list of the bacterial infection following HSCT. There are bacterial pathogens, predisposing risks, and clinical manifestations. In early post-engraftment, which is 30 to 100 days post-HCST, Klebsiella, CNS, and Staphylococcus aureus. This one is from the day +1 to day 90. This is the highest percentage from the Klebsiella pneumoniae. The second one is the Staphylococcus aureus, and the third one is the CNS. The most common in pediatric HSCT over 10 years is Staphylococcus and the MRSA. In the graph, the Staphylococcus aureus MRSA is the highest percentage, which is this one is within 10 years. We have this 3.6%, and the MRSA for 10 years is 5.16%. What is the difference between the Staphylococcus and MRSA? The Staphylococcus is the group of the bacteria responsible for staphylo infections, with Staphylococcus aureus being the most formed. The main difference is that the non-MRSA generally responds well to a variety of antibiotics, while the MRSA may only respond to a few, and it's really hard to physicians or to the nurses to treat. There are risk factors for infection following HSCT. It depends on the severity of defects in host defenses, and the subsequent risk of infections are influenced by a complex interaction between several factors, like underlying illness of the patients, the conditioning regimen, the graft and the closeness of the match, the type of transplant, the degree and the durations of neutropenia, disruptions of anatomical barriers like mucositis and within-dwelling catheters, depressed T and B cell functions and immunosuppressive therapy, and the presence of GVHD or graft versus host disease. Infection preventions like antimicrobial stewardship and antimicrobial prophylaxis are essential for control and management of MDRO. Hand hygiene, environmental cleaning or disinfection, isolation and surveillance are indeed the backbone of effective prevention programs. In 2014, the World Health Organization declared antimicrobial resistance a worldwide threat that requires urgent action. Infections are a major cause of morbidity and mortality in allogenic transplantations. Therefore, it is crucial to have a skilled nursing team to assess, prevent, detect, and treat infections. Delays in diagnosing and infections that result from a depressed inflammatory response may lead to increased susceptibility to a broad range of potentially life-threatening organisms. There are some nursing consideration in care for infections. The 5 moments for hand washing, like before touching a patient, you should wash your hand. After touching the patients, before cleaning or septic procedure, after body fluids exposure, after touching patients' surrounding. One of also the consideration in care is the assessment and early detections. Like for the Hickman line site, we should be vigilant for this one. Is there any swelling, discharges, or early pain? For this one, we should inform the doctor right away. For any presence of mucositis, anal fissure, or any skin integrity like bruises or different kind of wounds, you should assess and inform the primary right away. We're also giving or sharing the education to the patient, the sitters, and also for the healthcare worker to prevent the spread of infection or to prevent the contamination or the patients might have this kind of infections. The isolation precautions also. Isolations like standard and contact is one of consideration in care. Personal hygiene, equipment and cleaning, hand hygiene, CVC management, personal protective equipment or PPE, access to low environmental loading department, movement of patients like transporting to any ward in the hospital, low bacterial diet, psychological support, health education at discharge. Why is so important for the precautions to adherence? The applications of contact precautions require that gowns and gloves should be worn when entering the patient's room and removed before leaving it. Dedicated equipment such as stethoscope or blood pressure cuff remain in patient's room and not to be used for other patients. Contact precaution may also include single room isolation, an entire isolation ward, or quarantine of a group of patients. The aim of contact precaution is preventing the transmissions of epidemiology important pathogens from a colonized or infected patients through direct or indirect contact. In addition to hand hygiene, appropriate contact precaution measures should decrease the risk of MDRO transmission. The most important recommendations concerning the preventions of CVC-related bloodstream infections are hand hygiene and maximum barrier precaution, appropriate choice of insertion site and catheter material, plan an echo-guided insertion when possible for both centrally and peripherally inserted central lines, use of 2% chlorhexidine for skin antisepsis for continuous and discontinuous antisepsis of the exit site, use of sutureless devices like stoplock for fixing the catheter wherever possible, use of appropriate dressing, removing the venous catheter when no longer necessary, assessment, inspections of the exit site should be performed daily, proper handling of parenteral solution, proper management of infusive lines, educations of the patients on the need to inform the nurse if changes at the level of the CBC are noticed. MRSA should be placed under contact precaution until antibiotics are discontinued and until 3 consecutive cultures taken more than 1 week apart are negative. Screening cultures for MRSA include the anterior nares, any body sites previously positive for MRSA, and any wounds or surgical site. In this matter, our unit made a plan or significant action plans. Like in 2016, we started to review the privileged staff for CBC management, like Scrub Hub. Like we're using this alcohol swab for 1 minute time and 1 minute dry time. And we also started to review any literature review related to MDI, collaboration between nursing team members, primary nurse, nurse clinician, head nurse, unit council chairman, program director, and executive director. In 2017, we also started to use a chlorhexidine, wash spray off, and Covenant stick for skin protection. We're using the 4% chlorhexidine wash for prior 24 hours. And also we started to practice the body system. Body system means that we are not doing the Hickman line, changing line, Hickman line dressing alone. We are with somebody to assist us, to observe us, and to make the environment in a sterile, very clean. In 2018, we started to assign task force within BSI group members for CBC management, patients' personal hygiene, wound care, and environmental rounds. Collaboration with the product coordinator in regards to the supplies of CBC care. In 2020, collaboration between multidisciplinary members, nursing, medical infection control, and pediatric infectious disease. And also start the CLABSI bundle new assessment and documentation. In 2022, the aseptic non-technique is used to prevent the risk infection. This one, we're not using, or we're not doing the alcohol swab anymore. If we're doing the blood extraction through central line, we are using the alcohol cup for before and after of this blood extraction. And also review the IV line change duration and minimize manipulation. This one is approved by the infection control. Before we are changing the lines like every 4 days, but now every 7 days to minimize the manipulation of the lines. Thank you.
For the next presentation, please welcoming with me Mr. Abdelhakim Salama. Mr. Abdelhakim is senior oncology nurse and BMT clinical specialist, specialized in oncology and intensive care unit. Abdelhakim is working since many years with bone marrow transplant as a coordinator in King Faisal Specialty Hospital. He's going to present his journey during post preparation for the patient bone marrow transplant. Thank you, Abdelhakim.
Thank you, Ahmed, and I would like to thank the organizing committee who gave me the opportunity to be part of this event. And as my colleague Rada, she covered the BMT preparation, I will be talking about the BMT post-transplant outpatient care. This is the outlines of my topic. And as you all know, that post-stem cell transplantation period is a critical chapter in the patient journey towards recovery because it's a very long process. Patient going through pre-transplant preparation, admissions, and going through the complication, ended by our post-transplant long process also. That makes here a very critical period. Effective follow-up and comprehensive care are essential components that significantly impact on the outcome and the quality of life for post-transplant. And in general, our PMT patient post-discharge need to be seen in the post-PMT clinic weekly or more frequently for the first 6 weeks. Then if they are stable, they can be seen every 3 to 4 weeks for the next 2 months, every 2 to 3 weeks for the next 2 months, then every 3 to 4 weeks, and depending on their clinical status. And once discharged from the hospital post-transplant until the day 120, they will be advised to wear a mask at all times except when at home, and they will be avoid places, the public places, and until day 120 work, where each patient will be evaluated on a personal basis. Excuse me, sorry, there's an updated one. This is not the one, sorry. If you can just quickly find it. Sorry for that. I just add some slide. I just need you to see. Yeah, this one. Thank you. This is in the picture here. This is an excellent proposal, can be implemented in post-transplant clinics in the hospital. It's a systematic one, and this will help you to identify any potential complication occurs post-transplant. It's cover the whole body systems, and under each system there's checkpoints. This will help you to identify any potential problems happen post-transplant. Routine lab post-transplant in the post-PMT clinic. Usually we do CBCD, renal and hepatic profile, lipid profile every 3 to 6 months, thyroid function test at 3 and 6 months within the first year after the transplant, and other times as clinically indicated. We do CMV monitoring. It should be continued initially weekly until the until completed of first year transplant for allogenic recipient at risk of who are at least at risk of late CMV disease, and annual chimerism up to from the first year up to 5 years post transplant. GVHD follow-up occurs in 30 to 40% of patients post-transplant. In the clinic, full assessment and physical examination to the skin, liver, and GI must be done. We have to check the signs and symptoms. Sometimes skin and liver biopsy for diagnostic purpose. And patient with progressive or chronic GVHD are to be, it's very important to discuss them in the multidisciplinary BMT meeting. And patient on extended steroid therapy like GVHD patient are high risk for vascular necrosis of bone. That's why vitamin D and calcium supplement should be considered in this patient. Also, female patients should be on hormone replacement. Antimicrobial prophylaxis, this is the tough part in my topic, but because it's very huge, and I will try to give you the most important things that you need to know. With the absence of GVHD, most patients have adequate immune reconstruction by 1 year after the transplant. Patients with chronic GVHD remain immunodeficient and have a high risk for infection. For BCB patient, they should receive prophylaxis against the BCB for at least 6 months after transplant and until the immunosuppressive medication have been discontinued. The preferred drug is trimethoprim sulfamethoxazole. Varicella zoster infection for those patients, seropositive patient, whether is via vaccine or via disease, should receive prophylaxis, acyclovir, throughout the first year after transplant and until day 8 after systemic immunosuppression end. The acyclovir dose is 800 milligram BOPID. Encapsulated bacteria post-transplant patient with a chronic GVHD are highly susceptible to recurrent bacterial infection, especially with encapsulated bacteria such as Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitis, as they are functionally acyclinic. Again, trimethoprim sulfamethoxazole recommended as the first-line drug for prophylaxis for infection with encapsulated bacteria. There are other groups who should consider for encapsulated organism prophylaxis, including those who are patients without GVHD but are receiving glucocorticoid or other immunosuppressive medications, patient with persistent or manifestation of chronic GVHD without immunosuppressive medication, or patient being treated with relapsed or progressive malignancy after transplant, and patient who had surgically or functionally asplenic. Also, patient receiving systemic immunosuppressive therapy for chronic GVHD should receive antibiotic prophylaxis against infection with encapsulated bacteria for at least 6 months after discontinuation of the immunosuppressive medication. They will receive double-strength trimethoprim sulfamethoxazole, 800 milligram given as a single dose daily, which is adequate for prevention with both BCB and encapsulated bacteria. Disease monitoring and blood and bone marrow. So patient with the CML or Philadelphia positive ALL should have a blood tested for BCR-ABL at 6 months in intervals for the first 2 years after transplant and at yearly intervals. When BCR-ABL are detected in the blood, marrow aspirate should be evaluated by cytogenetic testing, morphology, and molecular testing. For AML patient with a FLT3 TID, NBM1 or c-KIT should have a blood tested at 6 month intervals for 2 years after transplant and then at yearly intervals. For lymphoma patient, PET-CT or CT scan as indicated. Chimerism is one of the important indicator post-transplant. It's the ratio of recipient to donor cells. It's essential for monitoring the engraftment of donor cells to assess the graft failure or relapse post-transplant. And it should be done like monthly for the first 3 months, then a day plus 180, then yearly up to 5 years. And the study will be performed on separated T lymphocyte and myeloid cells. This is the recommendation screening post-transplant. We have implemented this form and we use it in our BMT clinic. We do 6 months and annual workup post-transplant. It's also a systematic one, cover the whole system, and tell you about any potential complication occurs during the post-transplant. Gonadal dysfunction or the ovarian failure due to radiotherapy or chemotherapy. The optimal care for those patients includes regular gynecological exams and screening every 6 months, at least for the first 3 years post-transplant. These exams can help to identify and treat any complication that may arise. Then we'll talk about the prevention of osteoporosis. We have to monitor in women the annual measurement of FSH and estradiol. In men, annual measurement of LH, FSH, and free testosterone. Baseline and follow-up prostate exam, measurement of PSA and lipid profile in men who are being treated with testosterone. And the management is minimizing the daily and total cumulative glucocorticoid exposure, optimizing calcium and vitamin D intake, participating in the weight-bearing exercise, and also bone strengthening drugs, including the biphosphonate. Return to the work or school post-transplant. So patients should not be returned to the work or school before 6 to 9 months or maybe later post-transplant, unless there is significant professional or financial hardship. Home tutors can be arranged, or perhaps the patient can work at home or at the office during the off hours. Moreover, patient don't feel capable to full workload before the 6 or 9 month post-transplant. For the activities of daily living, we have to encourage the patient for exercise, for his appetite start to improve and salivary function, smell and taste return after chemoradiotherapy. Anorexia may persist in patient with using cyclosporine. Contact with household pet, but not feces and gardening are safe. However, contact with barnyard animals swimming in public or private pools should be discouraged for the first year, and patients should avoid the use of pesticides, solvent, fertilizer, or other immunosuppressive agent. Sexual activity may be resumed. So in summary, excellent care post-PMT is very important for the success of the transplant. It might extend for several years post-transplant and based on the patient status. Complicated cases post-BMT must be discussed in the multidisciplinary meeting. GVHD, herpes zoster, and other post-BMT complications must be assessed and treated properly. The annual assessment, including the chimeric study, must be done on time and reviewed by the team. Return to school or work post-PMT should not happen before the 6 to 9 month post-PMT and based on the clinical assessment of the patient. With that, I finish my topics and thank you for listening. Thank you so much.
Thank you, Mr. Abdul Hakim, for this fantastic presentation. Ladies and gentlemen, it's my pleasure to introduce our next speaker, Ms. Dua Al-Sadda. Ms. Dua, she works in adult oncology as a discharge specialized nurse. She play a vital role in discharging the patient, also in patient education, especially in BMT. Dua, she has an extended training and education in oncology, hematology, and bone marrow transplantation. Dua will tell us today about the discharge preparation for BMT patient. Welcome, Ms. Dua.
Hi, good afternoon. Today I'm going to talk about the bone marrow transplant discharge patient. So our objective for today, what is the introduction first. So what is the process of discharging BMT patient? An important point for the patient should know before discharge, when the patient need to come to the emergency. So as introduction, discharge planning is interdisciplinary system process which aids aids patient and their family to develop feasible plan of care after hospitalized. This process should result in the safe, timely, and appropriate discharge of patient to their next level of care, whether ambulatory care service or home or to another care facility, with all information and education that patient need. Planning the patient for the discharge with a clear information will help us on reducing the length of stay for the patient, reducing emergency readmission need for the patient, reduce the pressure on the hospital beds, reduce the patient concern and question after discharge. So the process, it's a circle, a process: admission the patient 2 to 3 days before discharging the patient, day of discharge, and the calling the patient after 24-hour appointment and follow-up. So from the day one, we start our BMT patient education post-transplant. So on the first day, we have a grading team. We're going to visit the patient, educate the patient, welcoming the patient to our hospital, and give the patient all the information about our hospital, like the patient right, who's the team the patient may need, how to reach the team. And we will ask the patient to release out all his concern to be answered, and what the things that may he need when he will be discharged. So from day one, we are preparing the patient to be ready for the day of the discharge. 2 to 3 days before discharging the patient, we are just follow up with the patient. All his need, all his concern was solved. Caregiver are ready to deal with the patient at home. Patient ready and well known about his care that he need at home to do. On the day of the discharge, we just need to be sure that the patient will discharge with everything. So 2 to 3 days, we are sure the patient, all the facilities is ready to giving to the patient. On the day of the discharge, we just need to clarify that the patient received it already. Calling the patient after 24 hours, just to be sure that the patient dealing well with himself at home, medication giving on the time. He don't have any concern, any complication at home. Regarding the appointment and follow-up, just to see the progress of the patient post-transplant. So this is the discharge planning checklist we are using. As we said, first part, it's on the day of admission. Second part, it's the period discharge meeting, like before discharging the patient, like 1 week. Then the third part, it's 2 to 3 days before discharging the patient. Day of discharge, this is the things that we just need to be sure that the patient receive everything and he's ready for being discharged. So this, the instruction that we put on the patient room, just to be sure that the patient know everything, and the patient on daily basis, he's updating about his health situation. First table, it's the communication board. Here we are writing the patient name, MRN, day of admission, as well as the consultant of the patient. Day of discharge, actually we are putting it once we know the patient will be discharged on this day. Then the second part, second line, it's the concern and the patient question. Sometimes the patient will do it on a separated paper, and sometimes he will just put it there. Other one, it's the daily treatment plan. Like today, the patient will have a procedure, he have CT scan, he have a specific treatment plan. We will put it there if he need to be fast or not. Then the third one, it's the changing the shift. And how is the patient today? Is there any pain? Is there any concern not answered? Anything that we can help the patient. Third part, it's the, Then the third part, it's the following assessment for the patient, because still short. It's okay. You just try to. So it's about the patient fall down, because sometimes the patient get dizzy with the medication, with the chemo, with kind of medication like sedative medication. So we just need to be sure that the patient not on high risk for fall. That part here, yes, that part, it's the communication, the numbers that the patient may need. It's the patient relation, cleaning, head nurse, and the social worker. And that one for the dietitian. This part for the patient, if he have any needs, like he cannot hear or he cannot walk or he's blind. So there in the pressure injury, that I'll just ask the patient just to do the scan in case that he will see any progress things on his skin, like pressure injury, like only first stage. So once the patient see any change, he can tell us, so we can treat the patient as fast as possible. So he will not go in second or third stage. It will be difficult for us. For the fall, we just ask the patient to do the scan as well, just to know how to prevent himself from falling down, as well as for the caregiver, just to be sure that the patient is safe and he will not be in the fall side. Here, it's about the dietitian, food that the patient need to eat during the process of transplant and the chemotherapy. Usually they will receive their food from our kitchen, but just to be sure that the patient at least know how to deal with the dietitian side when he be discharged. Second, that one, it's about the CVC line. All our patients with the CVC line, Borta, Burma. So we just need to be sure that the patient know how to deal with a Burma cat or Borta cat, just to be away from central line infection. That one, it's just to help the patient about the daily question of the patient. So here, once the patient answer the physician this question daily, he will be known about his situation every day. So every day patient know what's going on with him, and all his concern will be answered as soon as possible. Last one, it's the daily lab routine for the BMT patient, just to show the patient his progress. Anyway, for all this information, we have a Takhasusi application where the patient can just apply this application, put his MR in there, and all his information will appear for him, like the lab, the procedure will be, and what's the result of that procedure. So upon discharge, or like what we said from day one for the discharge, what the education that the patient need to know about his physical activity, diet, medications, and restriction. Actually, all of this part, we have facility work with us, like the diet, it's about the dietitian. They will come to the patient, educate him, tell him what kind of food that we are going to provide and what he need to eat, and what the restriction on the diet side. For the medication, we have the pharmacist. All the pharmacists will assist the patient about the medication, as well as daily process. We are asking our nurse just to educate the patient about all the medication provided to the patient. So before giving the patient the medication, the primary nurse will educate the patient about the medication he's going to take. So on the day of admission, it will not be difficult to the patient to save all that medication, because he already knows once he is in the hospital. As well as our pharmacist will educate the patient, and they have a special table for our patient. They will give it to the patient just to be sure that the patient taking his medication on time. Physical activities and restriction, usually BMT coordinator, they are dealing with the patient and educate the patient about all the restriction and what the daily activity that they need, and how they are going to deal with themselves outside the hospital, like when they finish and be discharged, how they can deal with their own self after BMT. This card should given to the patient before left, just to be sure that the patient receive everything. For first, it's the appointment. We'll just clarify with the patient if he take whole his appointment and he understand where he go. Second part, it's about the CT, the radiology system, all the procedure about the radiology, if the patient have a CT or any kind of radiation. Did he take the appointment and he take the instruction that he need to know. Third part, it's about the physiotherapy. Some of our patients after transplant, they get a little bit sick. So sometimes they are losing their activity. So we transfer them to physiotherapy. So on the day of discharge, they need to have a physiotherapy, home health care or physiotherapy appointment. So we need to be sure that just the patient take this appointment with him. Fourth part, it's about the dietitian. Fifth part, it's about the pharmacist that he received all his medication and he know how to take it. Last part, it's about the medical record. Is the patient take his sick leave, his medical record, if he have any concern or any important paper that he need to release it to his work. So we just need to be sure that the patient receive all his document as well as he can find it in the application. Last part, it's about the side effect and when he need to seek for the emergency room. In the middle, we can see the medical take-home supply. Our patient, sometimes they need supplement. So we just discharge the patient with a supplement from our hospital, but sometimes they need to refill it. So this is the process. We give them that paper just to do the guideline and the steps. Sometimes they can order it. So the hospital will provide it to them at home. As well as for the pharmacy, some of our patients will be in hurry. Some of our patients, they will receive the medication, but still they need to do the refill, but they cannot reach our hospital. So they can follow this paper just to order the medication through the application. Then they can call this Subul just to send the medication home. This is our discharge education about the immunocompromised patient, CVC line, what's happened before getting the treatment. This is about the disease. First one, it's about the chemotherapy and the patient, how to deal with himself during the chemotherapy process. That one, the last one, it's the process of the BMT. Patient need to read it before go to the hospital, before the BMT start, so the patient will know what's the BMT meaning. So when patient need to come to emergency, this two card we're giving to the patient. Sorry. We're giving to the patient this two card just to be sure that the patient know how to deal with himself if he have an emergency case. So first card, it's written there in details if the patient get fever, if the patient get UTI or he get diarrhea, how to deal with himself at home. If still that sign or symptom active, that time he need to come to our emergency room. The small one, it's about that patient. If he cannot, if the patient not from Jeddah, not from Riyadh, not from Medina, so he cannot reach King Faisal, he just needed to the emergency room where he will go. So they can know that the patient need to have done this procedure, taking the blood sample, culture, urine and stool culture, and start the IV. So the hospital will not mess up that BMT patient, and he need to be treated in a specific way. That's all. This is my reference. Thank you so much.
Thank you, Dua, for this valuable information and great presentation. Now, please welcome with me our star for the day, Ms. Nada Turkestani. Nada, she is the acting assistant nurse in adult oncology. Nada, she has a bachelor degree in nursing and a postgraduate diploma in oncology. Nada, she has an extensive education and training in bone marrow transplantation and hematology. Nada will present for us the CAR T cells today.
Good afternoon, all. Thank you, Omri, for the presentation. And thank you all for giving me the opportunity. We're going to talk today about the chimeric antigen receptor, CAR T cell therapy. I know they already covered it in session number 6 with the quality, but we're going to talk about the nursing role in it. So What are the CAR T cells? Chimeric antigens receptors, CAR, are receptor proteins that have been engineered to give T cells the new ability to target the specific antigen, produce an artificial T cell receptor for the use of immunotherapy. The receptors are chimeric because they combine both antigen and antigen binding and T cell activating functions into a single receptor. CAR T cell therapy uses T cell engineered with CARs for cancer therapy. The promise of CAR T immunotherapy is to modify T cells to recognize cancer cells in order to more effectively target and destroy them. So how does it work, the CAR T cell therapy? It goes in many stages. First, apheresis, which is the T cells are isolated and collected from the patient's peripheral blood, leukapheresis. Then activation of T cell. T cells are transformed into cytotoxic T cells. Then comes their transfection, where a gene is inserted using a virus that causes the CAR to be expressed by the T cell. Then the cell expansion, where the cells are in culture, allowing them to expand and proliferate. Then comes the conservation, where cells are purified and cryopreserved, can be a fresh infusion. Then the administration, where cells are infused to the patient. So what are the targeted diseases for the CAR T cell therapy? Allogenic or allo HSCT and CAR T cell therapy are the main modalities of adoptive cellular immunotherapy that have widely permeated the clinical space. The expanding field of immuno-oncology has unlocked the possibility of treating and potentially curing patients with the most life-threatening relapse and refractory hematologic malignancies such as B-cell ALL, which is the third line, then the diffuse large B-cell lymphoma, second and third line, follicular lymphoma, the third line, and multiple myeloma, which is the fifth line. Here are some of the approved CAR T cell therapies. Since 2017, the CAR T cell therapies have been approved by the Food and Drug Administration, the FDA. Kymera was the first CAR T cell therapy to approved by them. Then after that, it comes many of the CAR T cell therapies. As we can see here in the table, started with the Kymera and end up with the Carvykti. Okay, the CAR T cell therapy patient journey. It starts with the primary oncologist in the CAR T cell therapy center or oncology center, hematology center, then identification of eligible patients and evaluate them. Then it goes through the apheresis, bridging therapy, manufacturing, lymphodepletion, infusion, monitoring, long-term monitoring, and follow-up. Eligibility. Who are we looking for? The selection of appropriate patients who have the ability to meet the demands of CAR T cell therapies is essential for optimal outcomes. The patient must have the type of cancer that CAR T cell targeted and cured, can be cured. Progression or relapse diseases through standard therapy, needs to have measurable disease. The patient's cancer express the targeted surface protein, able to tolerate apheresis, hemoglobin or platelets, good performance status, and good organ functions. There are some important considerations that we need to consider before starting the CAR T cell therapy to the patient, like timing. Patient needs to be off therapy and for apheresis and prior to treatment, limited apheresis or cell production slots, maintain regular contact with home oncologist, social, travel, time of work, caregiver support, which can be covered with a multidisciplinary team with the social workers. Cost, which is in case of the most recently approved CAR T cell therapy, is more than $450,000. CAR T cell therapy common side effects. There are many side effects. We're going to talk about the most common of them. Starting with the cytokine release syndrome, CRS, neurologic toxicities, B-cell aplasia, tumor lysis syndrome, TLS, and anaphylaxis allergy. We're going to cover the first two, the CRS and the neurologic toxicities due to the timing. Okay, the cytokine release syndrome, CRS, is typically the first observed and appears within the first week after treatment. CRS is also known as cytokine storm, which is caused by a large rapid release of cytokines from immune cells affected by the immunotherapy. CRS can be life-threatening. It can usually be managed through early intervention. Sometimes patients who have received CAR T cell are briefly sent to the ICUs if their hypotension becomes unmanageable. If the CRS grade 3 or 4 becomes too difficult to manage with the regular interventions, then usually the patient will start to be treated with tocilizumab. The most common symptoms of the cytokines release syndrome, it looks like similar to sepsis due to the infection or severe flu-like syndromes, such as a high-grade fever, tachycardia, hypoxia, hypotension, decrease in liver or kidney functions, and prolonged PTT and risk of bleeding. As we said, it can affect many organs. Here are some organs that can be affected, like skin, gastrointestinal, respiratory, cardiovascular, coagulation, renal, hepatic, and neurologic. Moving to the second common side effect that we're going to talk about today, it's the neurologic toxicities. The patient could feel like confusion, tremors, gait instability, aphasia, or other difficulties in speaking, seizures. Neurologic toxicities may occur separately from CRS as well. The multidisciplinary care for patients receiving the CAR T-cell therapy. Care for patients receiving CAR T-cell therapy involves a multidisciplinary team, including physicians, advanced practitioners, nurse coordinators, nurse educators, apheresis nurses, inpatient and outpatient nurses, cellular therapy technologists, case managers, social workers, and many more. Dedicated educational efforts for patients, caregivers, and clinical providers that make up multidisciplinary care team are warranted for optimal treatment. Nursing role in CAR T-cell therapy. Nurses administrating the chemotherapy should be knowledgeable about the sequence, duration, administration, and safe handling considerations of the chemotherapy regimen. The nurse taking care of the patient should have a thorough understanding of CAR T-cell therapy, the infusion process, and the toxicities associated with this therapy so that he or she can be the best support for the patient and their caregiver. Oncology nurses play a crucial role in monitoring and managing the side effects associated with the CAR T-cell therapy, as well as educating the patients and their caregivers' families on what they may experience before, during, and after the treatment. Patient and caregiver education. Nurses working with these patients should educate family and caregivers in early recognition and reporting of CRS and neurologic symptoms. The education will help in reduce the patient and caregivers' anxiety and increase their compliance to the treatment. The patient and their caregiver should be educated in depth about the side effects and toxicities associated with the CAR T-cell therapy, including what to watch for management, when to call the coordinator, and when to go to the nearest emergency room. Patients and caregivers should be educated about the increased risk of infection due to prolonged cytopenias and B-cell aplasia, so hygiene and infection prevention strategies should be educated as well. The patient should monitor for any signs of relapse, including fever, night sweats, and palpable lymphoadenopathy. Moving to the patient and caregiver education upon discharge. Here comes the role of the discharge nurse. Patient needs to be reminded that they are required to stay close to the hospital where they receive the CAR T-cell therapy for at least 4 weeks after the infusion of the product in case of emergencies. The discharge nurse will provide the patient with a wallet card that contains information of CAR T-cell therapy, important contact information, and reasons to seek for urgent care. The patient should be instructed to always have the card with them in the event of medical emergency. The patient and caregiver should be instructed that the patient should not drive or operate machinery for 8 weeks at least after the infusion because of the risk of the late onset of neurologic events, such as seizures, as we talked about before. To conclude, CAR T-cell treatment for cancer patients has shown promising outcomes. However, many remaining challenges need to be considered. The high quality of CAR T products needs to be ensured through optimization of protocols on long-term safety, requires further study. Similar to ALLO HSCT, disease recurrence after CAR T and treatment-related toxicities require ongoing innovation in product development and toxicity mitigation strategies. That's it for me. Thank you so much.
Thank you, Nada, for this great presentation and update. Ladies and gentlemen, please welcome with me Miss Amani Mustafa. Amani, she is the stem cell quality coordinator since 2019. Amani, she has a background in ICU and renal transplant for more than 25 years. She is involved in many researches in our hospital as an investigator. Also, Amani will tell us today the JASI accreditation, some rules about the JASI accreditation and quality management in BMT.
Thank you, Ahmed, and the organizing committee. Thank you all. We'll go through the quality in the HSCT, the GCI accreditation, the HSCT journey to get the award of the accreditation, HSCT program facts and activities, and take-home message. So why quality in the HSCT? As you can see, the quality is a cherry on the top of the cake. You know, physicians, nurses, they cannot work without a quality. So the quality to ensure the procedure are being performed in line with agreed standard with full participation by all the HSCT team members. Track and monitor the harvest process from the time of donation to the administration. Identify risk areas and work on it proactively to eliminate the patient risk at any step. Investigate safety incident and set an action plan to avoid such incident in the future. Formalize training and educational competencies. Review policies based on evidence and standard to achieve compliance on a regular basis. Also maintain effective communication, coordination between the HSCT sections, a clinical team, collection team, and laboratory processing. So why JASI? The hospital is accredited in many organizations and accreditation, but why JASI? JASI is a specialized accreditation aiming to promote high quality patient care and laboratory performance in hematopoietic stem cell collection, processing, and transplantation through an internationally recognized system of accreditation. So as you can see, JASI standard in the three sections, the clinical, the collection, the process, quality management is a part of this and is the main part in each standard. So the HSCT program facilities have a collaboration and coordination between each other. And this is the interaction between all the facilities, as you can see, the clinical facility, processing, apheresis, bone marrow collection, and the other facilities. What I mean by other facilities here, the pharmacist, the radiation therapy, the data manager, everyone, maintenance and infection control, engineering, everyone helping the HSCT team. So HSCT program journey, this is the fact regarding to the program. The program started in 2001 with adult service, started with only 10 cases. You can see only line under each milestone, but it takes time and effort from all the team. It's not only one man show, it's a team effort and time. So in 2005, they started the pediatric. In 2014, the gap analysis done for the current practice against the JASI standard and the quality management committee formulated. In 2015, they built the infrastructure for the safety reporting system and dedicated clinical pharmacist for the program. In 2016, they published the first HSCT annual report. In 2017, the team created dedicated HSCT policies and the procedure and form were published under the policy management system to support the program and formalize and follow the standard. In 2018, the dedicated outpatient HSCT clinic was established. In 2019, dedicated outpatient HSCT treatment area was established. A refurbished BMT lab processing to category D. Documents were submitted to JASI accreditation, mock survey on-site visit of JASI. In 2020, the team celebrated the JASI award, which is granted in July 2020, and they implemented the COVID-19 precaution in the HSCT program. In 2021, adult HCT outpatient program was established. In 2022, we crossed the 100 cases. In this year, till September 2023, the program reached 1,000 cases under adult and pediatric. And this is a big achievement, and I would like to take this opportunity to appreciate everyone involved in this achievement. Let's take an overview about the program. As you can see, the program started in 2001 with 10 cases and reached to 1,000 in September 2023. The program here distributed by the service and by the transplant type, allogenic and autologous, and pediatric and adult. Also, I would like to take this opportunity to appreciate the data manager and data registry who registered our cases under the EBMT program. And this is the EBMT benchmark report. We received it from the EBMT organization. And as you can see here, at the beginning in 2015 till 2019, it's clearly worse than average. But with the improvement and with the effort of each one, the system improved in 2016 to 2020, and clearly better than the average, which is 98.9%. And we continue doing the improvement till we reach 99. This is for the allogenic cases. For the autologous cases, the same. It was 37.6%. We reached 99.6%. Here, this is the EBMT benchmark report regarding to the 100-day mortality. For the allogenic, our center is within the range, and you can see this is highlighted by the blue color. For the autologous, also within the range, and it is 100-day mortality. The HCT program or activities, the program has many activities. Start with the key performance indicators, which includes 30 days and 100-day mortality, 1-year survival, acute and chronic GVHD, engraftment data, central catheter-related infection. Audit, we have many audits over the year, donor screening and testing, verification of chemotherapy administration against the written order, Med-A compliance, verification of chemotherapy drug and dose against the prescription, ordering a system, total body irradiation, external and internal. The system deviation, if any system deviation, we have to report it in the safety reporting incident, and also we have to document it in a variance forms. Others, we have a weekly meeting for the HCT quality meeting, weekly meeting for policies and procedure to review, monthly educational competency, monthly HCT combined meeting to discuss any mortality or engraftment failure, performance improvement project and researches. Over the years, all the team, nursing, physician, and pharmacist and quality, they did many research and many projects. For this year, we have a 3 research and a 3 project. So what is the take-home message? Quality is always a priority in every aspect of the HCT process. Maintain patient safety is a crucial. Continuous training and update knowledge are necessary. Audit review, update of policies and the procedure is important. Safety incident report is required. Communication is the key of the success. As you can see, if not documented, that's mean not done. So those people that documented and still valid till today. So documentation is very essential. Quality is everyone's responsibility. Everyone in the transplantation team is a valuable person. And this is my message to all of you. Thank you.
Thank you, Amani. Okay. Thank you, everyone. I think we are done with our nursing program. Now we give like 5 to 10 minutes for question and answer. Do you have any question? Any questions? Yes. Salam.
And really, it was amazing presentations. But my question, mashallah, all of them, they mentioned that the social and emotional and psychological support for our patient is this service providing by the nurse or there is a psychology specialists to provide the service?
Okay, you want to answer or you want me to answer? Okay, actually, I think this service is covered by many stakeholders in our hospital, many parties. Nursing, they're covering party, social workers, they're covering also parties. There is also all the service they're covering that. So it's really distributed, it's teamwork between all the parties in the hospital.
Because what we know that when you support a patient having cancers, it is really very critical because it needs special skills to provide it to the patients. That's why I'm asking. If it's providing from our nursing, this is a great job, guys, alhamdulillah. And if there is another source, even another source, if it's good, inshallah. Jazakumullah khair.
Yes, thank you. Yeah, I agree with you. Actually, it's something really very important. And as usual, as nurses, we're covering everything. So we are involved in this extensively. Thank you. Any other questions? Hanan, can you use the microphone so we can?
Actually, we are certified to do psychosocial from the social services department. We are social worker. We do for the recipient for the BMT, and we do for the donor as well. So there is really a skills for that, and we are certified for this. Yeah, of course. Yeah, we are practicing for such a thing for the donor and the recipient.
Okay, thank you. Any other questions? Okay, I have two questions. My first question is to Mr. Badawi and Mr. Abdul Hakim. Now, you mentioned the VOD and SOS. Now, is there really an extensive guide or a clear guidelines for our nurses and for the patient himself to identify when there is a VOD?
Yeah, of course, VOD is one of the complications that it's really expensive in terms of treatment. And it might lead to threatening the life of the patient. So that's why nurses need to be vigilant when they come to evaluate or even diagnose VOD. So we look on three parts of the patient. So we look at the bilirubin level. If it's more than or equal to milligram per deciliter, and we are looking for the a patient abdominal girth on daily basis in order to see if there is ascites as well or no. And the third part, which is the daily weight, and the weight should not be exceed 5% from the baseline. So this is the three categories that nurses have to be looking on daily basis within the first 21 days of transplant.
Okay, good. Thank you. Is there anything also for the patient so in case if he notify anything from this before the nurse, he can notify the nurses? Any kind of education or?
Yeah, of course, it's a multidisciplinary responsibility when it's come to patient education in terms of transplant complications. Nurses, coordinators, and physicians have to be doing their role in terms of patient education. They have to be educated about these findings. And if you notice that there is any accumulation of fluid in the peripherals, like legs or hands or even and face, they have to report such findings to the physicians in order to investigate more about the VOD or sinusoidal obstructive syndrome.
Okay, good. Thank you. Thank you, Badawi. My second question to Amani. Amani, what's the next? Yeah, I think now we have just you already. We think we are in the somewhere in the top. So what's next?
We are maintaining our quality in all aspects, as you all say, and the next preparation for reaccreditation. Reaccreditation will come in 2025, but we will submit our document in 2024, inshallah. So we are maintaining what we achieve. Always there is a room for improvement, but we are maintaining what we achieve and also working to make it better.
Okay, good. Any plans for expansion for BMT?
We wish.
Okay, any question? Thank you all for attending. We appreciate your attendance. Thank you for the organizing committee, for everyone. I think we will come back at 3:25. So now you can have break till 3:25. Thank you.
Hello?
Right. Thank you so much for inviting me, Dr. Ibrahim and Dr. Nahla, and the organizing committee for this successful program. The last session today will be about AML. So it's my pleasure to moderate this session, focusing on optimizing treatment outcomes in patients with AML. The last few years have advanced the knowledge and the treatment targets for AML, and we are moving toward precision medicine and personalized medicine in AML. We're very glad to have Professor Naval Daver with us. Professor Daver is a professor and director of the Leukemia Research Alliance program in the Department of Leukemia at MD Anderson, Houston. He will speak to us on maintenance treatment for FLT3 AML post allogenic stem cell transplantation. So without further ado, Professor Daver, the mic is yours.
Thank you. Thank you very much. Are you able to hear me?
Yes.
Yes.
Okay, great, great. I will share my screen and we will move with the presentation. Let's see, put this in the slideshow. Okay, so, I'm going to be speaking about maintenance in post-transplant setting. Thank you very much for the invitation. Pleasure to speak to you all. As was mentioned, there is a lot of progress happening in the treatment of AML, but there's still a lot that we can do to improve this further. And transplant is still very, very much a part of the treatment regimen in acute myeloid leukemia. I do not think we are getting away from transplant. If anything, we are probably actually doing more transplants in our recent experience at MD Anderson, especially in older patients, because of successful use of HMA-VEN as well as FLT3 and IDH inhibitors. So I think we really now are focusing in the last few years extensively on how we can improve the post-transplant outcomes as well as improve the general approach to delivering transplant. These are my research and advisory disclosures. So firstly, I think it's important to realize that a lot of the progress in AML has come from better understanding of molecular architecture of the disease. This is one of many studies that have now outlined the molecular architecture in acute myeloid leukemia, showing that AML is quite a heterogeneous disease with many different mutations that can be seen, and many of these are both prognostic and more becoming therapeutic. So FLT3 is very, very common mutation. This is seen in about 1/3 of all AML, has two different types, as you know, the ITD and the TKD, and both has prognostic and therapeutic impact. But there are others as well that are now becoming more and more important, including IDH1, IDH2, NPM1, MLL. And I think we will see more and more with time emergence of additional targeted therapies and molecular directed treatments for such patients. So beyond using the genomics for prognostication, which is something that is now being incorporated in the NCCN, in the ELN, and is being done extensively in most large academic centers treating acute myeloid leukemia, we are also using these for treatment decision, either in the frontline or the relapse setting, or potentially in both settings. FLT3 mutations, as I mentioned, now there are a number of FLT3 inhibitors approved, 3 approved, and 1 that is commonly used, sorafenib, midostaurin, quizartinib, gilteritinib, IDH inhibitors as well. There are now multiple IDH inhibitors approved in the relapse refractory setting in the US, and these are now starting to get approved in the Middle East, Europe, and other parts of the world, which is great in the frontline setting and potentially in the salvage setting. And another very interesting group I won't talk about, but I think is going to be of high interest in the next 1.5–2 years, is the group of menin inhibitors that work for MLL rearranged and NPM1 mutated AML. There's 5 different menin inhibitors in trials, initially in salvage, but very quickly the trials have moved to the frontline in combination treatments. And then the 2 groups for which we don't yet have a clear targeted approach that is effective, but a lot of ongoing research will hopefully give us some directions, are TP53 and then the RAS mutation, which is a very common pathway of resistance to many different molecular targeted treatments, including FLT3 inhibitors, IDH inhibitors, and venetoclax. So kind of moving more into the focus of FLT3, as I mentioned, it's important to note there are two different types of FLT3 mutations, the ITD, which is the common mutation, which is about 80% of all FLT3 mutations detected in AML, and the TKD, or the D835, as it is also called, which is less common, about 15 to 20% of all AML. Now, this is important not just theoretically, but also to select the right FLT3 inhibitor, both in the frontline and in the salvage setting. There are certain FLT3 inhibitors like the gilteritinib, midostaurin, that can target both the ITD and the TKD. These are the so-called type 1 FLT3 inhibitors. And there are some like the quizartinib, which are very, very potent, but they will only target the ITD. These are the type 2 FLT3 inhibitors. And what we can commonly see is if you use a drug like quizartinib, especially let's say in the frontline setting where it is now approved in the US recently and will probably become available in the rest of the world soon, one of the major mechanisms of resistance we expect based on previous publications and research by our groups and others is actually the emergence of on-target TKD, which means then that patient could be sequenced to a type 1 inhibitor-based regimen, such as with gilteritinib, and you could still see efficacy. So very similar to CML, chronic myeloid leukemia, where we use molecular sequencing on treatment at the time of molecular or morphological relapse to select the subsequent TKI that overcomes the mutational resistance. This may be the way we start looking at FLT3 as more and more effective FLT3 inhibitors with different kinome and different profiles are emerging. So firstly, I think it's important to note that there are many different types of FLT3 inhibitors that have been evaluated in randomized phase 3 studies. This is just a summary of 6 of the large phase 3 studies that have been conducted that have shown that FLT3 inhibitors improve survival in every setting. These include incorporation of FLT3 inhibitors in the frontline setting, quizartinib in the quantum first setting, midostaurin in the RATIFY study. You see those two first curves both showed adding a FLT3 inhibitor to intensive chemotherapy in frontline eligible for intensive chemo patients improved survival. 2 maintenance studies that I'll talk about more with sorafenib, both showed in randomized phase 2 studies improved EFS and OS, and of course the large phase 3 Morpho study with gilteritinib that we will discuss more also showed a clear improvement in clinical outcomes and is something we are using. And then in the relapse setting, single agent FLT3 inhibitors, both gilteritinib and quizartinib showed improved response and survival compared to salvage intensive chemotherapy. Now, that being said, you can clearly see that there's still room for improvement. Even in the frontline setting with quizartinib midostaurin, we're still around 50 to 55% 4-year survival, not at 80, 90% as we are with core binding factors and others. So there's still room for improvement. And in salvage, of course, there's room for a lot of improvement, probably with combination and other approaches. So now what about using these as maintenance? You know, the most focus in the last 10 years as FLT3 inhibitors have been developed has been in the salvage setting, integrating them to frontline intensive chemo, or now adding them to HMA-VEN. But since these drugs are quite effective, even at a low molecular level, and are well tolerated and can be delivered continuously, again, very similar to the TKIs that target BCR, ABL, and CML, it's a very obvious question to say, why can we not use them in an early intervention setting, whether we call this maintenance or early MRD detectable intervention? I think it is a similar approach. And here you see the concept of maintenance is basically in patients who have achieved remission and do not have a detectable MRD. Now, this is critical because not having a detectable MRD is very, very dependent on the sensitivity of your MRD assay. And this changes every 5 to 10 years. We have seen this in ALL. What we used to call non-detectable 10 years ago, for example, with flow or morphology, today we are 3 logs lower than that with clonoSEQ high sensitivity molecular NGS approaches. And we are seeing that many people that we said we're getting maintenance for MRD negative disease, in fact, we're actually getting treatment for extremely low, but now with better technology detectable disease. And I think this is something we are starting to see in the FLT3, where instead of using flow at 10⁻⁻⁴, we are starting to use more and more NGS that can go down to 10⁻⁻⁶, 2 logs lower, and we're capturing many patients who actually had low burden disease and could be targeted with these treatments. So this is the current status of the NCCN recommendations. These will probably be updated in the near future. This was from early 2023. Maintenance is added and considered a part of treatment. Oral azacitidine maintenance for patients who have completed intensive induction and consolidation and cannot go or are not able to go to transplant. But for those who are able to go to transplant, post-transplant maintenance, the only recommendation at this time from the NCCN is to use the FLT3 inhibitors. They actually do include all the FLT3 inhibitors as potential options, sorafenib, midostaurin, or gilteritinib, although I will say the level of data is not really the same with all of these, especially with midostaurin, where the data for maintenance is very limited post-transplant and actually was not clearly showing a superiority. So we have not used midostaurin maintenance in general post-transplant. We have been focusing previously on sorafenib, but now looking more at gilteritinib. So this is the data with sorafenib. This was actually a study that was led by Dr. Ali Bazarbashi from Lebanon. This was initially a pilot study to assess feasibility, safety, dosing regimen that can be given, and duration of maintenance in patients with FLT3 mutated AML who went to allotransplant. Now, these were actually relapsed patients, and after proceeding allotransplant, we knew that their risk of relapse remained very, very high. Historically, as you know, relapse FLT3, even with transplant, the risk of relapse within the next 2 years is close to 60, 70%. And so they decided, let us try to give this oral TKI therapy, sorafenib, what was available at this time when they started the study in 2015. And they found that it was possible to deliver sorafenib, and that in those patients who got sorafenib versus those who did not get sorafenib, in this retrospective analysis from the EBMT and their registry, they found that the use of sorafenib was associated with a improved survival in a matched analysis. So based on this, it led to a prospective studies where we looked at sorafenib added as a maintenance, and there were 2 such studies. These started around 2015-16, soon after the study published by Dr. Bazarbashi and colleagues. One of them was done by Dr. Burkhardt and colleagues in Germany, published in the JCO, where they took frontline patients with a known FLT3 mutation at diagnosis who got their planned induction consolidation, whatever it may have been, and then went to allotransplant. And then after transplant, these patients were randomized to receive either sorafenib or placebo, with the primary endpoint of relapse-free survival and a key secondary endpoint of overall survival. Now, the study actually was planned to enroll close to 150 or 160 patients per my recollection and discussions with Dr. Burkhardt. But in fact, they had a hard time enrolling a lot of these patients because people were already starting to give sorafenib maintenance off trial, given the emerging data with FLT3 inhibitors being effective, sorafenib becoming more and more available. So it was hard for them to enroll patients because they did not want to go on the placebo. So because they had already enrolled 80 patients, they said, let us review the data. This will take many years to complete. And in fact, the data they had available was quite promising and showing that there was a clear improvement in RFS post-transplant. This is from the time of starting of the maintenance with sorafenib versus placebo. And you see clearly an improvement both for RFS and OS. And also good to see that the OS at 3 and 4 years in this patient population was close to 75-80% post-transplant. That is really quite good. You know, if you had asked me 5 or 6 years ago, post-transplant survival in a FLT3 mutated patient, even in first remission, I think we would have said 50-60%, but with maintenance, getting this close to 75-80% looks quite encouraging and promising. Now, what about tolerability? Sorafenib is a more difficult drug to tolerate, no doubt, compared to gilteritinib. And we do see adverse reactions with sorafenib. Most of these are in the form of infection or GI toxicity. We can see electrolyte abnormalities. And I will say that in most of our patients, when we start sorafenib, we usually start with a lower dose, 200 BID is what I've used. We usually try to start somewhere between day 45 and 90 to 100. And then we do the 200 BID for 1 or 2 months, assess the patient closely. They're getting weaned off their immunosuppression and other medications. And if they're tolerating it well, we may then slowly go up to 400, 200, and 400 BID. But I would say less than 30% of patients can tolerate 400 BID. So usually we are doing either 200 BID or 400, 200. And in this study, from my recollection, about half the patients got an effective dose of about 200 BID, and that still seemed to be clinically meaningful to improve the RFS and OS. So I think the key is to try to give the tolerable maintenance. We don't have to push the dose. It's better to give some sorafenib rather than pushing 400 BID, which may be toxic, but this drug can be delivered with good dose reduction optimization and can improve the relapse-free overall survival. Now, to further build the confidence here, there was actually a second study. This was done from China, very similar design, a little bit larger study, where they took 200 patients, randomized them to sorafenib versus observation here, no placebo, just observation, with a very similar endpoint, relapse-free survival and overall survival at 2 years. Again, showing actually almost exactly mirror image curves that without a maintenance, the survival at 3 and 4 years was about 60%. With maintenance, this increased to about 80% or so. This was seen both for overall survival and a cumulative incidence of relapse, with a 1-year relapse rate that was much lower, 7% versus 25%. That being said, there is a infection and GVHD profile, although interestingly, this was in this study not really higher with sorafenib as compared to the other study where there was slightly increased risk of infection GVHD. So both these studies support in the use of sorafenib. In fact, many in the US and in our group, actually, MD Anderson, we started using and conducting trials with sorafenib maintenance post-transplant. We've been doing those for about 5 years or so. But the big issue was always the tolerability with sorafenib, requiring dose adjustments, having hand-foot disease, having some GVHD flares, mucositis, appetite changes, and in some patients, 5 to 10%, in spite of dose optimization reduction, having to fully stop treatment. So we were always looking for potentially better second generation, well-tolerated, with less toxicity FLT3 inhibitors, and these started coming in around 2012 and 13 into phase 1 studies that we were very involved with. So these included gilteritinib and quizartinib. Both of these, as I mentioned, did show improvement in their initial phase 3 registration studies in relapsed AML, improving survival compared to salvage chemotherapy, and led to approval of gilteritinib worldwide, quizartinib in Japan, but although quizartinib now is also approved in the frontline setting through the frontline Quantum First study. So both these drugs now are available commercially in the US and will probably be available in other regions in the near future. So what are the data for maintenance with these drugs? Because we really have been more interested based on the safety and tolerability profile of these drugs as single agents in relapse and in combination frontline to maybe focus on these for maintenance. So there are now data from the Morpho phase 3 study. Quizartinib, also the Quantum First study, did include maintenance as a part of the study, although it was not statistically defined to be an independent endpoint or powered to show maintenance benefit. It was a part of the continuum of treatment, induction, consolidation, maintenance. And there's an ongoing study, no data yet, of crenolanib, which is another second generation FLT3 inhibitor in frontline combination, both intensive chemo and maintenance. So first looking at the Quantum First, so this has now been published in Lancet by Harry Erba and colleagues. This was a randomized phase 3 study looking at frontline quizartinib versus chemotherapy in newly diagnosed patients with acute myeloid leukemia. This is wrong. It shouldn't say salvage. It's quizartinib versus frontline chemo, actually. These are patients 18 to 75 years of age, no previous treatment, considered fit for intensive chemotherapy, primary endpoint overall survival. As you can see, median survival was improved, 31 versus 15. Primary endpoint was met with about a 11% absolute survival benefit. So this really looks to us as probably one of the best data sets for FLT3 inhibitor in frontline. And this is our frontline FLT3 inhibitor of choice today in newly diagnosed patients who are fit for intensive chemotherapy. Now here it's important to highlight that transplant still maintained a very independent, very significant impact. I get questions from colleagues in different parts of the US and other countries saying, oh, now you have these really good drugs, quizartinib, gilteritinib, they look very potent, response rates are good, molecular clearance. Can we start monitoring patients and not do transplant? My answer would be absolutely not. Yes, quizartinib, gilteritinib improve the response depth as well as the duration. But really, when you look at survival, especially at 3 and 5 years, it is clear that those who get the FLT3 inhibitor and the transplant are the ones who are really getting the best survival, as we would like to see, close to 75, 80%, as compared to those who do not go to transplant. Yes, there is a benefit of the FLT3 inhibitor, but the overall survival curves are much lower in general, less than 50%. So transplant is still very, very critical. Now, the good thing that's happening is a lot of focus on MRD across leukemia, and especially in FLT3 and NPM1, where we now have many large data sets published by the UK group, the German group, our group, others, showing that you can use these two markers as MRD, high sensitivity, predictive prognostic markers for outcome. This is from the Quantum First study, just looking at MRD in all patients, whether they got quizartinib or placebo with intensive chemo. And what's clearly shown is that MRD negative was better than MRD positive. The MRD used here was not flow. This was a FLT3 specific NGS MRD that had a sensitivity close to 10 raised to minus 5, although for publication, we use 10 raised to minus 4, which is considered by the FDA, NCCN, and ELN as a negative cutoff, but the sensitivity could actually go down to 10 raised to minus 5. Now, that was obvious, but it's good to show that MRD negativity improves survival across the board. What about in the setting of transplant? So this study allowed patients who went to transplant after getting quizartinib intensive chemotherapy to resume maintenance post-transplant. And what was seen is in the subset of patients who went to transplant were MRD negative pre-transplant with this FLT3 NGS, the addition of maintenance with quizartinib post-transplant did not seem to have any benefit. These patients were already in a deep remission. FLT3 was very low or cleared out, not detectable, and so there was no benefit. On the other hand, those who were MRD positive post-transplant, there seemed to be a benefit there of adding the FLT3 inhibitor quizartinib. So again, this was not the primary endpoint. The study was not statistically powered, but we're again getting very similar biological suggestion to what was seen with sorafenib, that maintenance post-transplant seems to improve it, but even more so, molecular detectable directed maintenance may be even more effective, allowing us to select patients most likely to benefit versus those who may not have as much benefit. So this then brought us to the phase 3 Morpho study. This is the study of gilteritinib versus placebo, the largest phase 3 study that has been done in the post-transplant maintenance setting and reported. And we saw this press release, and nowadays we get a lot of these data, and I think they're a little bit misleading sometimes here, showing that the study did not meet its primary endpoint, and we were all a little bit upset and depressed about that initially. But as we start seeing the data, I don't think that is giving you the full picture. So yes, if you look at all comers, 400 patients who had post-transplant maintenance versus placebo, the p-value is 0.051. This is basically 2 patients who can shift the curve. When you look at it as a survival curve, I think that you do see that there's a survival advantage for relapse-free survival. But I think that is not really the main question, or at least to me, the main information that was obtainable from this study. I think the main thing here is how can we select patients most likely to benefit from maintenance versus maybe avoiding maintenance, or whether we should even call it maintenance or MRD directed therapy in those who are not going to have a benefit. So the very nice thing about this study is probably the first study that was able to get a very consistent and high rate of molecular longitudinal data. And what they looked at was MRD, but the MRD here was very high sensitivity, 10 raised to minus 6 sensitivity, immediately pre-transplant or immediately post-transplant. And what they said is if you have any detectable MRD at any level, immediately pre or immediately post-transplant, then we will consider this patient as MRD positive and see what the impact of gilteritinib was in this specific group of patients. About 50% of patients in total, when you looked at pre and post-transplant, had some detectable MRD. Many of these are very low levels, as you see, MRD of 10 raised to minus 6, minus 5, minus 4, but still was detectable. And so when you look at these patients using a high sensitivity molecular FLT3 NGS and tease out those patients who are MRD negative, MRD positive, you start seeing already that in general, as expected, achieving MRD negativity was associated with improved survival, which is good. It's quite interesting to see here that the MRD positive curve actually does better than most other MRD positive curves we have seen in the past. I think part of this is because you're really now looking at a very, very low level of MRD. This is not flow MRD 10 raised to minus 3, minus 4. This is 10 raised to minus 6, minus 5. And even some of the MRD positive patients, I think transplant alone was sufficient, but still MRD negative, even at 10 raised to minus 6, predicted for an improved survival. Now, what I think is probably the most important message from this study is that in those patients who had MRD at any level on this specific FLT3 NGS assay, you can see that use of gilteritinib post-transplant clearly improved relapse-free survival, and as will be shown eventually in the paper, also the overall survival. So I think we should think of this more as molecular-directed MRD intervention rather than as a maintenance for all patients, blindly not knowing what their MRD status is. So very similar to what is being done in ALL, where we use MRD 10⁻⁶, -7 with high sensitivity clonoSEQ assays and then do intervention. So in our practice today at MD Anderson, we are starting to get these data, request the high sensitivity in vivo scribe MRD pre and post transplant. If we find any detectable level of FLT3, we are definitely adding the FLT3 inhibitor maintenance. For those who are negative, there's still a debate. Some people are worried that, are we getting the first pull? Are we getting as good quality? Should we still consider maintenance? I think that part is not sure, but for sure, I would do maintenance. Now, what about in those patients? Because I know in many regions, even the US, only about 10% of centers have access to this. So let's say you don't have access, or it takes a few years to get access. What should one do? My recommendation would still be to use maintenance, because when you look at these curves, what you can see is that with the gilteritinib in those who are MRD positive, you're getting the survival close to those who are MRD negative already. So yes, you may be over-treating some patients, but gilteritinib is quite a good, well-tolerated drug, not much severe toxicity. But at the end of the day, you're pulling the curve up for all patients close to the 75–80%. And I think until we have very good molecular tests globally available, my inclination would still be to use gilteritinib as a maintenance and then monitor those patients going forward. You know, there were some interesting things from the study about the geographical outcomes. Again, these are small subsets. The study was not powered for this, and we're still trying to tease this out. This may be differences in transplant practices, time to transplant, and other approaches. But overall, at least in the US, where we do think the NCCN will consider this strongly, there was a very clear benefit with the gilteritinib maintenance compared to the placebo. One of the big questions is, if you remember Dr. Chris Hourigan's data, was that using myeloablative conditioning may overcome the MRD positive situation. And that was something that we were saying, that if you're MRD positive, then you should consider myeloablative conditioning. If you're MRD negative, you may be okay with reduced intensity conditioning. That is not what was seen in this study. Again, this may be because we're now getting into very low levels of MRD 10⁻⁶, with a specific marker rather than FLOR-NGS. And here you see that in both MRD positive, MRD negative, the MAC had a better outcome than a RIC. So I think the suggestion would be, at least for FLT3, if you have the opportunity to produce with a myeloablative conditioning, that is probably the direction I would move for. Now, lastly, you know, all this being said, I think 6 years ago, 7 years ago, if you would have asked many of us what would be the approach and how maintenance would have worked, we would have thought it would have been a much clearer home run with maintenance. I think what we have learned now is that, yes, FLT3 is important, but it is not ubiquitous and it is not consistent throughout the course of the disease. So now there are multiple data sets coming out showing that close to 50% or even more patients who get intensive chemo with a FLT3 inhibitor, when they relapse, do not have a detectable FLT3. So it could be that there is a subset of patients where you completely wipe out the FLT3, adding a FLT3 inhibitor may not add much. Either you observe with surveillance or consider non-mutational specific maintenance, such as HMA, HMA-VEN, other things that Dr. Craddock, who has done a lot of work with, may discuss and is here in the meeting with us as well. So I think we're learning a lot about longitudinal molecular sequencing, not just for MRD, but also for molecular evolution and molecular loss. This is unique to AML. You don't see this problem in ALL, but I think this will be the way we will, at the right time, do the right intervention. So all in all, a lot of progress happened over the last 20 years. The FLT3 field is moving very, very rapidly. A number of incorporations have occurred, including use of higher dose daunorubicin, allotransplant in first remission. We consider this up to 75, 76 years for fit patients. Use of FLT3 inhibitors, initially the first generation, such as sorafenib, midostaurin, but probably better tolerated and effective with the second generation, like quizartinib. And then maintenance, in my opinion, is here to stay. Sorafenib already showed the data in 2 randomized phase 2 studies. Quizartinib in the subset analysis showed very similar improvement. And now with gilteritinib, again, using maintenance for all patients or in the future MRD-based intervention should help improve the outcomes. So with that, I will stop. Thank you very, very much for the opportunity to present, and happy to turn it back to the moderator here. Thank you.
Thank you, Professor David, for the excellent talk. And excellent review on the role of FLT3 inhibitors post-transplant. I would like just to ask the audience to post questions in the Q&A, as we will have a Q&A session after the second talk. The second speaker, it's my pleasure to introduce Professor Charles Craddock. He's a professor of hematology oncology at University of Warwick. He's the academic director of the Center for Clinical Hematology in University Hospitals, Birmingham in London. Professor Craddock will speak to us on MRD negativity, pre-allogenic stem cell transplantation in AML. Is it necessary? So the mic is yours, Professor Craddock.
Thank you. I hope you can hear me properly. And I just wanted to say, first of all, what a pleasure it is to join this meeting and also to follow the really insightful comments of my great colleague, Naval Daver, who I think, Naval, you're making some really profound points here around the further interpretation of morpho. And we may bring this up in our discussion, but I think the point you're making about clonal selection during intensive chemotherapy and how that applies to the selection of maintenance at diagnosis when you may be transplanting a different clone, I think is a profound and hitherto largely unexplored significance. So I'm going to move in the next 20 minutes to the important question about improving outcomes after transplant. And the fundamental question of, do we need to have patients transplanted in CR1 to be MRD negative? These are my disclosures. And it doesn't need me to remind you of the pivotal role that allogeneic stem cell transplantation now plays in the management of adults with acute myeloid leukemia. This is largely because it's become increasingly apparent, even to non-transplanters, that an allogeneic transplant is the most effective anti-tumor weapon that we've got, partly because of dose intensification, but also because the graft versus leukemia effect is so potent. At the same time, we have reduced intensity measures, we have better supportive care, and we have more donors available. So we can confidently think about taking the great majority of adults with high-risk acute myeloid leukemia who are fit, under 70, to a safe transplant so they can benefit from this curative potential. And I just want to remind you of this elegant piece of work by the HOVON group, where they looked at the relapse risk, so that's the bottom third of this graph, in patients in AML CR1 who had chemotherapy or a transplant. And suffice it to say, in this elegant piece of work, the risk of relapse is reduced by 67%. Hazard ratio for relapse is 0.33 in patients who go to transplant. So we must remember that this is a highly effective anti-tumor weapon. And interestingly, if you look at this, it applies across all biological subtypes. This is some other evidence just to remind you of the potency of the graft versus leukemia effect. This is work we did in Birmingham and Oxford, where we looked at the intensity of cyclosporine exposure in the first 21 days post-transplant. And you can see that the lower curve, that's the patients with the high levels of post-transplant immunosuppression, had a 40% reduction in outcome, and that was largely because of increased relapse. So that's confirming potent, manipulable graft versus leukemia effect, importantly in this population who had reduced intensity transplants. So when we're thinking about how do we reduce the risk of relapse, we have to be thoughtful about the factors in play. So disease biology is increasingly important, but so is disease status at transplant. Patients with refractory disease do much worse than those in CR. And as we'll talk about in a minute, certainly pre-transplant MRD status is a prognostic factor. We know that the risk of relapse with a reduced intensive conditioning regimen is lower than a myeloablative regimen. We know that how we taper immunosuppression matters. And finally, this really important question, which is at the heart of this talk, which is that in patients allografted for AML, retrospective data has really shown compelling evidence that the presence of pre-transplant MRD is associated with a much higher risk of relapse. In fact, the first data from Seattle suggested that your risk of relapse if you were pre-transplant MRD positive was just the same as if you had active disease. But the caveat here, of course, is that these are retrospective data sets, and there's potential selection bias. And it was very interesting that Dr. Dava referred to the fact that in the Morpho study, a prospective study, maybe it's because of different levels of MRD, but you saw much less impact of pre-transplant MRD on relapse risk. There was an impact, but it was much less important, apparently, than in this large retrospective data set from the US group led by Chris Horrigan. And again, another data set using NGS MRD in FLT3 mutated patients. Again, high risk of relapse, but retrospective data set, how real is it? So I think the first question we want to think about as a group now is, what can we do about the treatment we use to get people to transplant? Can we make it safer? Can we have a higher CR rate? And can we have a higher MRD negativity rate? And would that help patients? So I think conceptually, we're moving, and Dr. Dava and I have discussed this on a number of occasions, towards really rethinking the transplant as an integral, almost holistic package. And what you do in terms of getting people into remission matters profoundly, because if you have a higher CR rate, you have less toxicity from induction chemotherapy, or you have greater degrees of MRD negative CRs, then you plausibly will improve transplant outcomes. And the reason that's important is because outcomes in terms of toxicity in big registry data sets, this is the Swedish registry, do matter. And they are significant. So if you look at the day 60 treatment-related mortality in young patients with no comorbidities, they're modest, aren't they? They're 3 to 5% at day 60. But actually, once you start having patients with some significant comorbidities, or older patients, or patients with adverse karyotype, then the day 60 treatment-related mortality with something like FLAG-R, IDA, or even CPX can be as high as 10 to 15%. That's 10 or 15% of patients who aren't getting to transplant. And also that increased toxicity may contribute to transplant-related mortality. So the evidence that actually doing something in terms of adjusting your induction regimen might influence transplant outcome is very enticing. It's limited, but the strongest piece to my mind is the data from the Jeffrey Lancet randomized study of CPX versus DA in patients over 60 with secondary AML, where there was a survival advantage for CPX, but that was only observed in the patients who went to transplant. So some suggestion there that because the transplant-related mortality was lower in the people who had CPX induction, the overall outcome for that population was better. And that leads us to think about innovative induction regimens. And I really take my hat off to Naval Dava and his team for pioneering this concept of, say, rethinking what does induction look like. And the MD Anderson team have some very encouraging phase 1/2 data in a number of settings in this important area. The first was the phase 1/2 data in azacitidine, venetoclax, magrolimab. With that triplet, particularly in high-risk patients, we saw it was well tolerated, and we see, look at the frontline cohort, high CR rates, much better than you'd achieve with intensive chemotherapy, and certainly much less toxicity. So that's really provocative, and that's data that has led the UK group, with Naval's input and advice, to think about a randomized phase 2 study in patients with high-risk AML who are fit, who would be going to transplant as their curative strategy, about randomizing between DA or Vyxeos or FLAG-IDA and this magrolimab, venetoclax, azacitidine triplet. We're obviously waiting for a bit of updated data from ENHANCE-3, but I'm fairly confident this study will be able to start recruiting in Q1 next year. And I think it potentially is a real game changer in how we take patients with high-risk disease to transplant. Similarly, Farhad Ravandi and team have demonstrated that venetoclax, azacitidine, and gilteritinib is a highly effective induction strategy in adults. These are unfit adults, bear in mind, with FLT3 mutated AML. So look at the CR rates that are reported in this quite reasonably sized phase 1/2 study. 100% patients are achieving less than 5% blasts with very modest toxicity. And to speak to this important point, high rates of MRD negativity. So again, this needs to be confirmed in a randomized phase 2 study, and Dr. Dava and I are discussing that with European colleagues at the moment. So there is an opportunity for us to deal with the front end of a transplant so that we reduce relapse or improve transplant-related mortality. The next question, of course, is what impact might MRD have in terms of how we choose the conditioning regimen? And Naval's already referred to this data, but it comes from a pivotal transplant study. So I'm not ashamed to just reiterate the results of US CTN 0901, which essentially randomized 270 patients with AML or MDS to either a myeloablative regimen or a RIC regimen. I mean, interestingly, let's not forget the RIC regimen had clear benefits: lower non-relapse mortality, well, not surprising, but that was real, and less GVHD. But the challenge in this study was that there was a higher rate of relapse in the reduced intensity arm than the myeloablative arm, which translated into worse event-free survival and in longer-term follow-up, worse overall survival. Those data are relevant because, as Naval said, Chris Hourigan in a very nice study showed that this interplays with MRD importantly. So if you were MRD positive pre-transplant and you had a reduced intensity allograft, and that's this bottom line here, the lilac, the dotted lilac, your outcome, but particularly your relapse rate, was much higher than if you had a myeloablative allograft. So I think this is important data because, exactly as Dr. Dava said, it's suggesting that if you're MRD positive, you should, if you can, go to a myeloablative transplant. There are caveats about this study. The observed rate of relapse in the RIC arm was really very high. It was 50%. That's higher than any other randomized study. And the observed rate with the myeloablative arm was much lower. So, you know, a bit of a health warning about some of these data, important as they are. That's all very well for people who are fit enough to tolerate a myeloablative regimen, but what about if you're not fit enough? That's most adults over 55. So in the UK, we looked at intensification of the RIC regimen using the sequential Flamza regimen, where you have an extra block of 5 days, cytosine, arabinoside, and amoxicillin. So we randomized 242 patients in this study, and importantly, Sylvie Freeman in our group did pre-transplant MRD by flow, but prospectively, she examined its impact on transplant outcomes. So let me share that data with you. There was no benefit in this large population with a median age of 58 of intensification of the RIC regimen. No benefit in people who are pre-transplant MRD positive, no benefit in adverse cytogenetics. So we, I think we're disappointed by these data, but we've stopped using this regimen. And importantly, Sylvie was able to replicate the retrospective studies showing that if you are pre-transplant MRD positive, this is the red line, your relapse incidence is higher than if you're MRD negative pre-transplant. But look at the data. It didn't have as striking an effect as reported in retrospective studies. Certainly, the relapse rate is doubled from 20% to 40%, but in the MRD positive pre-transplant patients, they still do quite well in terms of 2-year overall survival. We still are very interested as a group in the UK in exploring other conditioning regimens in the hope that we can find an optimal regimen, particularly for MRD positive older patients. And we've just closed out this study with 280 patients randomized to a thiotepar fludarabine busulfan regimen, either in myeloablative form or reduced intensity form. And I hope we'll have those results by next summer. And then finally, I just wanted to draw your attention to the other provocative data in people who are pre-transplant MRD positive, which is that alternative donor stem cell sources may be valuable. This is the Seattle data showing that if you are MRD positive pre-transplant CR1, your relapse risk with a cord, it was in this study much lower than with a sibling or unrelated donor. And interestingly, Rob Wynn, who's a superb pediatric transplanter in Manchester, has found almost identical data showing that in high-risk MRD positive children with AML and CR1, they do much better with a cord. So he's planning with French colleagues a randomized study of expanded cords using the Exelthera product versus any alternative stem cell source. And I think we should keep our mind open to the fact that in certain populations of high-risk AML, cord may be quite a useful stem cell source. And then finally, I just wanted to, I'm going to be very quick on this because Naval's presented it so nicely. Think about using post-transplant pharmacological maintenance to buy time for this very powerful graft versus leukemia effect. As Naval has said, there is data from using sorafenib in two modest randomized studies of benefit, but the data we were waiting for, I think, is from Morpho. And I'm not going to go through this again, but I just want to emphasize what Naval said, which is that in the MRD positive population, there's a clear benefit from gilteritinib maintenance, and I think that's now the standard of care. So finally, in the setting of maintenance, particularly in patients who are MRD positive with a high relapse risk, what about if you're not FLT3 mutated? Well, azacitidine upregulates expression of cryptically silenced, epigenetically silenced and tumor antigens. So this study, Amadeus, in which patients received a year's CC486 maintenance, closed out early this year. And again, we hope we'll have results next year. And then finally, I just kind of want to remind you that it's not just pre-transplant MRD that's important, it's post-transplant MRD. And in this very nice study from the Figaro data set, we found that actually the most important prognostic indicator in both patients who are pre-transplant MRD positive and post-transplant and pre-transplant MRD negative, the presence of post-transplant MRD detected in the first 50 days is a very important, it's the most important predictor of relapse. And I think as a transplant community, we need to think about assessing MRD earlier in these patients, because if they are MRD positive, you can taper immunosuppression. So finally, to keep the time, I want to just remind you that in fit adults who are under 55, particularly those who are MRD positive, you should go to a myeloablative regimen. The patients who are MRD positive but can't tolerate a MAC can still do quite well with the transplant. We should press ahead. There's no evidence that further intervention before they go to transplant is a benefit, and patients may lose that curative opportunity. And so conclusively, I think there's no evidence that transplant should be deferred unless there are exceptional circumstances in patients who are MRD positive. Get on, do the transplant, and think about manipulating what happens post-transplant, whether that's gilteritinib maintenance, whether that's an early taper of immunosuppression, whether that's prophylactic DLI. And then finally, we need to be thoughtful, I think, as our main way of improving transplant outcome in a mutation agnostic way of thinking about strategies that optimize the GVL effect. And I put a couple down there and discussed them already at high level. But lastly, let's be sure as a community that we're delivering these randomized prospective studies that can be so insightful, particularly when there's embedded genomic data. So thank you for your attention. I'm very happy to take any questions.
Thank you so much, Professor Prado, for the excellent talk. So we'll open the Q&A session. I'll start with a question until we have the audience with us. So there is one question from the audience. In MD Anderson, you're adopting a triplet regimen. This is a question for Professor Daber. Venetoclax, azacitidine, gilteritinib. How often do you face cytopenia and how do you deal with it? What's the tolerability? what's the best patient profile who can benefit from this regimen, and the dosage proposal. How do you start and how do you escalate dosing?
Yeah, it's a great question. And, I think as with any combination, when you're adding a new drug, there is added myelosuppression. So this is something we've been working on now for about 3 years, as Dr. Craddock mentioned. And initially, because of the way of the label of venetoclax, we were doing 21 days to 28 days of venetoclax, which I think even in the doublet is proving to be myelosuppressive. And in the triplet with gilt added was definitely myelosuppressive. So over time, we've been amending the protocol, and we've now come down to 14 days, 4 days of venetoclax and 14 days of gilteritinib, which we actually stop both of them on day 14 with the day 14 marrow. And what was really interesting to see is that on day 14, we actually saw pretty much all the patients had either marrow remission or aplasia or ablation. So with 14 days of both drugs, we're actually seeing very good tolerability. The count recovery, we showed at ASH and will be in the paper, is now about 34, 35 days, which is actually almost exactly the count recovery with Aza-Ven. So we're actually not seeing added myelosuppression once we have optimized the dosing. So I think that is the key with these combinations as we move forward. I mean, this is inevitable. We are going to be having to combine drugs, optimize them. And the way is you have to adjust the dosing. But yeah, I think this is the regimen as was mentioned by Dr. Craddock. We are looking at this in a larger phase 2 dose optimization with the FDA, the Project Optimus approach, and then also in a randomized study. I think the second part of the question, and I'll start and turn it over to Dr. Craddock for his thoughts, is, what is the right population? I think that's a great question. So right now, we're in the label setting because from a regulatory perspective and from a drug development, that is probably the most obvious path. So we're doing in patients above 70, 70 to 75, 80, who are not considered good candidates for intensive chemo to improve on HMA-Ven. And we're showing that. But with the data emerging with the response rates of 95%, CR, good count recovery, good tolerability, survival looking good at 1.5 to 2 year follow-up, the question is, why should we be putting our 60-year-old or 65-year-old or 55-year-old through intensive chemo if our goal is to get a good remission and move to transplant? I think that is the next step, is to move into the younger population, fitter population, to a randomized study of HMA-Ven FLT3, whether it's GILT or QUIZ, versus intensive chemo FLT3. But would love to get Dr. Craddock's thoughts on that as well.
Well, if you want, thanks, Naval. And again, I really take my hat off to the pioneering work of your group. I think you're changing the practice. You're changing AML practice worldwide. And if I look at this from a bit of a distance, I think certainly you're right that we wish now to look at a randomized study, in my judgment, in patients 50, 55 with FLT3 mutated AML. These patients are going to go to transplant. There's every chance that we're doing them harm with current induction strategies in terms of subsequent transplant outcome. I think it'd be really interesting, Naval, to pick through some of that morpho data, because I think there may be some stuff in there that we're not aware of. But also the other point is from a patient's perspective. We've just done some work in the UK. We're putting in a grant around supportive care in AML. And we put together a patient group of about 15 patients who get treated. And all too often, we don't listen to the patient voice. But patients are not talking about CR rates or MRD negativity rates. They're talking about being stuck in hospital. They're talking about infection. They're talking about nutrition. They're talking about total sense of wipeout and fatigue. And the regimens you're talking about are a potential complete game changer in terms of how we manage this population of patients. So I know you are pursuing this actively, but I would be really keen from a UK perspective that we join you in defining a population of older allomandatory FLT3 mutated patients where we immediately go to a randomized study. I think we've got all the evidence. And I think we should also be ambitious that in 5 years' time, the standard of care in FLT3 mutated adults could completely change. Because even if the CR rates are equivalent, and they're probably not, they're probably better with your triplet, but even if they're equivalent, the transplant-related mortality will be less, the transplant outcome will be better, but also patients' experience will be transformed. They'll spend most of their time at home with their families. So I think it's tremendous you're taking this forward at pace. And I think this, if I was to put a bet on it, will be the game changer in terms of how we manage FLT3 mutated disease in 10 years' time. In all ages.
Thanks. Dr. Zaid Al-Zahrani has a question.
Are you hearing me?
Yes, yes.
Okay, great. So I have two questions for Professor Naval Daver. The first one, maybe I did not get it through your talk. Now we have the Morpho trial, which is showing that, you know, there is, with the use of the PCR NGS FLT3 before the transplant, did not show any survival benefit. And also for the Quantum First, which is did not, with the use of the same PCR NGS, although the maintenance was not, the study did not power to answer this question. If we have this testing now in the community, would you say, can we stop doing the maintenance for FLT3 positive, for FLT3 negative patient pre and post? This is the first question. The second question, now we have now at least two available medication that it is approved for frontline therapy for FLT3 positive, like we have midostaurin, we have quizartinib, and the gilteritinib is coming in the way that there are two phase 3 trial, the BRECOG and the HOVEN trial, which is, you know, has been in the phase 3 trial. Who is the winner? Because, you know, we have this plenty of this medication upfront. So what do you think the winner for those upfront setting?
Yeah, so it's a great question. I can start with, so the Morpho, right? And I think this is really, really nuanced as to when we would not do maintenance. And I think there's an academic answer and there's a practical answer, right? So the academic answer is, yes, if you replicate the Morpho, meaning they send the first pull, that is very important. We usually don't do that in MRD in general, even Anderson. So that's a practice change. So if you're sending the first pull and you're getting the 10⁻⁻⁶, really sensitive PCR MRD, because if it's 10⁻⁻⁴ or 3, it's not going to work. You're going to miss 35% that were below that. But if you can get that and it's truly negative, then I think, yes, the study suggested that maintenance would not help and one could consider not doing it. Now, the practical aspect of that is, in reality, most of the people, including me and most of the experts in the US, are not getting that 10⁻⁻⁶ routinely. We're starting to get it. And also, we're not absolutely sure we're replicating the conditions of that study. So I would say in most situations, people are erring towards the side of giving the maintenance. And I think that's partly because gilteritinib is such a well-tolerated drug. I think if it was a more difficult drug with more toxicity, more severe adverse events, this may be more discussion. So I would say for now, probably we are giving maintenance and we're using gilteritinib to majority of people. With the next year or two, if we can replicate and get this high sensitivity PCR and look at similar data, it will come from our centers and others, then we may say, okay, we really are now confident we can avoid maintenance. I don't think we're that confident yet about the avoiding maintenance part. The second question, you know, frontline, which is the best, you know, we're not going to have randomized data between quizartinib and midostaurin. It's never going to happen. And as Charlie was saying, it's not really a question that I want to spend 5 years answering. We have more important questions that to answer. If you look at the data and try to match, you know, there's differences in the two studies. The midostaurin study only went up to 60 years of age. Quizartinib allowed up to 75, and almost half the patients were between 60 and 75. So it was a much more difficult population. So when you look at the below 60 population of Quantum First to the midostaurin study, which was all below 60, you start seeing differences. The 5-year survival is about 60% versus 50%. So that makes us feel, and also all the history of the drug. Quizartinib is a specific FLT3 inhibitor. It was made to target FLT3, whereas midostaurin is multi-kinase. It was made for brain tumor, had some activity in FLT3, and also tolerability-wise, in our experience with quizartinib, we've used it a lot in the last 7-8 years from the phase 1, 2, 3 studies. It does not cause GI issues. Patients like it. I think what Charlie was mentioning about patient experience is critical with midostaurin. Many of my patients do not like the taste, the smell. They want to come off it. So all that being said, today we are moving with quizartinib. I think that's a great question. What will happen with gilteritinib? If gilteritinib beats mido with intensive chemo, I mean, that is the gold standard. I think that will become the highest bar, and then we would have to say gilteritinib is the best. If it does not, which I have to say I am nervous, that's a very ambitious study when you look at the gilteritinib intensive chemo data, then we will have to see. For now, I would use quizartinib has been our approach at Anderson, and I think most experts in the US are moving that way. But yeah, any thoughts on that, Charlie?
Well, broadly in agreement, but and we'd be going towards quiz, but I think the other point you made in your presentation, 2 points, Naval, that were really interesting, was that the prospective data set about the impact of pre-transplant MRD is different from the retrospective data set. Nobody's talking about that, but that's important. And the second point is you were talking about this clonal selection phenomenon, and that quite often patients who are transplanted having presented with FLT3 mutated disease, FLT3 negative at time of transplant. So I think there's a lot more work to be done on that data set to understand which are the patients who genuinely benefit from gilteritinib maintenance. Because very plausibly, there's a whole bunch of people going into transplant who didn't have FLT3 mutated disease.
Yep.
Those are my comments.
Can I have another question?
Go ahead, Dr. Zaid.
For Professor Craddock, we know those patients with complex cytogenetics, especially with TP53 mutations, we didn't have any really good drug now to overcome this TB, especially I'm talking about TP53 mutations. So I think the treatment is just to go ahead with transplant. You should not wait for another to deepen the remission. You just go ahead with the transplant. However, for those patients, like they have targetable agent, like FLT3, IDH1, IDH2, would you consider give them a chance to deepen the remission for those patients who have targetable agent before taking them to transplant?
No, thank you. A really great question. My view is you get these people to transplant as quickly as possible. Interestingly, there's a couple of studies now showing in complex high-risk disease that MRD is less important as a marker. And the danger, of course, is if you're trying to manipulate MRD, you lose the opportunity to proceed to transplant. What should be happening is that physicians treating AML and transplanters should be working in an integrated manner. And the focus should be, once you've got the patient into transplant, in doing everything you can in these high-risk patients, first of all, to do post-transplant MRD early, and in the high-risk patients coming in with interventions that we know have activity like DLI and certainly an immunosuppression taper. And the result of the UK pro-DLI study, which is looking at randomized prophylactic DLI in this setting, is awaited, and we should have that available next year. Good question, but get on and do the transplant.
Thank you. Dr. Ibrahim, we have a question here.
Hello, thank you. Very, very interesting session. Thank you. I'm from pediatric ward, so my question is that, is there an agreement between the adult treating young adult in terms of induction chemotherapy or induction combination? So is there a standard protocol right now, or what is the field for this? Let us talk about those who are young adult.
Okay, well, perhaps I'll just have a quick go at that. I think it's an easier scenario because your question, of course, is nuanced. Are these allomandatory patients, or are they patients who should just receive intensive chemotherapy? But the reason why I think it's an easier question is that the predicted toxicity of induction chemotherapy in young adults is really modest. I mean, there is this real question about late effects, and we shouldn't ignore that. But my sense is that the rationale for the use of DA on its own is gradually dissolving, and that the treatment approach is more and more nuanced according to the underlying disease biology. So Naval's talked very nicely about FLT3 mutated. We know that in patients with secondary characteristics, CPX is important. And there's also some quite interesting data coming out in 821 about, the importance of GEO, and actually from MD Anderson, a flag GEO combination. And then finally, I just draw your attention to some UK data that shows in NPM1 positive patients there may be good outcomes using FLAG-IDA rather than anything else. So I think we're going towards a more molecularly stratified approach, and that there can be coherence really about what we do. The challenge, of course, is in older patients where you're really just wanting to get them to transplant and you're really worried about intensive regimens. But Naval, your thoughts?
Yeah, I totally agree. I mean, I think the one thing in the really young, you know, when we're talking about, I'm guessing 20-year-old or 15-year-old is in line with what the UK has done and the Polish have done. We do believe the addition of purine analogs can be quite important here. So a FLAG-IDA or a CLIA type of regimen is what we have preferred for these really young patients. As Charlie mentioned, the toxicity is not that cumulative in these really young patients. For a 50-year-old, it may be. And of course, you know, just drawing your attention to the FLAG-IDA CLIA-VEN for a really young patient, we have these. We work with our pediatrician. For a 20-year-old, that would be kind of a regimen I would really like to go for if they don't have a FLT3. But if they have a FLT3, then intensive chemo with quiz is a good option. If they have a core binding factor, then a FLAG-GO sort of approach. Both our group and the British have shown this as very, very effective. And then if they don't have either of those, then I think a FLAG-IDA or CLIA-VEN, and all of these except core binding, we would go for transplant. But yeah, I think a very intensive approach for these really young is still the way we are going for high cure rate.
Thank you very much.
Excellent. Thank you so much. And with that, I would like to close this session. Thanks for the excellent talks from Dr. Daver and Dr. Craddock, and the interaction from the audience and the discussion. We'll now move to the closing remarks by Dr. Ibrahim. Thank you.
Thank you.
Thank you for your presence and attendance. I would like to extend my thanks to the organizers. The effort of every single body spent time on this. It has been an effort, a deep effort from everybody actually to get this out. I have learned a great deal during this last 2 days. I think knowledge is really important and do save lives. So I would like to also thank our sponsors generally and for their contribution, and also to stress that without their support, we would not be able to do this conference. We'll see you, inshallah, next year around this time, and hoping to attract more attendance. Thank you very much, physical. Thank you.